Let's look at the warm-up for GI1. First question, what are the functions of interleukins 1 through 5? So remember the mnemonic hot T-bone steak. IL-1 causes fever. IL-2 is the T in T-bone, so IL-2 is a T-cell stimulator. The bone in T-bone is to remind you that IL-3 stimulates bone marrow. And then for steak, the E and the A are capitalized. So the E reminds you that IL-4 enhances the production of IgE and also IgG. And then IL-5 increases production of IgA and also eosinophils. Next, after taking a course of amoxicillin, an adult patient develops toxic megacolon and diarrhea. What's the mechanism of diarrhea? So the amoxicillin disrupted this patient's normal bacterial flora. And now Clostridium difficile is overgrowing in the colon. So this is C. diff colitis or pseudomembranous colitis. So that's it for the warm-up. Now let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on the oral pharynx. Today I'm going to share Dr. Lewis's guide to mucus evacuation. Now many of you probably suffer from the occasional problem of nasal congestion, but are you familiar with the various techniques that one can use to evacuate this excess amount of nasal mucus? Now some prefer the traditional tissue and blow, others prefer to blow in the shower where you kind of end up doing the snot fling afterwards. Now some take this business very seriously and designate a finger in which the nail is grown out slightly and then that finger becomes the official booger picker. And then my favorite is the dangerous one nostril projectile snot rocket. Beware of this one, it can certainly backfire, requiring you to afterwards to lie to your friends and tell them that, yeah, that's just toothpaste on your shirt. Alright, so today we're talking about the oral pharynx, and this is going to actually feel a little bit more like an ENT video than a GI video. We're going to cover the tongue, the throat, salivary glands, the sinuses, that type of stuff. So let's get going. So first let's talk about the tongue, and we're talking more specifically about tongue development. So what should you know about this? How does it develop? Well, the tongue gets divided into the anterior 2/3 and the posterior 1/3. Now, the anterior 2/3 is derived from the first and a little bit of the second branchial arches. Now, sensation will be from the third branch of the trigeminal nerve, so cranial nerve V3 or 5-3-3. So that's that mandibular portion of that nerve. Now, taste will come from the facial nerve, cranial nerve 7. Now let's talk about that posterior part. So the posterior 1/3 is derived from the branchial arches 3 and 4. Sensation here is from the glossopharyngeal nerve, so cranial nerve 9, and taste is also mostly going to be cranial nerve 9, but at the very back of the tongue, there's some taste that comes from the vagus nerve, so cranial nerve 10. Motor function for the entire tongue, so this goes for anterior and posterior, is through the hypoglossal nerve, cranial nerve 12. All right, so because Step 1 loves tongue questions, let's go over this again in the Lewis Notes. All right, hello everyone, we're doing another Lewis Notes and we're doing the tongue today. So I've drawn a picture here of Dr. McGinnis and looks like he's having a stroke and got punched in the face. But we're gonna take his tongue and go through the origins, the taste, and the sensation and motor of these areas. Very important stuff. For some reason, this is really high yield on your test. So let's pay close attention here. Let's start with the anterior 2/3 of the tongue. So what is our origin here? So remember our origin was the first and second, primarily first, but second does play a part there in the arches. So remember that. For the taste, it's going to be the facial nerve. So you're going to see cranial nerve 7 as being your primary taste for the anterior. For the sensation, remember it's the trigeminal nerve, but it's going to be that V3, so cranial nerve V3, and that's the mandibular branch of that trigeminal nerve. And for motor, we have cranial nerve 12. So cranial nerve 12 is our primary motor, and we'll talk about this later. It's actually for the whole tongue, so that's the hypoglossal nerve. All right, so now let's move on to the posterior 1/3, and remember this is going to be on the origin, the third and fourth arches, so third and fourth arches on that one. For the taste, we have cranial nerve 9. So cranial nerve 9 is our primary taste on this one. That's the glossopharyngeal nerve. And actually sensation is the same thing as well, so that makes it easier to remember. So cranial nerve 9 is also going to be our sensation. And then motor, as I said before, is going to be the same as our anterior, so cranial nerve 12. Now the only other thing we need to look at is if I have this other green area over here for the very back of the tongue. So we actually get a little bit of vagus nerve, cranial nerve 10, providing a little bit of taste at the very back of the tongue. All right, guys, so those are the major things you need to know about the origins, the taste, the sensation, and that motor function of the tongue. All right, so now let's move on to some tongue pathology, and we're just going to get the highlights of these things. So first is glossitis. So this is inflammation of the tongue. Now this might look kind of beefy red on a picture. You might actually see smoothing of the tongue where you lose the surface features of the tongue. Now it's caused by most of the vitamin B deficiency. So think of B12, riboflavin, niacin, pyridoxine. Iron deficiency can also lead to glossitis as well. Next, we have leukoplakia. So these are areas of keratosis that appear on the mucous membranes. Now, this can be confused with oral candidiasis and lichen planus as well. Now, the cause is unknown, but we do see this more often in patients who smoke. Now, don't get this confused with oral hairy leukoplakia, which is a white patch on the side of the tongue with kind of maybe, if you imagine, a kind of a hairy appearance. That one is caused by Epstein-Barr viruses and usually occur in patients who are immunocompromised, like HIV. Next, we have oral thrush, another type of white spot on the tongue or the mucosa, and this is going to be caused by the Candida albicans. Now, this is seen in infants very, very commonly, but also seen in immunocompromised patients. And then we have our good old-fashioned oral herpes, so cold sores due to HSV1, sometimes still HSV2 can cause oral herpes as well. And then we have the aphthous ulcer, also referred to as the canker sore. So this is a very painful mouth ulcer. The exact cause is unknown, but things like physical trauma like biting the tongue, citrus fruits, stress, food allergies, B12 deficiency are also known associations as well. You can also see this in Behçet disease and Crohn's disease as well. All right, so let's now move on to the salivary glands. So what are all the different salivary glands? Well, there's the parotid gland, the submandibular gland, and the sublingual gland. Now, the sublingual secretes the most mucinous, the very thick secretions. The parotid gland is going to secrete those more watery, more serous secretions. Now, one of the functions of the saliva is that it contains alpha amylase, which begins starch digestion. Now, the digestion of starch actually begins in your mouth, so it's important. Bicarbonate is also in salivary secretions. There are mucins, which help lubricate the food, and antibacterial secretory products as well, like IgA and growth factors also that are going to promote epithelial renewal. So saliva is actually very good for the health of your mouth, your teeth, and your gums. Now, salivary secretion is stimulated by both sympathetic and parasympathetic activity. With sympathetic stimulation, you're going to get the very thick secretions, which is why when you see public speakers speaking, they're taking a lot of drinks of water. They're trying to get rid of that kind of extra thick secretions and that dryness. Watery secretions can be associated with the parasympathetic stimulation. So when you eat, you're in the actual rest and digest stage, and you'll need a lot of saliva to be able to digest, get all that food down. So the sympathetic stimulation is by way of the superior cervical ganglion. The parasympathetic innervation to the salivary glands in general is by the facial nerve and the glossopharyngeal nerve. Now, this is also an important point that cranial nerve 7, the facial nerve, actually runs through the parotid gland and can be damaged during surgery to the parotid gland. All right, so now let's move on to some salivary gland pathology. Again, we're just hitting the high points here. First, we have xerostomia. So this is severe drying of the mouth. The syndrome you should know that can cause this is Sjogren's syndrome. You also get dry eyes with Sjogren's as well. Medications can also cause drying of the mouth and tongue, things like antihistamines, anticholinergic drugs as well. Next, we have sialolithiasis. So this is stones or blockage of the salivary gland duct, preventing release of saliva. Now, the clinical features include acute pain and swelling in the submandibular gland, or the Stinson duct of the parotid gland is a common anatomical site you should know. Treatment is a bit unusual. In order to dislodge the stone or sludge in the duct, you can actually have the patient suck on some sour candy or have them chew gum. That increases that saliva stimulation, and it can actually unclog the duct. Sometimes surgery is still needed to remove big stones. Then we have sialadenitis. So this is inflammation of the salivary gland. Sialolithiasis, a blockage, can actually lead to this. It can be caused by bacteria. Staph aureus and viridin strep are the most common bacterial pathogens that you need to remember there. Now let's move on to the tumors of the salivary glands. So most tumors of the salivary glands are benign, and most occur in the parotid gland. Now the most common tumor overall is the pleomorphic adenoma. It has both epithelial and mesenchymal cells, thus the name pleomorphic. Now there is an increased risk with radiation exposure, but it's a benign, it can be recurring, and again, it's that mixed cell tumor of the parotid gland. Now it can lead to facial nerve injury, that's one pathology, and it is more common in women ages 20 to 40 years of age. Now, the second most common benign tumor is the Warthin tumor, again, benign. Now, let's move on to something malignant. Now, the most common malignant tumor is the mucoepidermoid carcinoma. Now, it is the second most common overall and the most common malignant. Now, one clue that a tumor might be malignant or benign is its location. So if it's located in the parotid gland, there's less than a 30% chance that it's going to be malignant. If it's located in the sublingual gland, there is at least a 70% chance that it's going to be malignant. All other glands kind of fall somewhere between those two. All right, so now let's switch gears again and go on to cleft lip and cleft palate. So cleft lip is a congenital deformity that's caused by the failure of the maxillary and the medial nasal processes to fuse. A cleft palate is failure of the lateral palatine processes, the nasal septum, and the median palatine process to fuse. Now, both of these can occur separately or they can be found together. Now, a cleft palate can actually lead to some serious problems with feeding. Babies with cleft palates are unable to produce enough suction to actually feed. So these babies actually get to feed with these kind of specially made, very long nipples that the babies can then kind of move to the very back of their throat and actually press their tongue against it to express milk or formula. Now, there are many factors and causes that lead to cleft lip and palate, many genetic syndromes as well. We're not going to go through all those here. Toxins can cause it. And then always remember that folate deficiency can lead to a cleft lip and cleft palate. All right, so now we're moving on to the nose. So first we're talking about rhinitis. So rhinitis is irritation, inflammation of the mucous membranes inside of the nose. Patients complain of congestion, rhinorrhea is what is runny nose, and that post-nasal drip. Now, what if it gets infectious? So infectious rhinitis. So this is the common cold. I'm sure you've all experienced this yourselves. What are the most common pathogens? Viruses by far. Things like coronavirus, rhinovirus, adenovirus, echovirus. Those are the big ones. Allergic rhinitis, another very common thing. Here we have, again, similar symptoms with infectious rhinitis, things like rhinorrhea, congestion, even a cough. But here there's no infectious agent, but it's triggered by airborne allergies, pollen, dander, those types of things. A large percentage of the population complains of that intermittent allergic rhinitis symptoms. Intranasal steroids can be used to help this, along with antihistamines and other things as well. Nasal polyps. So these are overgrowths of the mucosa that frequently accompany allergic rhinitis. They are usually movable, but they can cause severe nasal congestion and obstruction. Just like allergic rhinitis, you can use intranasal steroids to help treat these. You can also have a surgeon go in and cut those things out. And let's talk about cocaine. You might actually get a question about the pathologic effects of cocaine on the nose. Cocaine is a potent vasoconstrictor. Therefore, excessive use of cocaine can actually lead to ischemia that can then sometimes lead to perforation of the nasal mucosa. And next we have eustachian tube dysfunction. Eustachian tube is actually the thing that connects the middle ear to the pharynx. Now, this tube can be blocked up with mucus, inflammation. Again, you can use intranasal steroids to help treat this. All right, now we're moving on to the sinuses, so the paranasal sinuses. You should be able to recognize the different sinuses here. The four sinuses are the sphenoid, the frontal, the ethmoid, and then the big ones, the maxillary sinuses. Be sure to know those. So if there is allergic or infectious rhinitis for an extended period of time, then a patient might develop acute bacterial sinusitis, so infection of the sinuses. If you have snot and mucus kind of stagnating in an area for too long, then it tends to get infected with bacteria. Now, this is probably overdiagnosed in the outpatient setting. Actual sinusitis is accompanied with facial pain, fever, purulent nasal discharge, much sicker than what we usually see. Many patients just present with nasal congestion and they assume that they have a bacterial sinus, and it's just really congestion, not necessarily infection that they have. Moving a little bit further back, the tonsils and the adenoids. So if infected, patients will complain of pain with swallowing. Now, which bacteria is commonly associated with tonsillitis? That's going to be Streptococcus pyogenes. And almost every day I have to swab someone's throat in the clinic to help diagnose this. Now, if a patient has multiple bouts of strep throat, then they may have their tonsils and or adenoids removed. Now, sometimes patients will have extremely large tonsils that can actually lead to obstruction, which can lead to obstructive sleep apnea, and that would be another indication for the removal of those tonsils. All right, guys, that's it for the video part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what is the most common location of salivary gland tumors? So that's going to be the parotid gland. Next, what is the most common salivary gland tumor? And that's going to be that pleomorphic adenoma, which is a benign tumor. And then what is the histological appearance of that tumor? So remember, pleomorphic, think of multiple things. Name implies there's a variability in the shape and size of those cells. So it has epithelial and mesenchymal types of cells in there. About 50% of salivary gland tumors are these pleomorphic adenomas. Next, what is the second most common benign salivary gland tumor? So this is the Warthin tumor. So this is a benign cystic tumor where you have a double layer of columnar epithelium around the cyst, and then the stroma of the tumor is lymphoid. It kind of looks like a lymph node, and it can even form germinal centers with its lymphoid tissue. Next, what is the most common malignant salivary gland tumor? And we put in parentheses here the second most common tumor overall of the salivary gland. So this is the mucoepidermoid carcinoma. So this is the most common malignant tumor, second most common overall salivary gland tumor behind the pleomorphic adenoma. And the last question here, what medication is often used in the treatment of allergic rhinitis, nasal polyps, and eustachian tube dysfunction? Remember, it's those intranasal steroids. So steroid nasal sprays, fluticasone, triamcinolone, budesonide. There are a bunch of these, and a lot of them are even over the counter now. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the warm-up review. First question. On which type of immune cell is each of the following cell surface proteins found? So CD4 is found on helper T cells, CD14 is found on macrophages, CD16 is found on natural killer cells, and also neutrophils, monocytes, and macrophages. But I mainly want you to remember the NK cells. CD19 is found on B cells. Remember, B cells have CD19, 20, and 21. CD3 is found on all T cells, and then CD8 is found on cytotoxic T cells. And the last question. A child with an immune disorder has recurrent staph abscesses. It's found that the neutrophils fail to respond because the chemotactic stimuli are deficient. So what's the most likely diagnosis? This could either be leukocyte adhesion deficiency or hyperimmunoglobulin E syndrome, also known as Job syndrome, in which interferon gamma levels are low. So now you're all warmed up for the lecture.
Hello everybody, and welcome to our Step 1 video on the esophagus. Try to say esophagus really fast 10 times. I bet you can't. So this lecture is going to primarily deal with the esophagus and the pathologies associated with the esophagus. First, we're going to spend some time to go over some embryology regarding the esophagus, anatomy, and a bit of pathology of the entire GI tract. Then we'll focus our attention on the esophagus. The gut is broken down into 3 sections: the foregut, the midgut, and the hindgut. The foregut includes the esophagus, stomach, first and second part of the duodenum, liver, gallbladder, and the pancreas. The blood supply is from the celiac trunk, and the innervation is primarily from the vagus nerve, which provides all the parasympathetic, but you also get sympathetic innervations from the splenic nerve. The midgut includes the third and fourth parts of the duodenum, jejunum, ileum, appendix, and the proximal 2/3 of the colon up to the splenic flexure. The midgut gets its blood supply from the superior mesenteric artery, and just like the foregut, it's primarily innervated by the parasympathetic vagus nerve and the sympathetic splenic nerves. The hindgut includes the distal 1/3 of the colon, including the sigmoid colon, the descending colon, and the rectum to the pectinate line. It is supplied by the inferior mesenteric artery. Parasympathetic innervation is again by the pelvic splenic nerve, and sympathetic innervation is through the lumbar splenic nerve. So let's review the blood supply to the lower GI tract going from the foregut to hindgut, proximal to distal. It is the celiac trunk, superior mesenteric artery, and the inferior mesenteric artery. Also, let's review the innervation of the GI tract, again proximal to distal. The parasympathetic innervation is primarily by way of the vagus nerve all the way to the hindgut, which starts at the junction of the transverse colon and the descending colon, called the splenic flexure. At the splenic flexure, where the hindgut begins, the parasympathetic and sympathetic arise from the splenic nerves. In GI pharmacology, many drugs work on the parasympathetic portion of the GI tract, and as many of you recall, the parasympathetic is for rest and digest. In our case, digest is going to be what we're talking about in this case. So it's also important to know the major layers of the gut or gastrointestinal tract. The innermost layer is called the mucosa. The mucosa is where we have epithelium, which is usually columnar. This is primarily for absorption. The lamina propria is present below this for support, and there's also the muscularis mucosa that helps promote motility. Next is the submucosa. Here we see the submucosal nerve plexus called the Meissner plexus. Next is the muscularis externa. This includes an inner circular muscle and an outer longitudinal muscle. And in between these two muscle layers is the myenteric plexus, which is also called the Auerbach plexus. Then on the outside, we have the serosa, which is just the thin membrane that covers the organ. So, since we've been talking about anatomy and development, I want to briefly go over some developmental pathology. What happens when we don't develop our GI tract correctly? This isn't all of it. Some of the diseases are covered in more detail in other videos. Extrahepatic biliary atresia. This is incomplete recanalization of the bile duct during development. It presents shortly after birth. Because the extrahepatic bile duct is not developed, the bile cannot flow out of the liver. As a result of this, infants will have jaundice, dark urine, and light-colored or clay-colored stools. Annular pancreas. This occurs when there is failure of the ventral pancreatic bud to rotate properly. This results in a thin constricting band or ring around the duodenum. If duodenal obstruction occurs, then the patient will have non-bilious vomiting, as the obstruction is proximal to the ampulla where the bile enters the duodenum. And this also presents shortly after birth as well. Malrotation of the midgut. The normal 270-degree rotation is not completed. In the 6th week of embryonic life, the midgut is going to herniate through the umbilical ring, and then in the 10th week, it's going to return to the cavity and rotate again around the superior mesenteric artery. That's how we get the 270-degree rotation. So if you don't get that, then the cecum and the appendix lie in the upper abdomen. It is associated with volvulus or twisting of the intestine, which can result in obstruction. There are a couple more things I want to cover in this section, but I'll need you to turn to the study guide. Here we're looking at abdominal wall defects, and the two you need to know are omphalocele and gastrochesis. Students will often get these two confused, so let's look at the difference. Omphalocele is a defect in the abdominal wall with the extruding viscera covered by a sac. So one way to remember this is that omphalocele has a seal. The sac is composed of peritoneum and amnion. The liver is often protruding, as well as there are many potentially other abnormalities that can be associated with omphalocele, like genitourinary, cardiovascular, central nervous system, or musculoskeletal anomalies. And the frequencies of these anomalies is about 50%. Gastrochesis is a similar defect in the abdominal wall, but the viscera is not covered by a sac. The liver is never found protruding, and other anomalies occur a lot less frequently, approximately 10 to 15%. The defect in gastrochesis is lateral to the umbilicus, right greater than left. So try to keep these straight. I remember that omphalocele is worse by saying, oh my God, omphalocele is worse. Okay, so that's a very brief talk on developmental pathology of the GI tract, and you'll notice some things there were missing, but again, don't worry, we have that covered in future videos. Now let's move on to the esophagus and talk about it in more detail. The esophagus obviously transports food to the stomach. The upper third of the esophagus contains skeletal muscle. The middle third is both skeletal and smooth muscle, and the lower third is comprised only of smooth muscle. And another important structure is the lower esophageal sphincter, which relaxes in preparation for the passage of food into the stomach. And when that lower esophageal sphincter does not relax appropriately, we get a problem called achalasia, which means failure to relax. This failure of relaxation is caused by a loss of the myenteric nerve plexus, also known as the Auerbach plexus. Without a functioning Auerbach plexus, the esophagus will have an uncoordinated peristalsis or sometimes no peristalsis, and food and liquids will get stuck in the esophagus. Patients will often have dysphagia to both solids and liquids. This may be a clue on a test question, Most other cases of esophageal obstruction, such as cancer or scarring, will cause dysphagia to solids only, but not usually to liquids. When this is imaged with a barium swallow, you see a dilated esophagus followed by an area of stenosis in the distalmost aspect of the esophagus near the GE junction with delayed or incomplete emptying of barium from the esophagus. Sometimes this is referred to as a bird's beak appearance. Another form of secondary chalasia can occur in the setting of Chagas disease. This is an infection caused by Trypanosome cruzi. One thing to remember about this infection is that it makes things bigger. You get cardiomegaly and megaesophagus, which can result in achalasia. Another cause of esophageal dysmotility is CREST syndrome. The E in CREST stands for esophageal dysmotility, which involves low pressure proximal to the lower esophageal sphincter. CREST is a connective tissue disorder that is associated with 5 conditions, including calcinosis, Raynaud phenomenon, the esophageal dysmotility we just mentioned, sclerodactyly, and telangiectasia. CREST is a limited cutaneous form of systemic sclerosis, also known as scleroderma. So a diverticulum is an abnormal pouch coming off of the esophagus, and these are named based on their location in the esophagus. There's Zenker's diverticulum, which is immediately above the upper esophageal sphincter in the most proximal aspect of the cervical esophagus. The Zenker diverticulum is considered a false diverticulum because it only contains mucosa and submucosa and not the other layers of the intestinal wall. A Zenker's is the most common type of esophageal diverticulum. The traction diverticulum is near the middle point of the esophagus. The traction diverticuli are usually true diverticuli containing all the layers of the esophagus. And the epiphrenic, think about the phrenic nerve in the diaphragm, and so the epiphrenic is right on top of the diaphragm or near the diaphragm. So this diverticulum is immediately above the lower esophageal sphincter. These are again a false diverticulum, so be aware of these 3 different names of esophageal diverticuli. Let's cover some more esophageal pathology, and we're only hitting on the high yield stuff on these. Esophageal variceal bleeding. Bleeding from esophageal varices due to portal hypertension. Patients will present with hematemesis and other signs of cirrhosis, most commonly ascites, but also with skin changes, spider telangiectasias, and dilated periumbilical veins, also called caput medusae. You'll most often see this in patients with alcoholic cirrhosis. Patients are also placed on octreotide infusions. We can sometimes treat this with vasoconstrictors like vasopressin. Endoscopy is needed for both diagnosis and treatment because a brisk peptic ulcer bleed can also present with hematemesis. Endoscopic treatment most commonly involves placing bands on the varices. Boerhaave syndrome. This is a complete rupture of the esophagus caused by severe retching. This is a full thickness tear and is a very serious condition. Patients may present with a pneumomediastinum, which is usually seen on chest x-ray or a CT scan of the chest. Surgery is certainly needed for survival. GERD is a common predisposing factor. Mallory-Weiss tear. Laceration of the gastroesophageal junction caused again by severe retching or sometimes coughing. This laceration usually results in bleeding from the esophagus and hematemesis. This is not nearly as serious as Boerhaave's because it is only a mucosal tear. Endoscopy is usually required for diagnosis. Alcoholics and bulimics are at an increased risk for this. This is extremely common. This presents as heartburn, which is often associated with obesity, overeating, symptoms when lying down, and eating of certain foods can also trigger these symptoms. We treat these with H2 blockers and proton pump inhibitors. Chronic GERD can be problematic because it can lead to Barrett's esophagus, which is an abnormal change or metaplasia in the cells of the lower esophagus. Normally, the lower esophagus has squamous epithelium, but if this area is repeatedly exposed to stomach acid, then these cells get replaced with columnar epithelia and goblet cells. This process is called intestinal metaplasia. So the esophagus starts to look a lot more like the intestine. So what's the big deal about that? Well, the problem is that there's an association between Barrett's esophagus and esophageal adenocarcinoma. We'll cover cancer more in a bit. This is a herniation of the upper part of the stomach into the thorax through a weakness in the diaphragm. A sliding hiatal hernia is the most common. In that one, the GE junction is displaced on barium study, so you see an hourglass type configuration of the upper stomach. The second type is a paraesophageal or rolling hiatal hernia, when the stomach herniates through the esophageal hiatus and lies beside the esophagus without movement of the GE junction. Hiatal hernia will increase the incidence of GERD. This is inflammation of the esophagus. This can be due to GERD, but can also be a result of infection. Diabetic and immunosuppressed patients can have candidal esophagitis that presents with numerous small white pseudomembranes through the esophagus. In immunosuppressed patients, CMV can cause esophagitis. If you see a biopsy with enlarged cells, intranuclear and cytoplasmic inclusions, and a clear paranuclear halo, this is classic for CMV. HSV can also cause esophagitis. This might present similarly to CMV esophagitis with a biopsy that shows large pink intranuclear inclusions and host cell chromatin that is pushed to the edge of the nucleus. These are exactly what they sound like. This is a narrowing of the esophagus. This again can be caused by GERD. On test, they like to have a scenario where a patient swallows a caustic substance like lye. The damage caused by the lye can produce strictures in the esophagus. These can be diagnosed by barium swallow, and patients can undergo esophageal dilation by endoscopy to correct this. This is great high-yield syndrome that test makers love to use. Plummer-Vinson is a rare disease that is characterized by the triad of dysphagia due to esophageal webs, glossitis, and iron deficiency anemia. It generally occurs in postmenopausal women. Those esophageal webs will look like protrusions of the mucosa in the upper esophagus. Treatment with iron supplementation and esophageal dilation is usually all that needs to be done. Okay, so that's a ton of stuff. Let's do a mini review. Let's fill out the chart in the study guide. These are some high-yield associations that you should know. What upper GI problem is associated with the following symptoms? Specialized columnar epithelium seen in a biopsy from the distal esophagus would be Barrett esophagus. Biopsy of a patient with esophagitis reveals large pink intranuclear inclusions and host cell chromatin that is pushed to the edge of the nucleus. This is classic for herpes simplex virus. Biopsy of a patient with esophagitis reveals enlarged cells, intranuclear inclusions, cytoplasmic inclusions, and a clear paranuclear halo. This is CMV causing esophagitis. An esophageal biopsy reveals a lack of ganglion cells between the inner and outermost muscular layers. Is called achalasia. Protrusion of the mucosa in the upper esophagus is the esophageal web, which we said earlier was associated with Plummer-Vinson syndrome. Outpouching of the esophagus found just above the lower esophageal sphincter is an epiphrenic diverticulum. Goblet cell seen in the distal esophagus is Barrett's esophagus. A PAS stain on a biopsy obtained from a patient with esophagitis reveals hyphate organisms. This is Candida esophagitis. An esophageal pouch found in the upper esophagus is a Zenker diverticulum. We have a couple of cancers to cover. Esophageal adenocarcinoma. This is associated with Barrett's esophagus, which we covered earlier, a complication of long-standing GERD. We see this in the distal third of the esophagus, and we see the metaplastic change of the normal squamous epithelium with goblet cells. Adenocarcinoma is more common in whites. It is the most common type of esophageal cancer in the United States. Risk factors for adenocarcinoma include GERD, Barrett's esophagus, smoking, obesity, and nitrosamines. Esophageal squamous cell carcinoma. This is associated with alcohol and tobacco use. This is the most common esophageal cancer worldwide, but don't forget the adenocarcinoma is more common in the US. The clinical features will include dysphagia, anorexia, and pain. Now let's go through the end of session quiz. What is the histologic change found in Barrett esophagus? Normally, the lower esophagus has squamous epithelium, but if this area is repeatedly exposed to stomach acid, then those cells get replaced with columnar epithelium and goblet cells. What are the names of the diverticuli found in the esophagus based on their anatomical locations? Starting at the upper esophagus and working downward, there's a Zenker diverticulum, which is located immediately above the upper esophageal sphincter. There's a traction diverticulum, which is located near the midpoint of the esophagus. And there is an epiphrenic diverticulum, which is found immediately above the lower esophageal sphincter. A 60-year-old man with chronic reflux presents with esophageal cancer. What is the most likely histologic type? It is adenocarcinoma. In the U.S., adenocarcinoma is most common, but worldwide, squamous cell carcinoma is the most common. That's it for the end of session quiz. We have a couple rapid-fire facts. Dysphagia, glossitis, and iron deficiency anemia. Plummer-Vinson syndrome, hematemesis with retching, Mallory-Weiss tear, also think Boerhaave syndrome if it's bad. That's it for GI2. We'll see you next time.
It's time for another warm-up. Let's get going. Which cytokines match each of the following statements? So first we have promotes B cell growth and differentiation. Think of IL-4 and IL-5. Produced by the Th1 cells, that's going to be IL-2 and interferon gamma. Produced by Th2 cells, that's IL-4, IL-5, and IL-10. Secreted by helper T cells and activates macrophages, that's going to be interferon gamma. Pyrogens secreted by monocytes and macrophages, think of IL-1, IL-6, and TNF-alpha. Enhances synthesis of IgE and IgG, that's going to be IL-4. Enhances synthesis of IgA, that's going to be IL-5. And then we have released by virally infected cells, that's going to be interferon alpha and interferon beta. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to discuss the stomach, focusing on the basic anatomy and physiology of the stomach, especially with regard to gastric acid secretion and regulation. But before we dive into the stomach, let's talk about the vascular anatomy of the GI tract, starting with the abdominal aorta and the branches coming off of it. Now, this is a 4-star topic. There are 3 main arteries that come off anteriorly from the abdominal aorta. There's the celiac trunk coming off, and inferior to that, you have the superior mesenteric artery, or the SMA. Then inferior to that, coming off laterally, are the left and right renal arteries and the left and right gonadal arteries. And then the third artery that comes out anteriorly, inferior to the renals and the gonadal arteries, is the inferior mesenteric artery, the IMA. So again, the 3 arteries that come off the abdominal aorta anteriorly are the celiac trunk, the SMA, and the IMA. And you need to be able to recognize all of these arteries on an angiogram. We'll look at an angiogram in a moment. The celiac trunk is the artery of the foregut, and the artery of the midgut is the SMA, and the artery of the hindgut is the IMA. So the celiac trunk supplies everything derived from the foregut, the stomach, the proximal part of the duodenum, plus a huge chunk of visceral organs like the liver, the gallbladder, the spleen, the pancreas. The SMA supplies everything derived from the midgut, which is the majority of the GI tract, from the distal duodenum all the way down to the splenic flexure of the colon. So virtually all of the small intestine and the proximal 2/3 of the colon. Then the IMA supplies blood to the hindgut structures, from the distal third of the colon to the upper portion of the rectum. This means that the splenic flexure is what we call a watershed area. Now, do you remember what a watershed area is? A watershed area is an area that receives blood supply from the distal branches of 2 different arteries. We talk about watershed areas of the brain, like where the anterior and middle cerebral arteries kind of overlap. And we talk about the splenic flexure as a watershed area of the gut because it receives blood supply from both the SMA and the IMA. And the reason this is important is that if you occlude one artery with an embolus, you have some redundant blood supply so that tissue won't infarct. But if there's systemic hypotension, the watershed areas are actually going to be affected first because those are the most terminal branches of the 2 arteries. So those watershed areas are going to have less circulation in times of severe hypotension. So in patients with shock, the watershed areas are the most susceptible to ischemia, and that's definitely important to know. Let's look at the celiac trunk in a little more detail. Knowing the arteries that come off the celiac trunk is also about a 3-star topic. So about half of you can expect to see a question where they show you a celiac trunk arteriogram and then expect you to identify those arteries well. And it's not as difficult as you might think at first. There are 3 arteries coming off the celiac trunk, And then there are 3 arteries coming off the common hepatic artery that I want you to know as well. So the 3 arteries coming off the celiac trunk are the common hepatic artery, the splenic artery, and the left gastric artery. Then coming off of the common hepatic artery, you have the gastroduodenal artery, and it gives off a couple of important branches that you want to know. We'll come back to those branches in just a second. The second artery coming off the common hepatic is the right gastric artery, which follows the lesser curvature of the stomach and then anastomoses with the left gastric artery. And the third artery that comes from the common hepatic is called the proper hepatic artery, or sometimes the hepatic artery proper. It's basically what's left after the gastroduodenal and the right gastric have split off. So there are 3 branches of the celiac trunk and then 3 branches of the common hepatic. Then to go back and pick up a couple of important branches off the gastroduodenal artery, there's the right gastroomental artery, or sometimes it's called the right gastroepiploic artery. That's going to follow the greater curvature of the stomach around until it anastomoses with the left gastroomental artery, which comes off the splenic artery behind the stomach. And then the other important branch off the gastroduodenal artery is the anterior superior pancreaticoduodenal artery. This supplies the anterior part of the head of the pancreas and the proximal duodenum, which you could probably guess from the name, pancreaticoduodenal. Again, this is a 3-star topic, so a fair number of you will see a question about this on your exam. Even though all these organs get their primary blood supply from the celiac trunk, there are lots of anastomoses and a lot of collateral circulation. But you really don't need to know where all those individual anastomoses occur. But you do need to be able to identify arteries on a CT or an angiogram. So let's take another look at it.
This is an angiogram or an arteriogram of the celiac trunk. The patient is lying on his back facing us, so this is the patient's right and this is the patient's left. We said there were 3 main branches that come off the celiac trunk. One is the splenic artery, which is a large diameter vessel that goes off to the left toward the spleen. This small diameter artery is the left gastric artery, and the third branch is the common hepatic artery, which is kind of short and stubby in this patient. Then what comes off the common hepatic artery? Well, there's the right gastric artery, the proper hepatic artery, which heads toward the liver, and the gastroduodenal artery, which heads downward toward the duodenum and the head of the pancreas.
Now let's focus on the stomach as advertised. When you think about the function of the stomach, you probably think about digesting food. But the way it does that is by secreting enzymes and gastric acid. So I want you to remember that the stomach is an important secretory organ. So what's the stomach secreting? Well, one thing the stomach secretes is gastric acid, or hydrochloric acid, obviously. Gastric acid is secreted by the parietal cells in the fundus of the stomach. The stomach also secretes pepsin, which is important for the digestion of proteins. And it's the chief cells that make pepsin. Actually, they secrete pepsinogen, which is a proenzyme. And then when pepsinogen hits the stomach acid, it's cleaved to the active pepsin molecule. Another important product of the stomach is bicarbonate. So the mucosal cells of the stomach secrete bicarb into a layer of bicarb-rich alkaline mucus that lines the lumen of the stomach and protects the stomach from all that gastric acid. Mucus production in the gut is stimulated by prostaglandins. So prostaglandins, mucus, and bicarb all work together. And remember, if you take NSAIDs or aspirin, that's going to inhibit cyclooxygenase and inhibit prostaglandin synthesis. So there's going to be less bicarb secretion and an increased risk of peptic ulcers. And while we're talking about bicarb, what else makes bicarb? Well, the duodenum has Brunner's glands that make bicarb. The salivary glands make bicarb. The ducts of the pancreas make bicarb. And bicarb secretion is stimulated whenever there's a lot of acid around. And there's a hormone produced in the duodenum called secretin that stimulates bicarb secretion. We'll see that again when we talk about the duodenum. And then one last important substance that the stomach secretes is intrinsic factor. Now, which cells make intrinsic factor? Parietal cells. So the same cells that make stomach acid also make intrinsic factor. What is intrinsic factor? Intrinsic factor is a protein that binds to vitamin B12 so that B12 can later be absorbed in the last part of the small intestine, which is the terminal ileum. Make sure you know that. B12 is absorbed in the terminal ileum, but only if it's bound to intrinsic factor. And that intrinsic factor comes from the parietal cells in the stomach. If the parietal cells are destroyed, you won't be able to make intrinsic factor, then you won't be able to absorb B12, and that leads to pernicious anemia. In patients with autoimmune chronic gastritis, where autoantibodies are destroying the parietal cells, that leads to B12 deficiency and pernicious anemia. B12 deficiency causes megaloblastic anemia and neurologic deficiencies like peripheral neuropathy and possibly dementia.
Let's review how the stomach secretes gastric acid and how it's regulated. Gastric acid is secreted by the parietal cells to digest food for absorption and to activate pepsin. And if that acid secretion isn't tightly regulated, That can cause gastritis and esophagitis and ulcers. So let's review how acid production is regulated. The first thing I want to talk about is a hormone called gastrin. Gastrin is another important secretory product that comes from the stomach. Gastrin is secreted into the circulation by the G cells in the antrum of the stomach. So this is another specialized cell type in the stomach.
So in your stomach, you have parietal cells that secrete intrinsic factor and gastric acid, and chief cells that secrete pepsinogen, and mucosa cells that secrete bicarb, and now these are the G cells that secrete gastrin. G for gastrin. It's pretty easy. So what does gastrin do? We can think of gastrin as being pro-gastric. It facilitates the stomach's being able to accomplish its primary function, which is to digest food. So gastrin stimulates acid secretion. It promotes growth of gastric mucosa to protect the stomach from all that acid. And it stimulates gastric motility so that the stomach's going to churn the food and mix the food up with the acid and then eventually expel that food into the duodenum. So gastrin essentially is causing digestion to take place in the stomach. And there are three things that I want you to know that can stimulate gastrin secretion: phenylalanine, tryptophan, and calcium. So hypercalcemia can cause excess gastrin release, and that can lead to excess acid and GERD and ulcers. So gastrin's one important regulator of gastric acid, but that's not the whole story. What else regulates stomach acid secretion? First of all, what's the main nerve that regulates stomach acid secretion? Well, it's the vagus nerve, part of the parasympathetic nervous system. Rest and digest, right? The vagus nerve directly stimulates the parietal cells to secrete gastric acid by way of the M3 muscarinic acetylcholine receptors. And what category of drugs would inhibit that process? Antimuscarinic drugs like atropine. So atropine can suppress gastric acid secretion. Now the vagus nerve also stimulates the G cells. What did we say that the G cells secrete? G for gastrin. So the vagus nerve directly stimulates the parietal cells to secrete gastric acid, and then the vagus nerve also indirectly stimulates acid secretion by stimulating the G cells to make gastrin, and that ramps up acid production. But the interesting thing is that the transmitter that the vagus nerve uses to stimulate these G cells is not acetylcholine. The vagus nerve uses a peptide transmitter called GRP, or gastrin-releasing peptide. So this means you can give atropine all day long and it won't have any effect on gastrin production, even though it's the vagus nerve that's stimulating the G cells. I find that pretty interesting. Now, when the vagus stimulates those G cells and they release gastrin into the blood, that gastrin travels through the circulation and eventually reaches the parietal cells. And then gastrin binds to a receptor on the parietal cells, and that tells the parietal cells to make more acid. So gastrin does stimulate the parietal cells directly. But the main mechanism by which gastrin regulates stomach acid secretion is that gastrin can also stimulate another specialized cell type found in the stomach called enterochromaffin-like cells, or ECL cells. The enterochromaffin-like cells are important because they summate a lot of different signals. They're mediating signals from gastrin, from the vagus nerve, from somatostatin, and a bunch of minor players too. So the ECL cells receive all these different inputs, and then they secrete histamine. And that histamine goes directly to the parietal cells and stimulates a histamine receptor, and that signal also tells the parietal cell to make more acid. Now, think back to the different classes of G protein receptors for a moment. Do you remember which type of histamine receptor was involved in stomach acid secretion? Was it H1 or H2? Well, H1 mediates allergy symptoms like runny nose and pruritus. H2 mediates gastric acid secretion. And what kind of G protein did the H2 receptors use? H2 receptors were GS receptors. They're not the MAD2s, they're not the cutesies have one M&M. They're GS, which stimulates adenylyl cyclase to make more cyclic AMP. That cyclic AMP is going to help the parietal cell make more gastric acid. And what kind of drug will block these histamine receptors? H2 blockers like cimetidine or ranitidine or famotidine. These are over-the-counter drugs like Tagamet or Zantac or Pepcid AC. Now, what other signals regulate gastric acid secretion? We said that prostaglandins facilitate bicarb secretion to help protect the gut. It also turns out that prostaglandins also directly inhibit gastric acid secretion. They actually trigger a GI G protein receptor, which inhibits adenylyl cyclase and kind of counteracts the cellular effects of the histamine signal. And then the hormone somatostatin, or the drug octreotide, which is an analog of somatostatin, directly inhibits parietal cells from generating acid in the same way. Now that we have all these signals and transmitters converging on the parietal cell, how does the parietal cell generate acid? Parietal cells have a hydrogen-potassium ATPase on the luminal side of the cell. this hydrogen potassium ATPase is going to pump potassium into the cell against the potassium gradient and exchange potassium for a hydrogen ion, which is a proton. And because this is working against the potassium gradient, it requires energy. So it uses an ATP molecule to pump this proton into the lumen of the stomach. And this potassium hydrogen ATPase is also called a proton pump. And drugs like omeprazole are called proton pump inhibitors because they inhibit this enzyme and they inhibit secretion of gastric acid. And that's where these drugs work. Now, as you put hydrogen ion into the stomach, you have to balance that somewhere else in the body. So as acid gets pushed into the stomach, bicarb is going to be pushed into the circulation. And then later, as that acid gets reabsorbed, it's going to combine with the bicarb and they'll neutralize each other. But for a little while, when you make more stomach acid, you're actually causing a tiny bit of alkalosis. Since we talked about the role of gastrin, I want to touch very briefly on a disease where you have too much gastrin, which is called Zollinger-Ellison syndrome, or ZE syndrome. This is where you have a tumor, usually in the pancreas, that makes gastrin. We call this a gastrinoma, a gastrin-secreting tumor. And the problem is that these gastrinomas aren't being regulated by anything. So you make excess gastrin, and therefore excess gastric acid, and that leads to recurrent duodenal ulcers. Now, we're going to talk about peptic ulcers in another video, but most of the time, if you see duodenal ulcers, the first thing you should think about is H. pylori. Over 90% of duodenal ulcers are due to H. pylori, but a tiny percentage of the time, recurrent duodenal ulcers will be due to Zollinger-Ellison syndrome. Say you do an EGD on the patient and you see an ulcer and you treat the patient for H. pylori and you start a PPI like omeprazole, then the patient comes back 3 months later and they still have ulcers. Anytime you have recurrent ulcerations, think about Zollinger-Ellison syndrome and check a gastrin level. One other thing to remember about ZE syndrome is that these pancreatic gastrinomas can be associated with multiple endocrine neoplasia type 1. Now, right now I want you to take out a piece of paper and let's do a pop quiz on the branches of the celiac trunk.
Here's another angiogram of the celiac trunk, and I want you to pause the video and label the structures numbered 1, 2, 3, and 4. Number 1 is the left gastric artery. Number 2 is the common hepatic artery. Number 3 is the splenic artery, which is the large diameter vessel coming off the celiac trunk and heading toward the patient's left side. So those are the 3 branches off the celiac trunk. Then number 4 is the gastroduodenal artery, which is one of the major branches off the common hepatic. And to take this a little bit deeper, over here, coming off the gastroduodenal and following the greater curvature of the stomach over toward the left, toward the spleen, is the right gastroomental artery. And you can almost see where it anastomoses with the left gastroomental artery, which comes off the splenic artery. And then besides the gastroduodenal artery, what are the other arteries that come off the common hepatic artery? There's the right gastric artery and the proper hepatic artery, which then divides into the left hepatic artery and the right hepatic artery. And just for fun, let me also point out that you can see the cystic artery coming off the right hepatic artery. So make sure you can identify each one of these arteries.
Now you're ready for the end of session quiz. So pause the video, answer those questions, and we'll go through them together. First question, what's the artery of the foregut? That's the celiac artery. And the artery of the midgut is the superior mesenteric artery, and the artery of the rectum, the distal third of the colon, is the inferior mesenteric artery. Next, what disorder is characterized by an excess of gastrin? Again, that's Zollinger-Ellison syndrome. And what's the treatment? You're going to give PPIs like omeprazole and possibly give octreotide, especially if the gastrinoma has octreotide receptors, which it may or may not. Next, what receptors found on gastric parietal cells regulate acid secretion? Well, the most important receptor is the H2 histamine receptor. There's also the CCK-B receptor, the cholecystokinin receptor type B, and that responds to gastrin. And there's the M3 muscarinic receptor, which responds to acetylcholine. And then prostaglandin receptors and somatostatin receptors also play small roles. Last question. What happens to serum pH at the time of gastric acid secretion? Remember, when you pump hydrogen ions into the stomach lumen, you're pumping bicarb into the serum, so the serum pH rises slightly. The blood becomes slightly more alkaline. That's it for now. I'll see you next time.
It's time for another warm-up. Let's get going. First question here, label the following gram-positive algorithm. So this one will probably take a couple of minutes to fill out, so why don't you guys pause the video until you're done, and then we'll show you the completed algorithm. All right, so here is the completed gram-positive algorithm. So take a look, make sure you filled out everything correctly. All right, that's it for the warm-up. Let's get to that lecture now.
In the last video, we talked about the physiology and regulation of gastric acid production. So now we're ready to talk about some pathology of the stomach, especially pathology that's related to gastric acid. So let's start out with acute gastritis, which is inflammation of the stomach and a breakdown of the mucosal lining. So this can either be a problem of too much gastric acid or a problem in which the bicarb and the mucus aren't protecting the stomach from that gastric acid. But either way, it leads to breakdown of the mucosal lining, and then the cells start to get irritated and inflamed, and that would be acute gastritis. And it can certainly cause some tissue necrosis and even some hemorrhage. Now, there are several things that can lead to acute gastritis. One major cause is NSAIDs and aspirin, because those drugs inhibit cyclooxygenase and inhibit the production of prostaglandins, which are important to protect the mucosa from gastric acid. Alcohol is another important cause, so definitely remember NSAIDs and alcohol. And then a couple others you should know about include burns. So when a burn causes gastritis and ulceration of the mucosa, that's called a curling ulcer. The physiological stress of the burn is going to reduce the body's capacity to make that mucosal barrier, so it's going to have less protection against inflammation. Now you might remember the name curling ulcer by thinking of a curling iron burning the stomach. So a curling ulcer is associated with a burn injury. Now, brain injury can also lead to gastritis that results in ulceration, and that's called a Cushing ulcer. One way to remember that is that Dr. Cushing was a famous neurosurgeon. So we have Cushing disease, we have Cushing's triad associated with high intracranial pressure, and there's also Cushing's ulcer that's associated with brain injury. Then there's also chronic gastritis, which is primarily caused by the bacteria Helicobacter pylori. Now here you see the helical or spiral-shaped H. pylori bacteria within the gastric glands. And here's a biopsy from a patient with chronic gastritis, and you can see the neutrophils invading the glands, which is evidence of inflammation. You can also see lymphocytes infiltrating the tissue. And whenever you have excessive numbers of lymphocytes, you're more likely to develop lymphoma. So with chronic gastritis due to H. pylori and infiltrating lymphocytes, you're more likely to have a malt lymphoma in that region. And H. pylori also increases your risk of gastric cancer. Now, there's another type of chronic gastritis that's characterized by autoimmune destruction of the parietal cells. And that's going to lead to decreased production of intrinsic factor, and that's going to lead to B12 deficiency and pernicious anemia. So let's look in your study guide and touch on some of these histological details again. These are the kinds of things that have been known to show up on board exams, so these are worth knowing. What upper GI problem is associated with each of the following findings? So the first one says, stomach biopsy reveals neutrophils above the basement membrane, loss of surface epithelium, and fibrin-containing purulent exudate. Well, this is the histology that you would see with acute gastritis. The next one says stomach biopsy reveals lymphoid aggregates in the lamina propria, columnar absorptive cells, and atrophy of the glandular structures. That's chronic gastritis. And then diffuse thickening of the gastric folds, elevated serum gastrin levels, and the biopsy reveals glandular hyperplasia without foveolar hyperplasia. This would be Zollinger-Ellison syndrome with a gastrin-secreting tumor of the pancreas. Next, let's talk about peptic ulcers, which we said were associated with H. pylori. Now, this is where the gastric acid erodes through the mucosa and into the submucosal tissue, and it can occur either in the distal stomach, which would be a gastric ulcer, or it can occur in the duodenum, which would be a duodenal ulcer. Now, gastric ulcer will classically cause a lot of upper abdominal pain and epigastric pain right after eating, because whenever you eat, you're going to make more stomach acid. That's going to exacerbate the ulcer. And it can also lead to weight loss because these patients learn to avoid eating because it hurts when they eat. Now, gastric ulcers are very commonly associated with H. pylori infection. About 70% of gastric ulcers are due to H. pylori. And then NSAID use is another common culprit. And again, it's because with gastric ulcers, you have loss of mucosal protection. So the gastritis leads to ulceration. Gastric ulcers do increase your risk of gastric cancer. So whenever you see a patient with gastritis and a gastric ulcer, you're doing an EGD and you find a gastric ulcer, it's not a bad idea to go ahead and take biopsies around the edge of that ulcer to make sure there's not a cancer in there. Now with duodenal ulcers, the pain is going to be slightly different. When these patients eat, the area of the duodenum is going to make bicarb, and that bicarb is actually going to soothe the ulcer. So eating is going to make the ulcer pain go away, and the pain comes back several hours after meals. So these patients are going to tend to gain weight because that eating makes the pain better, at least temporarily. And about 90 to 95% of the time, duodenal ulcers are due to H. pylori. So if you do an endoscopy, first of all, the duodenal ulcer is going to have nice, clean, smooth borders. And then on biopsy, you're going to see the H. pylori organisms in the tissue. You can also see hypertrophy of the Brunner glands in the duodenum. But those Brunner glands are submucosal, so an endoscopic biopsy may not get deep enough to see them. And then very rarely, duodenal ulcers might be caused by Zollinger-Ellison syndrome, which is, again, that gastrin-producing tumor, a gastrinoma. Now, one of the reasons that peptic ulcers are so problematic is that besides being fairly common, there are also some pretty important complications that they can cause. We've kind of already touched on these. Obviously, ulcers can be painful. They can lead to either weight loss or weight gain. They can hemorrhage. So if you ulcerate into a vessel, it can cause lots and lots of bleeding. And if you needed to treat an actively bleeding peptic ulcer, what kind of drug could you use? Well, you can either give somatostatin or octreotide, and that's going to decrease splanchnic blood flow. And then ulcers can also perforate, particularly duodenal ulcers. Now, perforation is really bad news anywhere in the gut because the intestinal contents and bacteria are now getting into the abdomen. They're causing peritonitis. So those are a couple things that can happen with ulcers other than pain. Now, aside from treating the complications of an ulcer, how do you treat the ulcer itself to prevent those complications? Well, since the vast majority of ulcers are due to H. pylori infection, we need to focus on eradicating the bacteria with what we call triple therapy. Now, there are a couple of different triple therapy regimens you can use. You can use a proton pump inhibitor plus clarithromycin plus amoxicillin. Or if the patient's allergic to amoxicillin, then you can use metronidazole in place of amoxicillin. So either you can use a PPI plus clarithromycin plus amoxicillin or a PPI plus clarithromycin plus metronidazole. And then sometimes, if the H. pylori turns out to be resistant to clarithromycin, we have to use quadruple therapy, which is a PPI plus bismuth, which is found in Pepto-Bismol, plus metronidazole, plus tetracycline. The other big part of treating peptic ulcers and gastritis in general is pharmacotherapy to protect the stomach by neutralizing gastric acid and reducing gastric acid secretion. There are a bunch of different classes of medications that we use, so let's go through those one at a time. Let's start with antacids, which are compounds that neutralize gastric acid in the stomach. The three main antacids are calcium carbonate, magnesium hydroxide, and aluminum hydroxide. Now, these are available over the counter, so lots of patients start using these as soon as they start having any kind of indigestion or heartburn symptoms.
Calcium carbonate is probably the most commonly used one, so let's start there. Calcium carbonate is the main ingredient of Tums. It's basically limestone or chalk. But it helps with stomach acid because the carbonate buffers the gastric acid. All these antacids actually neutralize the existing gastric acid, so they work very quickly. The problem with calcium carbonate is that it can cause hypercalcemia if you take too much of it. What does hypercalcemia do to stomach acid? Well, it stimulates the G cells to make more gastrin. That actually makes the acid worse. So even though immediately it's going to relieve the acid, it can actually cause a rebound excess of acid because of the gastrin. Another common antacid is magnesium hydroxide, which is found in Rolaids. Now, the side effects we see from magnesium hydroxide come about because magnesium is a smooth muscle relaxer. IV magnesium is used to stop uterine contractions in patients with preterm labor. It's rarely used for severe asthma to relax bronchial smooth muscles. So you can think about magnesium as being a smooth muscle relaxer. And as a result, magnesium hydroxide antacids commonly cause diarrhea if you take too much. They can also potentially cause hyporeflexia and hypotension and even cardiac arrest. But it's difficult to take enough oral magnesium hydroxide to do that. Typically those symptoms come about from infusion of IV magnesium. And then one more antacid is aluminum hydroxide, which can cause constipation rather than diarrhea. So Maalox and Mylanta are examples of drugs that have aluminum hydroxide. And aluminum also causes some hypophosphatemia. And aluminum can also cause proximal muscle weakness, and seizures, and osteodystrophy. You should also know that all of these antacids can cause hypokalemia. They neutralize acid, which induces a little metabolic alkalosis. The body counteracts that alkalosis by pumping hydrogen ions out of the cells into the blood. Unfortunately, the pump used is a hydrogen-potassium countertransporter. So when it pumps one hydrogen out of the cell into the blood, it also pumps a potassium ion from the blood into the cell. And that shift of potassium out of the blood can lead to hypokalemia. Antacids work by neutralizing gastric acid that's already been produced. but there are other drug classes that prevent acid secretion in the first place. Let's start with the H2 blockers, which include cimetidine, famotidine, nizatidine, and ranitidine.
H2 blockers reduce gastric acid secretion by directly inhibiting the H2 histamine receptor on the parietal cells. So these are a type of antihistamine. They don't work on the H1 receptors. They won't do anything for allergic rhinitis or hay fever. But they can be useful in any scenario where you have excess stomach acid, whether it's GERD or gastritis or peptic ulcers. Now, out of all these H2 blockers, cimetidine bears some special consideration with regard to side effects. For one thing, cimetidine inhibits cytochrome P450, and that can affect therapeutic levels of other drugs. We mentioned cimetidine was the first C in our crack amigos mnemonic. What was the other C? Ciprofloxacin. Cimetidine also has anti-androgen effects, which can lead to impotence and decreased libido and gynecomastia. Remember, the mnemonic for drugs that cause gynecomastia was stacked. And again, the C was for cimetidine. Cimetidine is also known to have an unusual effect of decreasing methemoglobin levels. So in a patient that's taking nitrates and starting to develop some methemoglobinemia, you might start them on cimetidine to help reduce that. And then H2 blockers as a category are also known to contribute to thrombocytopenia. So if you have a patient who comes into the hospital and has a low platelet count, one of the things you're going to look at is whether or not they're taking an H2 blocker. Next, let's talk about your proton pump inhibitors, or PPIs. These all end in the suffix -prozol. There's omeprazole, esomeprazole, pantoprazole, and several more. Now, these are the big guns when it comes to blocking gastric acid production because they go right to the source and they inhibit the hydrogen-potassium ATPase, that proton pump. And when you talk about giving H2 blockers, you're blocking H2 receptors, but there are still other signals that might be able to go around the backside and still be able to stimulate the parietal cells. But if you're blocking the proton pump, there's no signal that can get that cell to secrete acid. So PPIs are especially useful in patients with severe GERD, patients with Zollinger-Ellison syndrome, or patients with erosive esophagitis where the GERD is so bad that it's actually eroding away your esophagus, and also peptic ulcers, of course, and gastritis. And we mentioned that we use PPIs as part of the triple therapy for H. pylori, very, very important part of that triple therapy. Now, the rest of these drugs are really less important and less commonly used. I'm just going to mention them briefly. There's bismuth, which we said is found in Pepto-Bismol. That can be specifically helpful to treat peptic ulcers because it binds to the tissues at the base of the ulcer and it forms a protective barrier. Sucralfate is another drug that works much the same way, but sucralfate actually requires an acidic environment to polymerize, and then it can bind to the base of the ulcer. And this protective barrier allows the natural bicarb and mucus to come in and neutralize the acid so that the ulcer can start healing behind that barrier. So these are particularly helpful to assist in the healing of ulcers, and they're also used for traveler's diarrhea. Another drug I want you to know about is misoprostol. Now remember, drugs with prost in the name are prostaglandin analogs. And prostaglandins aid in the generation of that gastric mucus barrier, which again is going to trap bicarb and protect the stomach. So if you have a patient that's taking NSAIDs, you might theoretically start misoprostol to prevent an NSAID-induced peptic ulcer. Now, clinically, that's not the drug of choice, but it might be the correct option on your exam. So it's definitely worthwhile to be aware of the specific mechanisms of action of all these anti-ulcer drugs. And then as a prostaglandin, misoprostol will actually increase uterine tone, and it can actually cause an abortion, so it's contraindicated in pregnancy. Misoprostol is also known for causing diarrhea, so be aware of that. Now we're going to move on to gastric cancer. But first, I want to briefly mention a disease which is a precursor to gastric cancer, and that's Menetrier disease. This is where you have hypertrophy of the mucus-producing cells, and the rugae of the stomach are so hypertrophied that they actually look like gyri of the brain. But you also have atrophy of the parietal cells and decreased gastric acid production. And this leads to enteric protein loss and hypoalbuminemia and edema. And then, like I said, it's thought to be associated with an increased risk of gastric adenocarcinoma. That brings us to gastric cancer. So gastric cancer is most commonly adenocarcinoma. Other than in the esophagus, pretty much throughout the rest of the GI tract, if you have cancer, it's going to be adenocarcinoma. There are lots of risk factors for gastric adenocarcinoma, such as H. pylori infection, chronic gastritis, also having a diet that's high in nitrosamines, which are found in cured and smoked foods and hot dogs, which is why nitrosamine-free hot dogs are such a big seller nowadays. Gastric cancer is more common in men than in women, especially in men over the age of 50. And classically, Japanese people in Japan have an increased risk of gastric cancer. But if they come over to the U.S. for a few years, their risk starts to drop pretty quickly. gastric cancer can be a particularly aggressive cancer and often spreads to the lymph nodes. Now, if it metastasizes to the left supraclavicular node, we call that a Virchow node. So if you have a patient that's been having a lot of weight loss, then has this big mass in the left supraclavicular area, that's going to be a huge red flag that there's an undiagnosed abdominal cancer, classically stomach cancer. There's also a name for mets to the periumbilical lymph nodes, which is called a Sister Mary Joseph nodule, which is named for a nun who worked as a nurse at the Mayo Clinic. The other name you should be aware of is Krukenberg. A Krukenberg tumor is when the stomach cancer has metastasized to the ovary. Another clinical feature worth knowing is acanthosis nigricans, which is a velvety darkening of the skin, particularly around the neck. And when we think of this as being associated with diabetes, but acanthosis nigricans is also associated with visceral malignancies like stomach cancer. So if you have a patient older than 40 that has new acanthosis, about 50% of the time there's going to be a visceral malignancy, so that's something to be aware of. And then histologically, gastric cancer can be associated with signet ring cells. So a signet ring cell is where the mucinous material in the cytoplasm pushes the nucleus to the periphery so that the cell looks like a signet ring. And it's classic for gastric adenocarcinoma. So again, if they give you a pathology slide from an ovary and you see those signet ring cells, what's the most likely diagnosis? It's probably a Krukenberg tumor, a gastric cancer that has metastasized to the ovary. Now, where else did we mention that you might see signet ring cells? I'll give you a hint. It was back in reproduction. It was a type of breast cancer. It was lobular carcinoma in situ, or LCIS, and also invasive lobular carcinoma. So if you see signet ring cells, I want you to think of two things. Think about gastric adenocarcinoma and lobular carcinoma in situ of the breast. There's one last upper GI pathology I want to talk about, which is congenital hypertrophic pyloric stenosis, or sometimes it's called infantile hypertrophic pyloric stenosis, or IHPS. It's a fairly common problem in infancy. About 1 in 600 live births have this. This is where the pylorus is hypertrophied so that it narrows the gastric outlet and the stomach can't empty very well. And because of this hypertrophy, you may actually be able to feel the pylorus externally when you palpate the infant's abdomen. It's going to be a palpable olive-like structure in the epigastric region. Now, why would you be looking for that? Why would you be inclined to palpate for that? Well, these parents are going to bring this baby to the emergency room saying, well, the baby won't stop throwing up. He's been throwing up for the last 2 or 3 days. I'm getting really concerned that he's dehydrated. So pyloric stenosis causes a non-bilious projectile vomiting. The stomach can generate a lot of pressure, especially if there's a stenosis in the pyloric region to kind of push against. So this is projectile vomiting, and it's non-bilious projectile vomiting because there's no bile reflux into the stomach because that pylorus is stenosed. Now typically this presents around 2 to 6 weeks of age, and the only way to treat it is to open up that stenotic area surgically. Pyloric stenosis is actually the most common condition requiring surgery in the first month of life, and it's most often going to be seen in firstborn males. And then one other thing to be aware of is that whenever there's prolonged vomiting, what electrolyte changes might occur? Well, think about what's going on. You're getting rid of hydrochloric acid. You're vomiting up hydrochloric acid, right? How's that going to affect your electrolytes? Well, you're going to have hypochloremia because you're vomiting up chloride with that hydrochloric acid. And because you're putting acid out of your body, you're going to be left with a metabolic alkalosis. So prolonged vomiting can lead to a hypochloremic metabolic alkalosis. We're talking about vomiting for days to weeks. An infant that's only been vomiting a couple of days, you may not actually see this. And also, when you create a serum alkalosis in the body, your body wants to correct that alkalosis. Now, our cells have a potassium hydrogen ion exchanger on them. And when the serum hydrogen ion concentration is low with alkalosis, the cells are going to start pushing hydrogen out of the cells into the serum. And that ion exchanger does that by bringing potassium into the cell. So it's exchanging hydrogen for potassium. So in the serum, you're going to be correcting the alkalosis, but you're going to start developing some serum hypokalemia. So whenever you have alkalosis, you're going to be pulling potassium out of the serum. And the converse is also true. Whenever you have acidosis, hydrogen ion is going to go into the cells, and the potassium is going to come out. So acidosis is associated with hyperkalemia. Alkalosis is associated with hypokalemia. So be aware of that. And then while we're talking about vomiting, I want to mention the anti-nausea drug called ondansetron. Maybe you've heard the brand name Zofran. There's another citron drug in the same category, which is granisetron. These are both serotonin antagonists, 5-HT3 receptor antagonists. Definitely make sure you know that. So when do we use these drugs? Well, primarily we use them in cancer patients who are undergoing chemotherapy and have nausea and vomiting because of the chemo. Or we can use them post-operatively to control post-op nausea and vomiting. These are also actually approved in pregnancy too. So in pregnant women that are having a ton of morning sickness, you might reach for these drugs. And then as for side effects, because this is a serotonin antagonist, you're going to have some vasodilation. That vasodilation can lead to headaches. Maybe you remember that for migraines, you can give a serotonin 1 agonist known as sumatriptan. So serotonin 1 agonists cause vasoconstriction to treat the headaches. Serotonin antagonists, like ondansetron, cause vasodilation, and that can cause headaches. Also, another side effect of ondansetron is constipation. Maybe you remember carcinoid syndrome, which is a tumor that produces vasoactive amines like serotonin. And one of the symptoms of carcinoid syndrome is diarrhea. So too much serotonin can cause diarrhea. If you give a serotonin antagonist, like ondansetron, you get constipation. All makes sense. Okay, go ahead and answer the end of session quiz, then we'll go through the answers together. Let's get going. First question, what are the two most common underlying causes of a hospital admission for bleeding peptic ulcer? So you have H. pylori and NSAIDs. Next, which antacid matches each of the following statements? May cause diarrhea is magnesium hydroxide. May cause constipation is aluminum hydroxide. May cause hypercalcemia is calcium carbonate. And may cause hypokalemia is actually all three of the above. Next, a patient taking NSAIDs for the management of her gout develops anemia, has pain with eating, and is positive on fecal occult blood test. What drug would most directly address the mechanism behind this patient's current problem? Well, the answer is misoprostol. This patient has an ulcer, right? But the underlying cause of the ulcer is that the NSAIDs are blocking prostaglandin production. So the drug that directly counteracts this is a prost drug, like misoprostol. And the last one, where is Firkos node located? That's a left supraclavicular lymph node that can indicate gastric cancer mets. Finally, let's go over these rapid-fire facts. If you see a mucin-filled cell with a peripheral nucleus, that's a signet ring cell that's seen in gastric cancer or LCIS. The most common type of stomach cancer is adenocarcinoma. An ovarian metastasis from a gastric cancer, again, is called a Krugenberg tumor. Gastric ulcerations and high gastrin levels, think about Zollinger-Ellison syndrome. Acute gastric ulcer associated with elevated intracranial pressure or head trauma is called a Cushing ulcer. An acute gastric ulcer associated with severe burns is a curling ulcer. All right, that's it for GI 4. I'll see you next time.
It's time for another warm-up review. Let's get going. Which enzymes do obligate anaerobes lack? So they lack catalase and superoxide dismutase. Next question, which Mycobacterium species fits each of the following descriptions? So first we have causes leprosy, so that's Mycobacterium leprae. Causes pulmonary TB-like symptoms in COPD patients, so that's going to be Mycobacterium kansasii. Causes a cervical lymphadenitis in children, so Mycobacterium cercophocium. Causes a disseminating disease in AIDS patients. That's going to be Mycobacterium avium intracellulare, or MAI, or Mycobacterium avium complex is the older version, or the MAC. Two different names for the same thing. And that hand infection in aquarium handlers, that's going to be Mycobacterium marinum. All right, guys, that brings us to the end of the review. Let's get to that video.
In this video, we're going to discuss the duodenum, or some people call it the duodenum. Or sometimes you'll hear people informally call it the dude, so that's what you call it, you know? That or his dudeness, or duder, or you know, El Duderino if you're not into the whole brevity thing. The first topic I want to review is a congenital malformation called duodenal atresia. Atresia means that some cavity or lumen failed to form. So with duodenal atresia, the gut tube failed to canalize. Duodenal atresia presents with bilious vomiting. Remember, pyloric stenosis causes non-bilious vomiting. But with duodenal atresia, the stomach empties into a little blind pouch. You can actually get bile into that little pouch, so the baby will present with bilious vomiting. The stomach will be distended, and you'll have something called a double bubble on x-ray, which is distension of the stomach with gas proximal to the pylorus, and then distal to the pylorus, where that blind pouch is, you have distension there as well. You should also know that duodenal atresia is associated with Down syndrome. Let's review some basic duodenal anatomy, especially how the duodenum comes together with the pancreas and the biliary tree.
So all these structures come together at the ampulla of Vater. The main pancreatic duct empties into the duodenum at the ampulla of Vater, and there's a sphincter muscle called the sphincter of Oddi that opens and closes and regulates the flow of fluids into the duodenum. So be sure you're familiar with those structures. Then up in the biliary tree, you have the common hepatic duct, which is draining bile that's produced in the liver. You have the gallbladder, and the cystic duct connects the gallbladder to the common bile duct. And then the common bile duct is draining bile into the duodenum, and again, through the ampulla of Vater. Now, if you clog up these ducts, that can be problematic. And several different things can clog these ducts. The first is sludging of the fluid. There's no stone necessarily, it's just thick, slow-moving fluid. We often call that biliary sludge. But gallstones can also clog up these channels and cause problems. We're going to talk about gallstones later on in the video on the biliary tract. And the third thing would be a pancreatic tumor, which can compress these ducts and cause problems as well. So if you have a pancreatic tumor that obstructs the common bile duct and causes jaundice, that may be the first sign that the tumor is there at all. And again, we're going to talk about that in another video. But say you had a patient with jaundice and you wanted to examine the biliary tree and the pancreatic duct for any obstruction. What type of procedure would you do? Well, that procedure is called an ERCP, an endoscopic retrograde cholangiopancreatogram. You go in with an endoscope down the esophagus and through the stomach to the duodenum, and then you inject contrast into the ampulla of Vater. When you look at this under X-ray or fluoroscopy, the contrast basically outlines the biliary tree. But unfortunately, this can cause a reversal of flow through the biliary tree because you're injecting contrast in a reverse direction, and that can sometimes cause temporary problems, including pancreatitis. But it usually doesn't cause any lasting problems.
The duodenum is where a lot of things come together. You have pancreatic enzymes and bile mixing with the food from the stomach to continue digestion. So it's important to be able to regulate all of that. So let's talk about hormonal regulation taking place in all this, starting with CCK. CCK is cholecystokinin, and it's secreted by the eye cells in the duodenum. And we talked about gastrin as being progastric. It helps the stomach do its thing. Well, you can think of CCK as being pro-duodenal. It tells the stomach, stop emptying, let us digest what we already have. So CCK decreases gastric emptying, and it increases pancreatic secretion, so you can digest carbohydrates and fats, and it stimulates gallbladder contraction, so you get a little bile in there to help emulsify the fats. Chole is bile, and cyst is a sac of fluid. So the cholecyst is the gallbladder. And then kinin has to do with movement, like kinetic. So cholecystokinin gets the gallbladder moving. It stimulates gallbladder contraction. There's another duodenal hormone called secretin, which is made by the S cells. And it facilitates secretion of bicarb by the pancreatic ducts to help neutralize the gastric acid. The gastric mucosa is designed to withstand the acidic environment, but the rest of the GI tract really isn't designed to withstand that acid. So you have to neutralize the acid, which is accomplished by the alkaline pancreatic juices and regulated by secretin. Secretin also reduces gastric acid production by inhibiting the parietal cells of the stomach. And then there's GIP, which is gastric inhibitory peptide. This is made by the K cells, and it also decreases gastric acid production. But it also plays an important endocrine role. GIP increases insulin release. And it's because of GIP that tissues take up glucose faster when you give glucose orally than when you give IV glucose.
So again, CCK, GIP, and secretin all help shut down gastric acid production and neutralize that acid in the duodenum. So let's pause for just a second to talk about another mechanism the duodenum has to counteract gastric acid. It's not just dependent on hormones and pancreatic bicarb. The duodenum also has submucosal glands called Brunner glands. And these secrete an alkaline mucus that neutralizes the gastric acid coming in from the stomach. So not only are your pancreatic duct cells making bicarb to neutralize stomach acid, the Brunner glands are also doing the same thing. So in cases where you have a lot of stomach acid coming into the duodenum, you're actually going to have hypertrophy of the Brunner glands because they're ramped up to make a lot of bicarb. Now, we alluded to this when we were discussing duodenal ulcers, where you have an excessive stomach acid production. You're going to see a compensatory hypertrophy of the Brunner glands. Now, these Brunner glands are only located in the duodenal submucosa. They're not found anywhere else throughout the GI tract. They're uniquely designed to neutralize stomach acid in the duodenum. Okay, back to our GI hormones. There's somatostatin, which basically shuts everything down. It shuts down the release of gastrin, CCK, secretin, GIP, VIP, insulin, glucagon. Somatostatin is the anti-hormone hormone. It's made by the D cells all through the GI tract, and it's also made by the delta cells in the pancreas. Now, one of the hormones that somatostatin shuts down is called VIP, or vasoactive intestinal peptide. VIP is made by smooth muscle cells in the gut, as well as by nerve cells in the parasympathetic ganglia and the enteric nervous system. And VIP relaxes smooth muscle and sphincters throughout the GI tract. Now, what do you think that's going to do? It's going to lead to diarrhea, especially copious watery diarrhea, because VIP also increases secretion of electrolytes and water in the GI tract. So if you have a tumor, a pancreatic tumor again, that produces a lot of VIP, we call that a VIPoma, and that's going to cause a high volume rice water diarrhea that looks a lot like cholera. And the last GI hormone I want to mention is called motilin. Motilin produces migrating motor complexes, which are huge peristaltic waves that go through your GI tract and help sweep everything downstream.
What happens when the gut isn't cooperating and there's no peristalsis? We call that an ileus. And this can occur postoperatively, or it can occur due to a stroke or septic shock or really any critical illness. So let's look in your study guide, and we're going to discuss some prokinetic drugs that help restore peristalsis and reverse an ileus.
So one way to get things moving through the gut is to increase acetylcholine. That makes sense. You're augmenting the parasympathetic nervous system. Another way is to increase serotonin. Remember, serotonin in excess causes diarrhea. So serotonin gets things moving through the gut. And then a third way is to decrease dopamine. So some specific drugs that we could use include cholinergic agonists like bethanechol. These drugs are going to mimic the actions of acetylcholine. Remember, the chol ending tells you it's a cholinergic agonist. Then you could use acetylcholinesterase inhibitors like neostigmine. They're also prokinetic because they increase the activity of acetylcholine that's already in the system. Another prokinetic drug is metoclopramide, which you may know by the brand name Reglan. Now, this is prokinetic for two reasons. First of all, it stimulates serotonin receptors, and it also inhibits dopamine receptors. Now, we sometimes give metoclopramide to diabetics with gastroparesis, which is kind of a paralysis of the stomach due to autonomic neuropathy. So if the stomach's not emptying very well, metoclopramide can be helpful for those patients. And metoclopramide can cause a couple of noteworthy side effects. It can cause seizures, and it can cause some drug-induced Parkinsonism because it's antagonizing dopamine receptors. And then finally, the macrolide antibiotics, particularly erythromycin, will stimulate smooth muscle motilin receptors. So sometimes you'll see erythromycin used in the ICU to promote GI motility, not as an antibiotic, but as a prokinetic drug. That's it for the duodenum, but I want to spend the last few minutes going over a little more GI anatomy. Let's talk about some of the GI ligaments that you need to know for your Step 1 exam, starting with the stomach. So the ligament that connects the greater curvature of the stomach to the transverse colon is the gastrocolic ligament. Most of these ligaments have very descriptive names, so it's no challenge to figure out what two structures it connects. The gastrocolic ligament connects the stomach to the colon. There's the gastrosplenic ligament, which connects what? It connects the greater curvature of the stomach to the spleen, gastrosplenic. Now, this is one of two ligaments you would need to cut if you were removing the spleen. Maybe the spleen was ruptured in trauma or because there was ITP or hereditary spherocytosis. So you would cut the gastrosplenic ligament and then also the splenorenal ligament, which connects the spleen to the posterior abdominal wall and the wall of the peritoneal cavity. Going back to the stomach, the ligament that connects the lesser curvature of the stomach to the liver is the gastrohepatic ligament. And if you needed to access the lesser sac during surgery, which is posterior to the stomach, you'd have to cut through the gastrohepatic ligament. That's also contiguous with the hepatoduodenal ligament, which connects the liver to the duodenum. And be sure you know that this ligament contains the portal triad, which is the hepatic artery, the portal vein, and the common bile duct. So if you need to control bleeding at the hepatic artery or the portal vein in a pinch during surgery, you might find this ligament and squeeze it to cut off those vessels. And then the last one is the falciform ligament. This is the only one that doesn't have a nice descriptive name. The falciform ligament connects the liver to the anterior abdominal wall.
It's also important to know which structures are truly abdominal, that is, the ones that are within the peritoneal cavity, and which ones are retroperitoneal. Now, our mnemonic for the retroperitoneal structures is a duck pair, not a pair of ducks, a duck pair. The A is for the adrenal glands, D is for the duodenum, the second, third, and fourth parts of the duodenum, not the first part of the duodenum. U is for the ureters, C is for the colon, so this is the descending and the ascending colon, but not the transverse colon. K is for the kidneys, and then for pair, P is the pancreas, everything except the tail of the pancreas. E is for the esophagus, at least the part of the esophagus that's below the diaphragm. Obviously, the upper esophagus is in the mediastinum. Then A is for the aorta and also the inferior vena cava, which runs right next to the aorta. And then R is for rectum. And it's definitely worth knowing that these structures are retroperitoneal. You can use the mnemonic, or you can kind of reason some of it out. You know that the retroperitoneal area is posterior to the abdominal cavity, so it must include posterior structures like the aorta and the kidneys. And if you know that the kidneys are retroperitoneal, it's easy to remember that the adrenal glands are retroperitoneal, and also the ureters. And if you remember that the majority of the pancreas is retroperitoneal, you can kind of reason out that the duodenum must be retroperitoneal too, because it kind of wraps around the head of the pancreas. Now, one last high-yield topic is to be able to recognize organs on a cross-section of the body, like a CT of the abdomen. Cross-sectional anatomy is about a 4-star topic. So let's look at a couple of CTs. First off, when you look at a CT, it's always oriented so that the patient is lying on his back and his feet are coming out of the image toward you. So this is the patient's right side, and this is his left side. Now I want you to ignore the asterisk and the arrows, which are showing some abnormalities. We want to focus on the normal anatomy. So it's easy to identify the vertebra here. These light-colored structures on either side of the vertebra are the kidneys, which are retroperitoneal, right? And what are these large black and white blobs here and here and here? These are loops of bowel. The black is gas, or air, and the white is oral contrast that the patient drank. So the contrast settles out to the dependent part of the bowels, and you can see these nice air fluid levels. Here's another CT, and this patient has a ton of abdominal fat. This largest structure on the patient's right side is the liver, and you can make out the gallbladder kind of tucked away with the liver. There's the stomach with another air fluid level and some contrast in it. And posterior to the stomach, you can make out the long, curving pancreas, which again is retroperitoneal. And there's the aorta adjacent to the vertebral column. And what's this round structure just to the right of the aorta? That's the inferior vena cava. And these paired structures posteriorly, those are the kidneys. And what's this? That's the spleen. And remember that the tail of the pancreas tickles the hilum of the spleen. You're very likely to see some CT scans on step 1, so go online and spend a little time practicing identifying all those abdominal organs. Now it's time for the end of session quiz, so pause the video and answer those questions, then we'll go through them together. First question, what important secretory products are secreted from the following cells of the GI tract? The G cells of the stomach secrete gastrin, the I cells secrete CCK, S cells secrete secretin, D cells secrete somatostatin, and the parietal cells of the stomach secrete both gastric acid and intrinsic factor. Next, what GI ligament matches each of the following descriptions? The ligament that contains the portal triad and may be compressed to control bleeding is the hepatoduodenal ligament. The one that attaches the spleen to the posterior abdominal wall is the splenorenal ligament. And the one that attaches the spleen to the stomach is the gastrosplenic ligament. Next, what's the mechanism of action of metoclopramide? Well, it's an antagonist at the dopamine D2 receptor, and it's also a serotonin agonist. It's going to increase contractility in the GI tract and kind of move things along. Are you making fun of my duck? This aggression will not stand, man.
Halt! Who goes there? I am the Pukinator, the ruler of regurgitation, the overlord of emesis, the supervisor of throw-up.
Supervisor? Nice one, Lewis. Dude, stay in character! Sorry.
I am the Pukinator, and your chemoreceptor triggers an instant no chance against my ferocious luxury. You do not frighten me, Pukinator, for I am ondansetron, the oldest and wisest of 5-HT3 serotonin antagonists. Curses, my oldest foe. That's right. Neither post-op nausea and vomiting or chemotherapy-induced vomiting shall stand a chance against the mighty power of ondansetron. Together with my brothers, granisetron and dolasetron, you shall be defeated. You will be forever banished from our peaceful planet.
No fair! You guys can't gang up on me! I'm gonna tell Mom! Mom? That's weird.
Let's go over the warm-up review. First question, which type of hypersensitivity is responsible for each of the following clinical problems? Asthma is a type 1 hypersensitivity. Positive TB skin test, or PPD, is a type 4 hypersensitivity. Allergies, anaphylaxis, and hay fever are all type 1. ABO blood type incompatibility is type 2. Poison ivy is type 4. Eczema is type 1. And Goodpasture syndrome is type 2. And the next question, what are the 4 obligate aerobic bacteria? So you might remember the mnemonic, nagging pests must breathe, which stands for Nocardia, Pseudomonas aeruginosa, Mycobacterium tuberculosis, and Bacillus species. Now you're all warmed up for the lecture.
Hey guys, Dr. Carmichael here, and we're going to be going over Step 1 GI6, enterocytes and absorption. We're going to be going over everybody's favorite topic, which is food. Today's lecture is going to focus on the small intestine and absorption. When we talk about digestion, we often start by talking about the stomach. Although an important organ in digestion, the stomach is terrible at absorption. It has tight junctions between its epithelial cells, and it lacks the very important villi, or the finger-like projections that are critical to the absorption ability of the small intestine. The villi and microvilli increase the absorptive area by nearly 1,000-fold. These villi are part of the all-important enterocyte. These are the primary intestinal absorptive cells. Not only are they critical for absorption, but they also contain digestive enzymes that also have a secretory role. Other high-yield histology structures you should know about are the crypts of Lieberkühn. These are located in the valleys between the villi. They are glandular and secrete various digestive enzymes as well. Let's cover some of the mechanisms that we go through in order to digest certain food types. How do we digest carbohydrates? We start digesting carbohydrates almost immediately when we take a bite of food. Salivary amylase begins the process of carbohydrate digestion in the mouth. Now, we don't generally keep food in our mouths for too long, so we have even more digestion occurring further down the GI tract. Pancreatic amylase hydrolyzes glycogen, starch, and most other complex carbohydrates to disaccharides. Disaccharides are broken down into monosaccharides by the intestinal brush border enzymes and absorbed. Monosaccharides are absorbed by a variety of mechanisms. Glucose and galactose are absorbed by sodium-dependent transport, and fructose is absorbed by facilitated diffusion. Next, let's move on to protein. Again, we see the beginning of protein digestion in the saliva. Protein is degraded to amino acids, dipeptides, and tripeptides by proteases produced by the pancreas. This is accomplished by converting trypsinogen to trypsin. This occurs due to autoactivation, or this can be activated by the intestinal brush border enterokinases. Trypsin will degrade the peptide bonds of arginine or lysine. Trypsin can also activate other proteolytic pancreatic enzymes. Dipeptides and tripeptides are absorbed through a hydrogen gradient. Single amino acids are absorbed through sodium-dependent transport. And though it seems counterintuitive, dipeptides and tripeptides are absorbed faster than single amino acids. Let's move on to fats. The breakdown of lipids actually starts in the mouth with salivary lipase. Lipids are further broken down in the stomach. Then pancreatic lipase hydrolyzes triacylglycerol to fatty acids and to monoacylglycerol. The pancreas is very important in fat digestion, and if you have chronic damage to the pancreas by pancreatitis, like gallstones or alcohol-caused pancreatitis, then you end up with deficiency in lipase and a problem with fat digestion. Next, in the process of fat absorption, bile salts emulsify the hydrolyzed products and formed micelles. Those micelles will get further broken down into triglycerides and cholesterol, and these get balled up into something called chylomicrons, which then can transport to the liver and further down the metabolism. I'm not going to go any further down in the lipid pathway. We have an entire lecture devoted to lipids, so stay tuned. Let's talk about iron. Where is iron absorbed? Iron is absorbed in the duodenum. There are multiple reasons that someone may have a problem with iron absorption. However, it is relatively uncommon cause of iron deficiency anemia. But if you get a question about iron deficiency anemia, you need to remember a couple of malabsorption problems. First, iron likes to get absorbed in an acidic environment, and they don't like things binding to it. Therefore, iron absorption will be impaired in the presence of antacids and certain antibiotics like quinolones and tetracycline. Even common things like cereals, dietary fiber, tea, coffee, eggs, milk can get in the way. Another common cause of iron deficiency anemia that is becoming more common is gastric bypass. If part of the duodenum is bypassed, then the iron cannot be absorbed. I've had gastric bypass patients with profound anemia that need iron IV infusions in order to get the iron to normal levels. Folate is absorbed in the duodenum and in the jejunum. Some review books say that the folate is absorbed in the ileum, but much more is absorbed in the duodenum and the jejunum. Most causes of folate deficiency are caused by poor nutrition and alcoholism, which is just poor intake. One potential question that you might get is an infant who is fed goat's milk exclusively. Babies may get folate deficiency because of goat's milk, because it has a lot less folate than cow's milk. Vitamin B12 is absorbed in the terminal ileum and requires intrinsic factor. So intrinsic factor, which is produced by parietal cells in the stomach, will bind to B12 in the duodenum, and then that complex is absorbed in the terminal ileum. B12 deficiency is a big cause of megaloblastic anemia. So what causes B12 deficiency? Malnutrition can cause it, but it can also be caused by decreased absorption. Pernicious anemia is an autoimmune destruction of the gastric parietal cells. Without parietal cells, there is no intrinsic factor, and without intrinsic factor, there is no absorption of B12 in the terminal ileum. Next, we're going to talk about A-beta lipoproteinemia. This is a rare autosomal recessive disease. It is a lack of apoprotein B leading to defective chylomicron assembly. ApoB48 is an important marker that gets attached to chylomicrons, and that allows the chylomicron to leave the enterocyte. So, if you can't make ApoB, then the enterocyte is just going to fill up with chylomicron particles and become a fatty enterocyte. You also see abnormal star-shaped red blood cells called acanthocytes. So, if all the chylomicrons can't leave the enterocytes, then at some point these enterocytes stop absorbing fat from the GI tract. This will present in early childhood as steatorrhea, malabsorption, and especially of the fat-soluble vitamins A, D, E, and K. Symptoms occur in the first few months of life as failure to thrive and neurological manifestations like ataxia. This is a high-yield topic. Give it 4 stars. Next, we're going to talk about celiac disease. Now, this is an autoimmune disorder of the small intestine leading to intolerance of gluten, or wheat. When a patient with celiac disease eats wheat, then a reaction occurs where the wheat protein cross-reacts with small bowel tissue and inflammation occurs. Patients produce antibodies to gluten and to tissue transglutamase. The result is blunting of the villi and microvilli. Now the patient has impaired absorption, which leads to foul-smelling, pale stools, stunted growth, and even failure to thrive. Luckily, the symptoms subside when gluten is removed from the diet. And important for testing is that it is associated with HLA-DQ2 and DQ8. Celiac disease has been associated with increased risk of T-cell lymphoma and GI and breast cancers. Next, let's talk about some enzyme deficiencies. The most common one is lactase deficiency. Lactase breaks down lactose into glucose and galactose. Lactose cannot be absorbed in the small intestine. If not broken down, then bacteria in the colon will metabolize lactose, and the resulting fermentation will produce copious gas. So, lactase deficient patients will present with bloating, cramping, and diarrhea. Lactase enzyme is located in the very tip of the microvilli. So, if a patient has gastroenteritis, then blunts the microvilli, then the patient might develop a temporary lactase deficiency and then not be able to digest the lactose. If a patient does have a permanent lactase deficiency, then they can choose to avoid lactose or You can eat lactose with supplemental lactase enzyme. And the most common one over the counter is Lactaid. Next, we're going to talk about tropical sprue. Students will often get this confused with celiac disease or celiac sprue. We're not completely sure what causes it, but we think it's infectious. It again affects the small intestines and looks a lot like celiac sprue, but it can affect the entire small bowel, where celiac disease likes to stay in the more proximal part of the small bowel. You can see vitamin deficiencies and megaloblastic anemia. It does not get better with gluten removal, but it does tend to improve with antibiotics. And next is Whipple's disease. This is a systemic disease with Trophorema whippeli, gram-positive bacteria. Symptoms include weight loss, lymphadenopathy, hyperpigmentation. Patients can also have cardiac symptoms, arthralgias, and neurological symptoms. You also see these PAS-positive foamy macrophages in the intestinal lamina propria. These macrophages are laden with T. whippeli. Patients are most often older white males. Treatment is with penicillin, ampicillin, or tetracyclines, and you have to take it for 1 to 2 years. This is a very long course of treatment, lasting less than a year, has a relapse rate of 40%. Next, we're going to talk about pancreatic insufficiency. This can be due to chronic pancreatitis, cystic fibrosis, or something obstructing the pancreatic duct like gallstones or cancer. Clinically, you see fat malabsorption. Patients will have steatorrhea and poor absorption of the fat-soluble vitamins like A, D, E, and K. But that's it for this lecture, guys. Let's move on to the end of session quiz. Now for the end of session quiz. What serum antibodies are associated with celiac disease? Antibodies to tissue transglutamase and gliadin. What is the treatment for celiac sprue? A gluten-free diet, so you have the patient avoid rye, wheat, and barley. What organism is associated with Whipple disease? That's Trophorema whippeli. What pathology of the small intestine is most closely associated with the following statements? Small intestinal mucosa laden with distended macrophages in the lamina propria. This is Whipple disease. Defects in the chylomicron exportations, that's A-beta lipoproteinemia. Cramping associated with milk products, that's lactase deficiency. That's it for the end of session quiz. Now for a couple rapid fire facts. Number 1, weight loss, diarrhea, arthritis, fever, adenopathy, and hyperpigmentation, that's Whipple's disease. Number 2, anti-transglutamase and anti-gliadin antibodies, that's celiac disease. Vitamin given to pregnant women to prevent neural tube defects, that's folic acid. And that's it for GI6, guys. We'll see you at the next one.
Let's go over the warm-up review. First question. A 2-year-old boy is hospitalized for Haemophilus meningitis. His mother is started on a prophylactic antibiotic. 2 days later, the mother calls the clinic complaining of blood in her urine. So what's the most likely cause of her symptoms? Well, this is most likely not blood in her urine, but orange urine from rifampin. Most USMLE questions are going to be more straightforward than this, but you might see a few that require you to kind of connect the dots. So you have to know that one of the common prophylaxis regimens for Haemophilus meningitis is rifampin. You have to know that rifampin will turn secretions like tears and urine a reddish-orange color. And you have to know that in patients who report blood in the urine, the differential includes things like rifampin or excessive ingestion of beets, in addition to things like UTI and kidney stones and bladder cancer that actually do cause blood in the urine. Just because the patient says it's blood doesn't mean it really is blood. So again, this is most likely red urine caused by rifampin. Next, which immunosuppressant fits each of the following descriptions? So the prodrug of 6-mercaptopurine is azathioprine. The drug that causes phocomelia is thalidomide. Nephrotoxic in 75% of patients is cyclosporin. Side effect of acne, osteoporosis, hypertension, hyperglycemia, and immunosuppression leading to infection would be glucocorticoids like prednisone. Now, we didn't talk about glucocorticoids as immunosuppressants back in immunology, but they definitely do suppress the immune system somewhat. And then inhibits the secretion of IL-2 and other cytokines is tacrolimus and also cyclosporin. The last one. What hematologic changes would be seen in a patient without a functional spleen? So you can see thrombocytosis because the platelets aren't being sequestered in the spleen anymore. You might also see Howell-Jolly bodies in the red cells and some target cells. I don't know that we talked about that when we discussed the spleen, but we're definitely going to cover that in hematology. So now let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on diseases of the small intestine. Now this lecture makes me alternate between constipation and diarrhea. Try to figure out where in the lecture this happens. Alright, let's get going. So this lecture deals with the diseases of the small intestine. We'll be going through quite a few diseases today. We'll hit the definition, the clinical presentation, and how to diagnose these pathologies. Now, one disease that is conspicuously absent is Crohn's disease. We're going to pair that with ulcerative colitis, which is found in the large intestine lecture. Therefore, don't worry, we didn't forget about Crohn's. We'll just see it later. So first, let's hit IBS, irritable bowel syndrome. We're going to be looking at our study guide a lot today as well. So irritable bowel syndrome, clinical presentation. So think of someone with chronic abdominal pain, altered bowel habits. And that abdominal pain is usually described as crampy with variable intensity, which improves with defecation. That's a big one. So if it resolves or improves with defecation, think of IBS. Altered bowel habits include diarrhea. They can be diarrhea predominant, it can be constipation predominant, or it could be just this alternating diarrhea and constipation. Other GI symptoms, they can have GERD, they can have dysphagia, they can have early satiety, nausea, and chest pain. Non-GI symptoms as well, they might have urinary frequency, they might have urgency, dysmenorrhea, dyspareunia, and even fibromyalgia type symptoms. Now, not associated with IBS, so if they have rectal bleeding, if they have nocturnal abdominal pain, weight loss, anemia, elevated inflammatory markers, electrolyte abnormalities, that is not IBS typically. Now for the treatment, well, a lot of things. Some of it's a bit hit and miss. Dietary modification, you might want to avoid things like lactose or gluten if that helps. Maybe some level of fiber supplementation. Antispasmodic medications, so think of dicyclomine, hyoscyamine is another one as well. Antidepressants sometimes can help TCAs, SSRIs. And then the guanylate cyclase agonist, so IBS with predominant constipation, those type of medications can be helpful. Let's move on to Meckel diverticulum. Meckel diverticulum is the most common congenital anomaly in the GI tract, and it results from the incomplete obliteration of the omphalomesenteric duct, also referred to as the Vitellin duct. Now, when you think about Meckel diverticulum, I want you to think about the 5 twos. So what are the 5 twos of Meckel's diverticulum? First is the size of the diverticulum, which is about 2 inches. The distance from the ileocecal valve is 2 feet. It occurs in 2% of the population. The more common presentation is within the first 2 years of life. And then there are 2 types of tissue that might be found. You might see pancreatic epithelium and you might actually see gastric epithelium. However, realize that some Meckel diverticula have neither of these types of tissue. Now, Meckel can cause melena, right lower quadrant pain, intussusceptions, volvulus, and even obstruction. Now, the diagnosis can be tough, but it can potentially be made by giving technetium, which has an affinity for gastric mucosa. You then perform scintigraphy to identify areas of ectopic gastric mucosa. So if you see gastric mucosa outside of the stomach, that's not normal, and you might have to consider that diagnosis of Meckel diverticulum at that point. Moving on to intussusception. Intussusception is telescoping of the small bowel onto itself. Now, it is the most common abdominal emergency in children younger than 2 years of age. Now, it occurs near the ileocecal junction. Now, 75% of cases are idiopathic, but the other 25% are triggered by viruses, more specifically the adenovirus, and also with Meckel diverticulum that we just talked about as well. Now, it's very unusual in adults. Now, the classic buzzword for intussusception is current jelly stool. Patients will present with the sudden onset of severe abdominal pain. They'll have vomiting and then this grossly bloody stool as well. Now, ultrasonography is used for diagnosis, and this can sometimes be described as a bullseye or a coiled spring appearance. So remember those for testing. So now let's move on to small bowel obstruction and some of the things that can cause small bowel obstructions. And this is going to be in your study guide. What are the common causes of SBO? So there's a great mnemonic, which is just ABC. So A is for adhesions, and that's usually from previous surgeries. About 75% of the time, small bowel obstruction is due to some level of adhesion. B is for bulge, and that's supposed to make you think of hernia, which is the second most common cause. Now, inguinal hernias can become incarcerated, which means that whatever is is herniating through the defect in the muscle wall cannot be reduced back into the abdomen. This can lead to infarction or strangulation of a segment of bowel, which will result in severe pain, bleeding, and will require immediate attention, and all that can cause obstruction. And then C is for cancer and other tumors. Classically, it's colorectal cancer that's causing the obstruction, but other cancers can cause this as well. Now, other less common causes of SBO include things like volvulus, intussusception, Crohn's disease, gallstone ileus, so that's where a gallstone obstructs the lumen of the small bowel, and then also a Bezoar is another interesting thing. A Bezoar is a kind of conglomeration of material, kind of gross. Typically, it's cellulose material that obstructs the small bowel because it's not properly digested. It's a big ball of ugh. Bowel wall hematoma from trauma can cause this as well. Inflammatory stricture, congenital malformation, radiation enteritis, all of these can again cause that small bowel obstruction. And then on X-ray, you're going to have dilated loops of bowel. Let's move on here. We just mentioned adhesions in the previous section here with small bowel obstruction. Adhesions are fibrous bands that form between tissues and organs. They occur frequently after abdominal surgeries. Now, this is the most common cause, again, of that small bowel obstruction. Sometimes surgeons can go in and lyse those adhesions, but with any subsequent surgery, you can develop even more adhesions, so we don't go in very often to do this. Moving on to intestinal ileus. So we just talked about some of the structural reasons for a small bowel obstruction, but there are some other reasons for the bowel to stop working. So with ileus, you have lack of peristalsis in the GI tract. Oftentimes, patients will present with this after surgery or if they are severely ill. So what's causing this? Well, when you're very sick, the body kind of preferentially diverts blood flow, energy and resources to the areas that really need it. Think of the heart and the brain, and the guts get kind of left out a little bit. So there's a lot of ileus in the ICU and in that post-op floor. And basically, you're just waiting around for it to come back. Next, we're going to talk about the meconium ileus. We know what an ileus is, just when you lose that peristalsis, where the gut is no longer working correctly or is obstructed. Meconium is the very first stool of an infant. So this is black, sticky, nasty stuff that comes out as the baby's first poo. Now, when you're a third-year ped student, you'll be in the nursery and it'll be the bane of your existence. Opening a diaper is like a game of Russian roulette. It's like, oh. Now, most of the time, meconium is passed within the first few days after birth. If it doesn't happen, then that's going to be abnormal. So causes of this meconium ileus include that cystic fibrosis and Hirschsprung disease. So on your test, if you see a meconium ileus, think of those two problems, cystic fibrosis, Hirschsprung disease. And we'll cover those in more detail in other lectures as well. Moving on to necrotizing enterocolitis. So this is seen in premature infants where the bowel undergoes necrosis. Symptoms will include feeding intolerance, increased gastric residuals, abdominal distension, and bloody stools, and it can even result in perforation and death. Now, diagnosis is suggested by plain film findings of dilated loops of bowel, paucity of gas, and pneumatosis intestinalis. So that's where you have presence of gas within the wall of the small or large intestine. Now, the pathogenesis is not certain, but occurs in premature infants, and 90% are found in infants that are fed orally. Therefore, some have theorized that feeding premature infants too quickly or too early could be a major risk factor. So these patients will need bowel rest, which may require parenteral nutrition, so getting nutrition through the IV. Moving on to intestinal ischemia. So this one can actually have some tricky terminology. Students get tripped up on the difference between mesenteric ischemia and ischemic colitis. So they are often used interchangeably. Now, generally speaking, mesenteric ischemia is referring to ischemia of the small intestine. Ischemic colitis is referring to ischemia of the large intestine. Now, I think where the confusion arises is that there is a little bit of overlap between these supplying arteries. Now, the superior mesenteric artery supplies the small intestine primarily and up through about 2/3 of the transverse colon. And then the inferior mesenteric arteries are going to supply the rest of the large intestine. Now, damage and even necrosis of the bowel can occur from inadequate blood supply. And that inadequate blood supply occurs more often in the watershed areas where there are fewer collateral arteries. And the most common areas are going to be in that splenic flexure. Now, the decrease in blood flow can result from splenic vasoconstriction, acute arterial occlusion, venous thrombosis, or hypoperfusion of the mesenteric vasculature just in general. Now, there is also a chronic form of mesenteric ischemia that is due to atherosclerosis, and then this intestinal ischemia in general is going to occur a lot more often in elderly patients. So patients will present with abdominal pain that is out of proportion to their exam. So they are writhing in pain, but their exam is relatively normal. They're not that tender. Now, the severity can vary depending on the degree of ischemia. Patients with more chronic disease may complain of pain after eating. Now, labs are usually nonspecific, but you might see an elevated white blood cell count that might be associated with more severe disease. Plain film x-rays may show dilated loops of bowel, bowel wall thickening maybe, and diagnosis is usually made by a CT angiogram. You have to look at the arteries. Now, treatment will depend on the underlying pathology. If the patient has a venous thrombosis, then anticoagulation might be needed. If this is due to arterial embolism, then early surgical laparotomy with embolectomy is the first-line treatment. Now, if this is a non-occlusive mesenteric ischemia caused by maybe vasoconstriction, then you might want to look and remove any drugs that could cause vasoconstriction. And then if there is bowel necrosis, then surgical resection will be needed regardless of the cause. Now, one way that this might show up on your test, think of maybe a man coming in with pain in his abdomen about 30 minutes after eating. An EGD and colonoscopy have been done and are both normal. He has strong history of CAD, coronary artery disease, and the answer here is going to be that ischemic bowel. So if a patient has atherosclerosis in the coronary arteries, then he or she could also have atherosclerosis of the arteries supplying the bowel. All right, so before we move on, let's do a quick Lewis Notes. All right, everybody, on this Lewis Notes, we're going to be looking at our small bowel diseases. This is going to be a little bit easier than maybe some of our other Lewis Notes, but still important. Write them down if you can. First one we have here is improved with defecation. That one's going to go along with our IBS. Current jelly stool, doesn't that sound awesome? Current jelly stool is going to be that intussusception, so that can be turning really bad really quickly with all that blood. Pain out of proportion, that's going to be out of proportion to exam, and that's when you're going to have that ischemic colitis. So they're losing oxygen to their bowel and it hurts a lot, especially worse when they're eating. Gastric and pancreatic epithelium, remember that's going to be that Meckel's diverticulum, and you can do that scan to look for that gastric epithelium. Pneumatosis intestinalis, so that's going to get air in the wall of the bowel wall. Remember, that's going to happen with our necrotizing enterocolitis. Next, we have alternating diarrhea and constipation. That's going to go along with our IBS. Again, we'll put that up there. Caused by cystic fibrosis and Hirschsprung. So remember, this is going to be our meconium ileus. So if they haven't had their first poop, then think of those two diseases. Next, we have bullseye on the ultrasound. So remember, if you have something that's telescoping, that might kind of look like a bullseye. So that's going to go under intussusception again. Caused by adhesions, and it's not the only thing that causes small bowel obstruction, but caused by adhesions is a big one. And then common in the post-op and also things in like the ICU when people are really, really sick, that's going to be that intestinal ileus where the bowel just stops working. Okay, guys, that's going to be it for our small bowel diseases. So next, let's move on to angiodysplasia. So this is a small vascular malformation in the gut. And these vessels tend to bleed. So it is a common cause of otherwise unexplained GI bleeding and even anemia. So these malformations are often found in the cecum or the ascending colon. Diagnosis can be with colonoscopy to directly see that bleeding area. If you can't find it, then you may consider using angiography to find the bleeding. And these are more common, again, in older patients. Moving on to carcinoid tumors. So this is a neuroendocrine tumor, and because it's a neuroendocrine tumor, it likes to secrete hormones. So which hormones, you may ask? Well, it likes to secrete things like histamine and prostaglandins, but you'll probably want to remember it more for secreting serotonin. So these tumors are found in the small intestine, and they make up about 50% of small bowel tumors. Now, they are most often found in the appendix, the ileum, and the rectum. Also, strangely enough, you find these tumors in the lung. Now, symptoms are going to be consistent with an excess of serotonin. So at that point, we actually have what's called carcinoid syndrome. Now, one mnemonic that you might want to use is BFDR. So the B is for bronchospasm, F is for flushing, D is for diarrhea, and R is for the right-sided heart murmur. So carcinoid syndrome results in deposits on the heart valves. Now, you're only going to see these symptoms if the carcinoid tumor is outside of the GI tract, because if the hormone is secreted in the GI tract, then it gets absorbed and then the liver will metabolize all the serotonin and then no effect will be felt. But if the tumor metastasizes out of the GI tract, or if it starts in the lung, then you can see the carcinoid syndrome symptoms because the liver is not catching all of that serotonin before it hits the circulation. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those on your own, and then we'll go through them together. First question, what intestinal disorder is common in the NICU to premature babies that receive oral feeds too soon? So you got to think about that necrotizing enterocolitis. Next, what are the common causes of small bowel obstruction? So the most common cause is going to be adhesions. Other common causes would be things like hernias or tumors. Next, what are the classic symptoms of carcinoid syndrome? So remember our mnemonic was BFDR. So we got bronchospasm, flushing, diarrhea, and then those right-sided valvular heart disease things. You might see things like edema or ascites with that. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the answers to the warm-up review. First question, which heart defect is associated with each of the following disorders? So chromosome 22q11 deletion is associated with tetralogy of Fallot, or possibly truncus arteriosus. Down syndrome is associated with endocardial cushion defects, like ASD, VSD, or an interventricular septal defect. Congenital rubella is associated with a PDA, or pulmonary artery stenosis, and possibly septal defects. Turner syndrome is associated with coarctation of the aorta, aortic root dilation, and also a bicuspid aortic valve. And then Marfan syndrome is associated with aortic regurgitation. Next, what 4-drug regimen is used to treat tuberculosis? So the mnemonic is RIPE, which stands for rifampin, isoniazid, pyrazinamide, and ethambutol. And the last question is, where are B cells and T cells found in the spleen and in the lymph nodes? So B cells are found in the follicles of both the spleen and the lymph nodes. And then T cells are found in the P structures. So in the spleen, T cells are found in the PALS, the periarterial lymphatic sheath. And in the lymph nodes, T cells are found in the paracortex. Now let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on the large intestine part 1. I hope you had your fiber today, because if you're not regular, then what are you? Today's lecture, much like my bowel movements, is short and satisfying with very little straining. Today we'll be discussing the large intestine, including Hirschsprung disease, volvulus, appendicitis, and then we'll end with some anatomy involving the pectinate line. So let's get going. So let's start with Hirschsprung disease. So in order to fully understand Hirschsprung disease, you actually have to know just a little embryology. The main thing that I want to point out is that your neural crest cells are an essential part of your large intestine. Even the most terminal parts of your large intestine require neural crest cells. And if you don't have those neural crest cells migrating to the terminal portions of the large intestine, what's going to happen? Well, you get Hirschsprung disease. So Hirschsprung disease is due to a failure of that migration of the neural crest cells. So Hirschsprung disease causes a congenital megacolon because you lack the Auerbach and the Meissner plexuses in these segments of the distal colon. And as a result, you can't produce normal peristaltic waves, which will help expel feces from the colon. And the classic presentation is meconium ileus, so a baby who doesn't pass their very first meconium. Now, Hirschsprung can present as a meconium ileus, or in less severe cases, they might just get chronic constipation and abdominal distension early on in life. Now, what other scenario might have that meconium ileus as well? You should probably remember this. Remember, also cystic fibrosis can do this as well. Now, patients with Down syndrome are at an increased risk of Hirschsprung disease. Patients with Down syndrome are at a higher risk of several different GI problems. So let's go through that right now as well. So what are those GI problems associated with Down syndrome? So Down syndrome is associated with duodenal atresia, and we just said it's associated with Hirschsprung disease, annular pancreas, and it's also associated with celiac disease. So there are 4 conditions that are associated again with that Down syndrome: duodenal atresia, Hirschsprung disease, annular pancreas, and celiac disease. Now there's a nice mnemonic for this as well. GI problems associated with Downs, that's going to be don't have a clue. So D for duodenal atresia, H for Hirschsprung, A annular, C for celiac. Let's move on to volvulus. So volvulus is a twisting of the colon around its mesentery. Now it can typically going to occur at the cecum or the sigmoid colon. And this is important because that twisting potentially can interrupt blood flow. It cinches off that blood flow in the same way that maybe if you think about the twisting of a water hose, kind of cinching off the flow of that water. And it's going to potentially cause bowel obstruction, but even worse, as we said before, it can cause ischemia, which results in infarction and death of that portion of the colon. So this usually is going to occur in our elderly patients, especially elderly men. Now patients will present with kind of a slowly progressive abdominal pain that can become quite severe with signs of intestinal obstruction, things like constipation, nausea, and vomiting. Patients may have a distended and maybe even a tympanic abdomen that is tender to palpation. Diagnosis is confirmed with an abdominal CT scan. Findings may include distended loops of bowel proximal to the volvulus. There can also be a kind of a whorl pattern observed as well. Now on the abdominal plain film, if you get one of those, that x-ray might actually show what's called the double bubble, which is air proximal and distal to the volvulus. Treatment is initially with a sigmoidoscopy to detorse that volvulus. So you can actually push a scope through the sigmoid colon where that twisting is and then actually untangle, so to speak, that volvulus. Then potentially a definitive surgery is performed to help prevent recurrent volvulus. Now resection of dead bowel might be necessary with a reanastomosis. Let's move on to appendicitis now. Appendicitis is inflammation of the appendix, usually secondary to obstruction. So in adults, there can be obstruction due to something like a fecalith. So that's a hard kind of stone-like lump of feces. So in the same way that you can obstruct the gallbladder with, say, a gallstone, you can actually obstruct the appendix with a fecal stone, and that's going to cause your appendicitis. In pediatric patients, a more common scenario is that they get a viral infection, and that leads to hyperplasia of the lymphoid tissue, which obstructs that tiny appendix. So your appendix actually houses part of your immune system, the mucosal-associated lymphoid tissue, referred to as the MALT tissue. So in kids, that appendicitis, again, very common reason for emergency abdominal surgery. So patients will present initially with periumbilical pain, and that's actually going to migrate to the right lower quadrant. Patients will have nausea and vomiting, anorexia, all that type of stuff. Fever will actually present maybe a bit later in the course. Now remember the famous McBurney points. Remember, it's 2/3 of the distance from the umbilicus to the right anterior superior iliac spine. Now patients with perforation or severe disease will have rebound tenderness, indicating inflammation of the peritoneum. Now remember your signs. So first we had that psoas sign. That's the right lower quadrant pain on passive hip extension. And then Rosvig sign is the right lower quadrant pain with left lower quadrant palpation. Now actually no one is using the obturator sign anymore, so you can actually stop memorizing that one. Now diagnosis can be clinical if the patient has a very typical presentation, including that right lower quadrant pain, rebound tenderness, and anorexia. You can take a patient directly to the OR potentially with this clinical picture if you have a well-experienced surgeon. More often the diagnosis is confirmed with a contrasted CT. Findings that suggest an appendicitis include an enlarged appendix, appendiceal wall thickening, periappendiceal fat stranding, or an appendicolith. Now the arrows in this CT image are pointing to an inflamed appendix measuring about 14 centimeters long, and the walls are thickened. An ultrasound can potentially be used, but you're really just going to be able to confirm the diagnosis of appendicitis. It's not really reliable enough to rule out an appendicitis with an ultrasound, though we do use it a little bit more often in children. Now labs are really only used to support the diagnosis. Patients might have an elevated WBC count. Never forget though to get a pregnancy test in all of your childbearing aged women. An ectopic pregnancy can certainly present similarly to an appendicitis. Now treatment is going to be preoperative hydration and antibiotics. You can use things like cefoxitin, or you could use the combo ampicillin with sulbactam. There's a couple others as well that you might use. And then of course you need to surgically remove the appendix. All right, so now let's move on to the pectinate line. We're moving down into the anal region. Now there's a very distinct line that demarcates where your endoderm ends and your ectoderm of your skin begins, and that is called the pectinate line. So let's talk about this. Well, proximal to the pectinate line, you still have what's called endoderm. Hemorrhoids that arise proximal to the pectinate line are called internal hemorrhoids. That's probably our most classic clinical presentation of why this is important. Now, luckily, structures above the pectinate line don't have a lot of sensation. So whenever you have internal hemorrhoids, you can do outpatient banding procedures of internal hemorrhoids. And then when that area becomes ischemic, the hemorrhoid just kind of falls off and it's gone. You actually can't do that with an external hemorrhoid below the pectinate line because that would be excessively painful. So internal hemorrhoids are not painful, but they can bleed. Now, the arterial supply above the pectinate line is from the superior rectal artery, which comes from the inferior mesenteric artery. Venous drainage above the pectinate line goes to the superior rectal vein, into the inferior mesenteric vein, and then into the portal system. Now, if cancer develops in this area, then it will most likely be an adenocarcinoma, again, above the pectinate line. Now let's talk about what happens distal or below the pectinate line. Here is where you have those external hemorrhoids. And here, because you have a squamous cell tissue, if a cancer develops, it's going to be a squamous cell cancer rather than adenocarcinoma, what we talked about before, above the pectinate line. And what is the biggest risk factor for squamous cell cancer in the anal region? Well, it's HPV, human papillomavirus, specifically types 16, 18, and 31. Again, distal to the pectinate line, the arterial supply is no longer the inferior mesenteric artery. Now, the arterial supply is the inferior rectal artery, which is a branch of the pudendal artery. And the venous drainage goes to the inferior rectal vein, and then to the internal pudendal vein, then the internal iliac vein, and then all the way up to the IVC. And because this ectodermal tissue has somatic innervation, these external hemorrhoids, again, are very painful. You wouldn't want to ban them, and they're going to require some type of topical numbing medicine for symptomatic relief in patients. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those on your own, and then we'll go through them together. All right, first question here. What is the classic presentation of appendicitis? So remember, classically, it starts off with diffuse kind of periumbilical pain, and then that pain is going to migrate to the right lower quadrant, remember, at McBurney's point. Patients may also have fever and nausea, those types of things. Next, what is the fundamental problem in Hirschsprung disease? So remember, it's the neural crest cells are going to fail to migrate to the colon, so the patient is missing the enteric ganglia or the enteric nerve plexus. So remember, you're not going to have Auerbach or the Meissner plexus. Next, where in the distal GI tract does endodermal tissue make an abrupt transition to tissue derived from surface ectoderm? Remember, that's the good old-fashioned pectinate line. Okay, so that's it for the end of session quiz. Now let's go over some rapid fire facts. So first we have the most common surgical emergency. That's going to be an appendicitis. And then severe right lower quadrant pain with rebound tenderness. So think of that McBurney point seen in appendicitis again. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Straighten up, you pathetic pains in my butt! You! What are the two types of hemorrhoids?
Internal and external, sir.
Very good! How are these two types differentiated?
The location?
More specifically, their position with respect to the what?
The dentate line?
Yes! The dentate or pectinate line, which divides the upper 2/3 and the lower third of the anal canal. Which of these two are more painful?
External, sir, as they are innervated by cutaneous nerves. Internal hemorrhoids are innervated by visceral nerves and therefore lack pain receptors, sir.
Very good. Now, if only there was some sort of cream to get rid of you! Now get out of my sight!
Oh, God.
Let's go over the warm-up. First question, which cytokines are secreted by the two different types of helper T cells? So the main ones I want you to know are that T helper 1 cells make IL-2 and interferon gamma, and T helper 2 cells make IL-4, IL-5, and IL-10. Next, what are the 5 classes of medications used to treat glaucoma? So we have alpha agonists, beta blockers, certain diuretics, including acetazolamide and then also mannitol for acute glaucoma, cholinergic agonists, and then also prostaglandins, specifically prostaglandin F2 alpha. The last question, damage to which nerve causes each of the following upper extremity symptoms? So wrist drop would be the radial nerve, scapular winging is the long thoracic nerve, inability to wipe your bottom is the thoracodorsal nerve, loss of forearm pronation is the median nerve, weak external rotation of the arm is the suprascapular nerve, loss of elbow flexion and forearm supination is the musculocutaneous nerve, and then loss of wrist extension is the radial nerve. Now let's get started with the lecture.
Hey guys, Dr. Carmichael here, and we're going to be going over Step 1, Video 2 on the large intestine. This is the sequel to the critically acclaimed Large Intestine 1. This will be the dark middle chapter of the trilogy where we find out that villus adenoma is actually tubular adenoma's father. I bet you didn't see that one coming. Now in this lecture, we'll be covering tumors, things growing in the colon, and some of these are not so bad and others are really bad. So let's move on to much more common types of colonic neoplasm, which is the colonic polyp, and then we'll move on to discussion about colon cancer. Colon polyps can occur anywhere in the colon. The most common type of polyp is a hyperplastic polyp. Typically, you're going to find these in the rectum or the rectosigmoid area. More than 50% of them will be located in those areas. This is not a neoplastic polyp, it is hyperplastic. These do not have precancerous risk. Not all colon polyps increase your risk of cancer. Hyperplastic polyps are completely benign, but you're going to remove them anyway because you can't tell they are hyperplastic until you look at them under a microscope. So let's turn our attention to the neoplastic polyps, which are the adenomatous polyps. These can increase our risk of cancer. There are three main types of adenomatous polyps: tubular adenomas, tubulovillous adenomas, and villus adenomas. And all three types can be precancerous, but the villus adenoma is the most villainous. It is the most precancerous, but any of these adenomatous polyps can be precancerous. So after you remove them, they need to go for analysis to make sure there is not any adenocarcinoma in situ, or adenocarcinoma that's broken through the basement membrane. So again, the more villous the polyp, the more likely it is going to be malignant. But even the tubular adenomas may have a malignant potential and need to be removed. Here, a tubular adenoma, and you can see that the tubular glands have cells that have darker nuclei and some atypia. This is a villus adenoma, which shows these finger-like projections, or villi, rather than a lot of glands, like we saw in the tubular adenoma. Now, most common polyps occur in adults, especially older adults, but kids can sometimes have them too. We call these juvenile polyps. If they occur at all, they usually happen in very young kids, and they are mostly found in the rectum. If there's only one polyp, there's no malignant potential, but there's something called juvenile polyposis syndrome, where they have multiple polyps, and that does increase the risk of adenocarcinoma. Another syndrome to be aware of is Peutz-Jeghers syndrome. This is an autosomal dominant disorder where the patient grows multiple benign hamartomas. What is a hamartoma? It's normal tissue that's endogenous to the site where it came from. It's just excessive amount of accumulation of that normal tissue. So with Peutz-Jeghers syndrome, there grow lots of hamartomas in the GI tract. They have hyperpigmented areas in the lips and mouth and on the hands and on the genitals. And Peutz-Jeghers is associated with increased risk of colorectal cancer. What are the other malignancies associated with Peutz-Jeghers syndrome? Well, you can have small intestinal tumors, stomach cancer, pancreatic cancer, breast cancer, ovarian cancer, uterine cancer. Overall, the cancer risk is about 50% in the 6th decade of life. So 50% of patients with Peutz-Jeghers syndrome are going to have cancer somewhere in one of those areas by the time they're in their 50s. Now, let's talk about colon cancer. Adenocarcinoma of the colon. It's the third most common cancer in both men and women in the U.S., and it's the third most common cancer killer of both men and women. Most of these patients are over 50 years old, which is why we start screening colonoscopies at the age of 50. So, what are some of the gene mutations and molecular pathways that lead to colorectal cancer? You can find yourself falling down the rabbit hole pretty quickly with colorectal cancer molecular pathogenesis. We are going to cover the high-yield oncogenes and tumor suppressor genes. These are two primary pathways that lead to colorectal cancer that I think you should know. First is the chromosomal instability APC pathway. In this pathway, there is a series of gene mutations that allow for progression to colorectal cancer. This is not just one mutation that occurs, but several that increase the risk of the first in the development of adenomas and the progression to cancer. So, the first thing that goes wrong is the loss of the APC gene. The APC gene is a tumor suppressor gene, and it is considered the most critical gene in early development of colorectal cancer. A mutation in this gene is present in 80% of sporadic colon cancers. And if you get a single germline mutation in this gene, then you get familial adenomatous polyposis, and we'll cover that in just a little bit. Okay, so after we lose the APC gene, what happens next that will lead us towards colon cancer? Next is KRAS. KRAS is an oncogene. An oncogene will stimulate cell growth and replication. So with KRAS mutation, there is increased growth stimulus. Next is loss of more tumor suppressor genes. There are a few here to remember. The first one is P53. This one is famous because it is the most commonly mutated gene in human cancers in general. The loss of P53 is thought to be a rather late event in the progression of colon cancer. The other tumor suppressor gene is located in chromosome 18q. This one is called DCC, which just stands for deleted in colon cancer. I guess they were short on names that day. Again, this is likely late in the process and helps in the process of allowing adenomas to become colon cancer. So that's the first pathway. First you lose APC, then you mutate KRAS, which stimulates growth, then P53 and DCC come in late and allows adenomas to progress to colon cancer. The second pathway is called the mutator mismatch repair pathway, or the microsatellite instability pathway. This pathway is less common than the APC pathway and is associated with the inherited condition HNPCC, or hereditary non-polyposis colorectal cancer, commonly called Lynch syndrome. This is due to dysfunction of the DNA mismatch repair enzyme. Cells tend to accumulate DNA errors throughout the genome. There is an accumulation of abnormalities in short sequences of nucleotide bases that are repeated hundreds of times within the genome, and these are called microsatellites, and that's where the name comes from. Okay, so those are the two pathways, the APC progression and the microsatellite instability that are due to dysfunctional DNA mismatch repair enzymes. Now, let's look at some of the other risk factors associated with colorectal cancers. Inflammatory bowel disease is a risk factor. We'll talk about ulcerative colitis and Crohn's disease in the next video. Ulcerative colitis is a greater risk factor than Crohn's disease, but both are risk factors. Smoking, which is horrible, is a risk factor for lots of different cancers, and colorectal cancer is no exception. Other environmental risk factors include high-fat, low-fiber diets, alcohol use, and obesity. America. Having adenomatous polyps is definitely a risk factor. Which type of adenoma did we say carried the highest risk for malignant transformation? The villus adenoma. Then another risk factor you'll see listed sometimes is strep bovis bacteremia. Let's clarify this just briefly. There's a study that found that 50% of colon cancer patients with colonized with strep bovis in their stool, but that doesn't necessarily imply causality. That doesn't mean that strep bovis is causing colon cancer. So if they just give you a patient with endocarditis and bacteremia and the blood cultures grow strep bovis, you might be trying to lead you to a diagnosis of colon cancer. So, how does colorectal cancer present? Like most other cancers, patients may present with vague symptoms or things like fatigue, weight loss, and lymphadenopathy. Patients can also get localized symptoms like abdominal pain, bowel obstruction, nausea, and vomiting. A change in bowel habits is more likely to be a cause from colon cancer on the left side or the descending colon. They may develop pencil-thin stools. Hematochezia is more often due to colon cancer in the rectosigmoid region. Patients may develop iron deficiency anemia from unrecognized blood loss, and this is common from cancers on the right side of the ascending colon. So how do we make the diagnosis? We usually do colon cancer screening with colonoscopy or with fecal occult blood testing. A barium enema and flexible sigmoidoscopy is still the protocol in some areas, but these are being used less and less for screening. You may also see narrowing of the lumen of the colon, which is called an apocore lesion. If the barium fills up the lumen and everything else in the lumen is tumor. The tumor marker for colorectal cancer is CEA. This is a pretty nonspecific tumor marker, and it can be elevated in other tumors as well. Therefore, it is more useful to monitor for recurrence rather than initial diagnosis. But the only definitive way to make the diagnosis is to get a tissue sample and send it for analysis. There are several genetic syndromes that predispose people for lots of polyps, and these are associated with colon cancer. The big one is called familial adenomatous polyposis. It is autosomal dominant mutation of the APC gene. You get lots of polyps, and of course, with these polyps, your likelihood of having cancer in one of them is going to be higher. There's also Turcotte syndrome, which is a variant of familial adenomatous polyposis, but with Turcotte syndrome, you have malignant CNS tumors, and that tumor specifically is a medulloblastoma. Turcotte kind of sounds like turban, which is something you wear on your head. So you might help to remember that Turcotte syndrome is associated with brain tumors. There's Gardner syndrome, which is a familial adenomatous polyposis plus bone and soft tissue tumors, lipomas and retinal hyperplasia. So one way to think about Gardner syndrome is it's just like a gardener growing lumpy vegetables. Well, in this case, it's a gardener of your body growing lots of different tumors throughout your whole body. Another syndrome is called hereditary non-polyposis colorectal cancer syndrome, or sometimes called Lynch syndrome. We mentioned that one when we talked about microsatellite pathway. Patients get colon cancers that does not arise from a polyp, and it is non-polyposis colorectal cancer. It's an autosomal dominant mutation, and that underlying problem is the defect in the DNA mismatch repair. This is one specific cause of cancer in the proximal colon. In regular colon cancer, about 50% of cancers arise from the distal third of the colon, distal to watershed area of the splenic flexure, and the other 50% arise proximal to the splenic flexure, in the proximal 2/3 of the colon. But in HNPCC, most of these cancers arise in the proximal colon, which is somewhat unusual. Okay, so that's it for colon polyps and colon cancer. Go ahead and complete your end of session quiz, and then we'll walk through the answers. First question, which pathological lesions of the colon are considered precursors to malignancy? Adenomatous polyps. Remember, hyperplastic polyps are not considered pre-malignant. And which colon pathology has the most malignant potential? Those are the villous adenomas, which is one type of the adenomatous polyp. Which gene mutations are commonly seen in the development of colorectal cancer? Remember the two major pathways. The most common is the APC chromosomal instability pathway. First you lose APC, then you get KRAS mutates, and then that stimulates the growth, and then late in the process you see loss of P53 and DCC. The other pathway is the microsatellite instability pathway, where we see dysfunction of the DNA mismatch repair enzymes and is associated with hereditary non-polyposis colorectal cancer. What are the risk factors for colorectal cancer? Adenomatous polyps, high fat, low fiber diets, tobacco use, inflammatory bowel disease like ulcerative colitis and Crohn's disease, and then you also had to add the polyposis syndromes like FAP, Peutz-Jeghers syndrome, or juvenile polyposis. And then we have a few rapid fire facts, guys. GI hamartomas, hyperpigmentation of the mouth and hands, Peutz-Jeghers syndrome. Multiple colon polyps, osteomas, soft tissue tumors, this is Gardner syndrome. And an apocore lesion of the barium enema is colon cancer. That's it for GI 9. We'll see you at the next time.
Thwarted you again, evil colon cancer. For I am the APC gene, the famous tumor suppressor.
You think I didn't know you'd be here, APC Gene? Well, I came prepared. I have begun mutating you, which you know will cause familial adenomatosis polyposis.
No. I will recommend prophylactic colectomy before the age of 25, which everyone knows is the general recommendation for FAP.
Not that. Anything but that.
Lewis, this is a dorky way to study.
Not dorky. Awesome. Now put your mask back on. Evil colon cancer?
Yes, APC Gene. Ah, weak syringe. Ah!
Let's go over the warm-up. First question. A patient with a urinary tract infection caused by Proteus vulgaris is at risk for what type of renal stones? These are ammonium magnesium phosphate stones, which can form staghorn calculi. Next, which reflexes are evaluated during a newborn examination in order to assess healthy neurological function? So you can check the Babinski reflex, the Moreau reflex, the Palmer reflex, the Rooting reflex, and the sucking reflex. And the last one. How can dementia with Lewy bodies be distinguished from other forms of dementia? So dementia with Lewy bodies is commonly associated with visual hallucinations, and it can also be associated with repeated falls and syncopal episodes. Now let's move on to the lecture.
Hello everyone and welcome to our third and final video on the large intestine. It's been a long journey, but like corn, we have traversed the GI tract and made it out with barely a scratch on us. Corn. All right. So we're going to talk about some diseases of the distal colon today, and we'll be wrapping up the GI section by talking about inflammatory bowel diseases. All right, so first we're going to talk about diverticulosis. So in the distal colon, you have diverticular disease. So what is diverticular disease? Well, a diverticulum is essentially just a blind pouch. So if we're talking about one, it's called a diverticulum. If we're talking about more than one, we call them diverticula, not diverticuli. So sometimes people will make that mistake. Now we talk about diverticula in the esophagus in another video as well, like a Zinker diverticulum, a traction diverticula as well, epiphrenic diverticula, Meckel's diverticulum, but we're here talking about colonic diverticula. Now a colonic diverticulum is an outpouching that protrudes from the GI tract that communicates with the lumen of the gut, and these are easily seen on colonoscopy. Now there are two categories of diverticula. There's a true diverticulum where all three layers of the gut wall are outpouching like in, say, a Meckel diverticulum. But most colonic diverticula are what we call a false diverticula, where only the mucosa and the submucosa are in that outpouching from the colon. So there are little spaces or weak spots in the muscle layer right at the perforating vessels. Now, if you have increased intraluminal pressure, the mucosa and the submucosa can poke out through the weak spot, and that forms, again, that false diverticulum. Now, colonic diverticula most commonly occur in the sigmoid colon. Usually these don't occur singly. There are usually several of them, possibly many of them. Now, we call that diverticulosis, and it tends to occur in people over the age of 60. About 50% of individuals over the age of 60 years will have multiple diverticula. Now here's a barium enema of a patient with diverticulosis. You can see this very irregular appearance of the descending colon where the barium is filling up all those diverticula and highlighting them. Now, diverticulosis usually doesn't cause any problems. Occasionally they can have a vague discomfort in the left lower quadrant that's relieved when they defecate. Patients may also present with painless rectal bleeding, but usually it's pretty much painless and asymptomatic. However, sometimes those diverticula can become inflamed, sometimes even infected. And when that happens, it's called diverticulitis. Now, while diverticulosis was generally asymptomatic, diverticulitis is going to cause problems. Classically, patients will have left lower quadrant pain because this is in the sigmoid colon most of the time. They might also have fever and elevated white blood cell count on the CBC. Now, rarely patients may have some rectal bleeding, but not very often. Others may be constipated because of the inflammation present in the colon. And if a diverticulum perforates, just like an appendix can perforate, then that fecal matter is going to go into the peritoneal space and cause infection and inflammation. And anytime you perforate the bowel, or whether it's a perforated appendix or perforated diverticulitis, one of the hallmarks that you're going to see on an X-ray or a CT scan is going to be free air in the abdomen. Now, anytime you see air in the peritoneal space on a CT scan, you know this patient has a perforation of the gut somewhere. Now, the treatment for an acute flare-up of diverticulitis is to give antibiotics, but diverticulitis doesn't always require hospitalization, so you can treat diverticulitis as an outpatient in many instances. So, which antibiotics do we use? Well, first we're going to use metronidazole. This is a great antibiotic to use because it covers anaerobic bacteria, which is of course present in the GI tract. And then with that metronidazole, you're going to add on a couple of things potentially. Either trimethoprim sulfamethoxazole, or probably more commonly a fluoroquinolone like levofloxacin or ciprofloxacin. All right, so now let's move on to inflammatory bowel disease. So the most important being Crohn's disease and ulcerative colitis. So they are both characterized by inflammation of the GI tract, but beyond that, they are actually quite different. In fact, the only reason we're discussing them together is because that's the way they are traditionally taught, and we don't want to blow your mind too much by splitting them apart. But either way, inflammatory bowel disease is definitely high yield. It's a 4-star topic. You'll likely have at least one question about either ulcerative colitis or Crohn's or both. So let's start off with Crohn's disease. Now with Crohn's, I want you to think of inflammation everywhere. And this inflammation is transmural inflammation, inflammation through the full thickness of the gut wall. The other reason to think about Crohn's disease causing inflammation everywhere is that it can take place anywhere throughout the GI tract, so anywhere from the mouth to the anus. Primarily, it's going to be in the small intestines and in the large intestines, and most common location of this inflammation is going to be the terminal ileum, so remember that. But even though the inflammation can occur anywhere in the GI tract, it could be just a little here and a little bit there. It skips around, so we call these skip lesions. So you might have lesions in the terminal ileum, and then in the sigmoid colon, and then the rectum is spared. And then you see more lesions in the perianal region. So these, again, are skip lesions. And that sparing of the rectum is actually a pretty classic finding. About half of Crohn's patients who have disease in the colon have absolutely nothing in the rectum. So what is causing this inflammation? Well, we're not certain what the fundamental cause of Crohn's disease is, but there does appear to be a relationship between Crohn's disease and intestinal flora. So the body is getting thrown into this cycle of inflammation by the presence of bacteria in the gut. So one of the treatments emerging for Crohn's disease is probiotics, which acts to maintain healthy intestinal flora, and we'll talk more about other treatments in just a little bit. Now, because you have this transmural inflammation, the lumen of the gut is going to be narrowed as the wall of the gut becomes thicker. And one of the ways that we identify Crohn's disease is with a barium swallow. So with a barium swallow, you're going to see that oral contrast highlighting a normal diameter lumen, and then an area where the lumen is strictured and narrow. And that's what we call a string sign, because the contrast kind of looks like a string in there. Now, clinically, Crohn's can cause a lot of problems, like stricturing, like what we just talked about, diarrhea, malabsorption, weight loss. Basically, the inflammation is preventing the enterocytes from functioning normally. It also increases the risk of colon cancer. Not as much as ulcerative colitis does, but it still does increase your risk of colon cancer some. Crohn's disease also can cause fissures and fistulas. So what kind of fistulas are we talking about here? Well, these are abnormal connections between the small intestine and then any other structure. So it could be an enterocolonic fistula, which is a fistula between the small intestine and the large intestine, the colon. You can have an intravesicular fistula, where the fistula is between the small intestine and the bladder. You can have an enterovaginal fistula. You can have an enterocutaneous fistula, so going to the skin. Now, in addition to these various GI problems with Crohn's disease, it also causes systemic problems. It can be associated with arthritis and joint problems. Remember that inflammatory bowel disease-induced arthritis is one of the HLA-B27 disorders. It can also cause immunologic problems. It can cause dermatological problems, specifically erythema nodosum, which are red, painful subcutaneous nodules on the shin. So lots of different problems there. Now, microscopically, if you get a biopsy of one of these GI tract lesions, you see non-caseating granulomas. It's not the caseating granulomas that you would see, say, in something like tuberculosis. These are non-caseating granulomas, which are consistent with chronic inflammation. So how do we treat this? Well, look in your study guide here. Which treatments are available for managing Crohn's disease? Well, for mild disease, there's the 5 ASA agents. ASA is amino salicylic acid. So mesalamine is 5 amino salicylic acid. It's another name for it. And 5 ASA is very similar to things like aspirin and NSAID. So it inhibits cyclooxygenase. So it will decrease production of prostaglandins and leukotrienes. And by doing so, it's going to reduce inflammation. 5-ASA is specifically designed to work just in the gut, so it reduces inflammation locally in the lumen of that gut. Next, we have sulfasalazine. So sulfasalazine is that 5-ASA that we just talked about that's bound to sulfapyridine. So it's a combination drug. So this drug remains bound until it reaches the intestinal flora in the colon, and then both those drugs get to work. So sulfasalazine is particularly helpful for both Crohn's disease and ulcerative colitis. Side effects of sulfasalazine include malaise and nausea. It's a sulfonamide because it has a sulfapyridine on it, and it can cause oligospermia, which is another interesting side effect. It can decrease sperm count. Now, what other drugs can you use for Crohn's disease? Well, you can use other anti-inflammatories, azathioprine or mercaptopurine or methotrexate. So any one of those three. And azathioprine tends to be used more commonly. You can also use the anti-TNF agents as well, like infliximab or adalimumab. Specifically, if the patient has an arthritic component to their Crohn's disease, you might be more inclined to go with one of those anti-TNF agents. Even just good old-fashioned steroids can be helpful with or without antibiotics for acute exacerbations. All right, so that's Crohn's disease. Let's move on to and contrast that to ulcerative colitis. Now, one big thing to keep straight in your mind is that while Crohn's disease gives you all this inflammation everywhere, with ulcerative colitis, the inflammation is limited to the colon, period. It's called ulcerative colitis, so it's pretty easy to remember. It starts in the distal colon and then it works its way proximally. And unlike Crohn's disease, ulcerative colitis does not skip around. It is continuous. It's always going to affect the rectum. So no skip lesions, no rectal sparing with ulcerative colitis. Now with ulcerative colitis, the inflammation is limited to the mucosa and the submucosa. So Crohn's disease, remember, was that transmural, that full thickness inflammation, but ulcerative colitis is mucosal inflammation only. Now, the underlying problem is an autoimmune disorder rather than a reaction to intestinal bacteria. Now, if you did a barium enema, you would see that the haustra of your colon are obliterated, and you get what's called the lead pipe appearance of the colon. Now, microscopically, instead of granulomas, you're going to see crypt abscesses, ulcerations, and then bleeding as well. Now, complications associated with ulcerative colitis include diarrhea again, especially bloody diarrhea, because this time the rectum is more involved. You can see malnutrition and also an increased risk of colon cancer, but in this case, a much higher risk than what we saw with Crohn's. Now, extraintestinal manifestations are a little less common overall, but patients are at an increased risk of primary sclerosing cholangitis, which is scarring and inflammation in the biliary tract. Patients may get a skin condition called pyoderma gangrenosum as well. And then again, because of that HLA-B27 association, patients can also have sacroiliitis and uveitis. So how do we treat this? Well, you can use one of those salicylate preparations like sulfasalazine. Remember, that's the sulfa antibiotic that we just talked about. It's bound to that salicylate, and then when it gets to the colon, the colonic bacteria break it apart, and then both become active. And then other anti-inflammatories can be useful like 6-mercaptopurine, infliximab, the TNF-alpha inhibitors. And then in very severe cases, you can actually remove parts of the colon. And after that procedure, the patient is cured. You wouldn't want to do that with Crohn's disease because Crohn's is going to just come back in a different area. It's skipping around. But with ulcerative colitis, only the colon is affected. So a colectomy partially would be curative. Now, before we end this video, we have one more topic. We need to do a little farm and cover laxatives before we actually leave GI forever. So there are several classes of laxatives. First, there are the bulk-forming laxatives like psyllium and methylcellulose. So these are the soluble fibers that work by bringing in extra water into the lumen of the gut. This will stimulate peristalsis and thus a bowel movement. Patients will sometimes get extra gas that can be a cause of bloating in those agents. Next are the osmotic laxatives like magnesium hydroxide, magnesium citrate, polyethylene glycol lactulose. So these will produce an osmotic gradient, which will again bring more water into the gut. Adverse reactions include diarrhea, so it works too well, dehydration, and these are sometimes abused by bulimics to lose weight. Next are the stimulant laxatives, things like Senna. These actually promote enteric nerve stimulation, which will lead to a colonic contraction. So these are a little more intense. Patients may get some cramping with this as well. You can get diarrhea, and an interesting side effect is melanosis coli, where the lumen of the gut is pigmented with kind of this brown color. You can see it on colonoscopy, and that's very interesting. Now, the final drug is Docusate, which is considered an emollient. It works similarly in the same ways as these other ones by promoting an osmotic gradient to encourage water to enter the gut lumen. A little bit different overall profile there. Again, the most common side effect, though, is going to be diarrhea. All right, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question here, what is the classic presentation for diverticulosis? Well, diverticulosis is usually asymptomatic, but patients might present with some painless rectal bleeding, maybe some vague left lower quadrant discomfort. Next, what is the treatment for diverticulitis? So remember, diverticulitis, you're going to have metronidazole, and then either you're going to add on a fluoroquinolone, which is probably the most common way to do it, or you're going to put something like trimethoprim sulfate methoxazole on. Next, determine which of the following characteristics are associated with Crohn's disease, ulcerative colitis, or both. So first we have skip lesions, that's going to be Crohn's disease. Loss of Hofstra, so that's going to be ulcerative colitis. Remember, you get that kind of lead pipe appearance. Transmural inflammation, that's going to be Crohn's disease. Fistulas, that's going to be Crohn's disease again. Increased risk of colorectal cancer, both, but remember that it's a greater risk in ulcerative colitis. Non-caseating granulomas, that's going to be Crohn's disease. Always involves the rectum, that's going to be ulcerative colitis. Associated with primary sclerosing cholangitis, that's going to be ulcerative colitis again. And then associated with ankylosing spondylitis, that one is both. All right, we have a few rapid fire facts too. Most common site of colonic diverticula, that's going to be the sigmoid colon. String sign on contrast x-ray, think about Crohn's disease. Lead pipe again, appearance of the colon on contrast x-ray, think about ulcerative colitis. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Welcome back. Let's go through the answers to your warm-up questions. First question, what infections are caused by chlamydia and chlamydophila species? Chlamydophila psittaci causes pneumonia in patients with exposure to birds. So make sure you know the association with psittaci and psittacosis with bird exposure. Chlamydophila pneumoniae causes interstitial pneumonia or walking pneumonia. It's one of 3 organisms that cause walking pneumonia. And for Chlamydia trachomatis, there are several different serotypes. There's types A, B, and C that cause trachoma eye infection in Africa. The one that's more clinically relevant in the United States is Chlamydia trachomatis types D through K. These cause STDs and pelvic inflammatory disease, as well as urethritis and neonatal conjunctivitis. And the other types of Chlamydia trachomatis is L1, L2, and L3, which cause lymphogranuloma venereum, causes a primary ulcer, plus lymphadenopathy in the inguinal region. And what is the treatment for most chlamydia and chlamydophila species is macrolides and tetracyclines. So either macrolides or tetracyclines. All right, that's it for your warm-up. Let's move on to the lecture.
Hello everyone and welcome to our video on the pancreas. So there's more to the digestive system than just the GI tract. So over the course of the next few videos, we're going to discuss things like the pancreas, the liver, and even the gallbladder. So let's talk about the pancreas, and even we'll throw in a little spleen embryology here. The pancreas is going to arise from the foregut. So the pancreas is derived from endoderm. Now the first thing that happens is a small diverticulum starts to develop on the distal foregut, almost at the midgut. So this diverticulum is called the hepatic diverticulum, and it develops on the ventral surface of the foregut. Now the hepatic diverticulum is going to give rise to the liver and the gallbladder and the biliary tree and also the ventral side of the pancreatic bud. Now that ventral pancreatic bud is going to become part of the head of the pancreas. Then there's also a dorsal pancreatic bud that develops from the dorsal surface of the foregut, and that dorsal pancreatic bud will eventually become the body and the tail of the pancreas. And this part of the foregut eventually rotates and becomes kind of C-shaped to form the duodenum, and as it does so, it drags that ventral pancreatic bud with it until it meets up with the dorsal bud, and they fuse together. That's around 8 weeks. So, one developmental anomaly that we can see with the pancreas is called an annular pancreas. Annulus is a Latin word for ring. Now, an annular pancreas is where the ventral pancreatic bud basically encircles the duodenum and forms a ring around it, and it can sometimes compress the duodenum from kind of the outside in, causing a narrowing or a stenosis of that part of the duodenum. Now, 2/3 of patients with an annular pancreas remain asymptomatic throughout their lives. Most patients that have this have so little stenosis that it doesn't really cause any problems whatsoever. Now, symptom onset, when it does occur, can occur at any age depending on the severity of that duodenal constriction. Children can present with gastric outlet obstruction and non-bilious vomiting, feeding intolerance, and abdominal distension. Now, in infants, an annular pancreas is associated with polyhydramnios, Down syndrome, esophageal and duodenal atresia, and imperforate anus, and even a Meckel diverticulum. And then in adults, these patients usually present at about 20 to 50 years of age if they're going to present at all, and they're going to present with abdominal pain, postprandial fullness and nausea, peptic ulcers, pancreatitis, and rarely some biliary obstruction as well. But again, most of these patients go through life without any problems at all, but it's something that can present a little more often in childhood. All right, so let's continue on in our pancreas and spleen embryology. So there's something called a pancreas divisum, which is where the ventral and the dorsal buds fail to fuse at all. So you have two parts of the pancreas that are not fused. Now, while we're also talking here about the pancreas, what about that spleen? So the spleen doesn't come from the hepatic diverticulum. The spleen arises from the dorsal mesentery of the stomach. So it's a mesodermal structure, not an endodermal structure. But it gets its blood supply from the artery of the foregut, which is the celiac trunk. Now remember that one of the 3 branches of the celiac trunk was the splenic artery, so be aware of that. So now let's talk about the function of the pancreas. So parts of the pancreas function as an endocrine gland producing insulin and glucagon and other endocrine hormones, which we'll talk about in the endocrine videos. But right now I wanted to focus on the function of the pancreas as an exocrine gland, which delivers enzymes and bicarbonate into the GI tract. So, what enzymes are secreted by the pancreas? Well, there's lipase, there's colipase, and phospholipase A, which digest fats and lipids. Lipase digests lipids. In order to digest and absorb lipids, fats and cholesterol, you need lipase from the pancreas, and you also need bile, which comes from the liver. Now, the pancreas also secretes proteases, which are enzymes that digest proteins. So we talked about pepsin in the stomach, which started on those proteins, but there are also pancreatic proteases. Now, proteins are too big for your gut to absorb. Your gut can only absorb amino acids, maybe some small polypeptides, maybe 2 to 3 amino acids in length. So in the stomach, the pepsin starts the process of chopping those proteins into smaller, more manageable pieces. And then the pancreatic proteases break down those proteins even further into pieces that can be absorbed by the enterocytes. Now, these pancreatic proteases include things like trypsin, chymotrypsin, elastase, and carboxypeptidases. Now, the pancreas secretes these proteases as zymogens, or inactive proenzymes, and then they are activated once they're in the duodenum. Now, you wouldn't want to have active proteases in the cells themselves, or they would start digesting cellular proteins, and then you would have a big mess. So the zymogen trypsinogen is secreted by the pancreas and gets dumped into the duodenum. Meanwhile, the duodenal mucosa is secreting enzymes called enterokinases and enteropeptidases. And they come along and convert trypsinogen to the active enzyme trypsin. And then trypsin can go around and activate the rest of these proteases. So this allows digestion to be ramped up very rapidly and in the right place. And of course, your pancreas makes the enzyme amylase, which is important for the digestion of carbohydrates and starches. All right, so let's talk about that for just a second here. Carbohydrate digestion. So carbohydrate digestion begins in the mouth with salivary amylase, but then in the duodenum, the pancreas secretes that pancreatic amylase, which breaks down complex carbohydrates into simpler sugars, oligosaccharides and disaccharides. But like the proteins, these sugars can't be absorbed until they are broken down into the smallest possible units, which are sugar monomers. Now, the enzymes that do this are called oligosaccharide hydrolases, which are things like sucrase, maltase, isomaltase, and lactase. These are all found in the brush border of the intestine in the enterocytes. So these are the rate-limiting enzymes of carbohydrate digestion, and it takes place right at the last step prior to absorption. Then once the carbohydrates are broken into monomers, the enterocytes can absorb them using a sodium-glucose co-transporter, which is called SGLT1. So that's sodium-glucose transporter. So it uses the sodium gradient to help drive the transport of glucose and galactose into the cells. And that's a common theme throughout the body, absorbing things with the help of sodium. So that's how glucose is absorbed at your enterocytes, through that sodium-driven active transport. Fructose, on the other hand, is taken up by facilitated diffusion using a transporter called GLUT5, G-L-U-T-5. Now, one last physiology thing I want to talk about briefly is how the body tells the pancreas to start secreting all of these enzymes. Now, there are several different signals involved here. The main signal is cholecystokinin, or CCK, the hormone that stimulates the gallbladder to contract, and it also stimulates pancreatic secretion. The vagus nerve stimulates the pancreas. Remember, rest and digest means the parasympathetic nerves are involved. And then finally, a secretin stimulates the pancreatic ducts to secrete bicarb to neutralize gastric acid. So now we're ready to talk about some diseases of the pancreas, and we're going to start with cystic fibrosis. So this is a systemic disease that causes big problems for the pancreas. So we also review CF in the reproduction videos, but let's think about CF from the perspective of the pancreas. Now, all those pancreatic enzymes have to get to the GI tract, and this is by way of the pancreatic ducts. So the pancreatic ducts make their own watery secretions to help kind of wash all the enzymes downstream to the ampulla levator and into the duodenum. So we sometimes call this the pancreatic juice. Now, besides all the enzymes, things like lipase, amylase, trypsinogen, and so on, the pancreatic juice contains a lot of bicarb, and that's going to help to neutralize the acid that's coming into the duodenum from the stomach, and a lot of sodium chloride. So the pancreatic ducts make the watery component of the pancreatic juice by pumping chloride into the lumen, and where chloride goes, sodium is going to follow, and where sodium goes, that's where the water is going to follow as well. And then remember that with cystic fibrosis, there's a defect in the CFTR gene. So the cystic fibrosis transmembrane conductance regulator. So the CFTR protein is a chloride ion channel. And when that gene is mutated, so that CFTR protein gets misfolded, these patients can't pump chloride into the lumen. And then sodium isn't going to follow, and then water isn't going to follow. And instead of nice kind of watery pancreatic juice, you get kind of a nasty, thick pancreatic secretions that just kind of gum up everything. Now, this mutation causes problems in the respiratory tract and affects the sweat glands. So these patients also have extra salty sweat and excessive chloride in their sweat. So that's how you do that sweat chloride test. But from a pancreatic perspective, the pancreatic ducts get plugged up with this kind of thick gunk, and they don't get all those pancreatic enzymes into the gut. So patients have malabsorption of fats and proteins. And if you have this malabsorption of fats, you also have malabsorption of fat-soluble vitamins, and that leads to problems as well. So in terms of treating the pancreatic complications of CF, these patients need to have supplemental pancreatic enzymes, and they need to supplement those fat-soluble vitamins as well. Let's move on to acute pancreatitis, another important pathology of the pancreas. So CF is a fairly common genetic disease, but you still probably won't see a ton of it. But you will definitely see acute pancreatitis. Acute pancreatitis is where the pancreas gets inflamed and starts digesting itself, so to speak. It's not supposed to do that, but when it happens, it can be a life-threatening condition. And these patients need to be hospitalized and monitored very closely to make sure the pancreatitis is getting better instead of getting worse, and to make sure they're not developing any complications. So what causes acute pancreatitis? Well, by far, the two most common causes are gallstones and alcohol. Lock that into your brain forever, gallstones and alcohol. These two things alone are going to cause about 75% of cases of acute pancreatitis. But you need to be familiar with the other causes of pancreatitis as well, and there are several good mnemonics. There's get smashed, and when I was in school and in residency, I learned of bad hits. But a student from PCOM sent us the mnemonic pancreatitis, so that seems pretty apt. So the P is for hyperparathyroidism, which reminds us that hypercalcemia can cause pancreatitis, because when PTH is high, you get hypercalcemia. A is for alcohol, one of our big ones. N is for neoplasm, so like a pancreatic tumor that blocks the pancreatic duct or the common bile duct and causes all that pancreatic juice to back up and start digesting the pancreatic tissue. C is for cholelithiasis, so that's just a fancy word for gallstones. So again, gallstones and alcohol are going to be your two most common causes of pancreatitis. R is for Rx, or drugs. So there are a handful of drugs that you should remember as potential causes of pancreatitis, especially the NRTIs that we use for HIV, like didanosine, zalcitabine, and stavudine. Also the protease inhibitor ritonavir, and sulfa drugs as well. So remember HIV drugs, remember sulfa drugs as potentially causing pancreatitis. E is for ERCP, so that's a procedure, endoscopic retrograde cholangiopancreogram. Again, ERCP is where you inject contrast into the pancreatic duct in order to visualize it. That retrograde flow of contrast is not exactly healthy for the pancreas. You're pushing things in the opposite direction as well from the way they should be going, and that can sometimes cause acute pancreatitis. Now, the next A in pancreatitis is for abdominal surgery. The T is for hypertriglyceridemia, which is an important classic cause, definitely worth knowing there. The I is for infection, and that's to remind you that things like mumps can occasionally cause pancreatitis. Not that you're going to see a lot of mumps, but every once in a while. The next T is for trauma, because things like abdominal trauma, like abdominal surgeries, can potentially disrupt the normal anatomy and cause problems. The next I is for idiopathic, which is a bit of a cop-out, but around 20% of cases are idiopathic, meaning we can't find a specific cause. So the third most common cause of pancreatitis is no cause at all, or we just don't know. And then the S is for scorpion sting, which is extremely rare. In fact, the scorpions that usually cause this aren't even native to the United States, but I always like to ask pancreatitis patients if they've been stung by a scorpion just for fun. So make sure you know all those, especially gallstones and alcohol, hypercalcemia, hypertriglyceridemia, ERCP, and drugs. Those are probably going to be the most testable ones. So how does pancreatitis normally present? Well, it causes pain, severe upper abdominal pain, possibly radiating to the back. Nausea, vomiting are also big clues. These patients often refuse to eat, or they have cytophobia, which is fear of food, because they know that eating is going to make the pain and vomiting worse. We usually make the diagnosis by an elevated serum lipase. Now, a lot of people check amylase too, but lipase is a bit more specific. And we usually get a CT scan just to confirm the diagnosis. But really, serum lipase is going to give you the diagnosis best. Then the reason that acute pancreatitis is such a bad disease is that it can lead to a bunch of terrible complications like multi-organ failure, that's not good, DIC, hemorrhage into the pancreas, necrosis of the pancreas. You can sequester all your calcium in the abdomen as well. When the calcium combines with fat and forms soap deposits in the belly, we call that saponification. And as the calcium precipitates out of the blood, it can cause severe hypocalcemia. And then acute pancreatitis can turn into chronic pancreatitis, and you can also get something called a pancreatic pseudocyst. And that's one reason we do the CT scan, to look for a pseudocyst in the pancreas. A true cyst is lined with epithelial cells, but these pseudocysts are lined with fibrous scar tissue, granulation tissue from all that ongoing inflammation, and they are filled with that pancreatic juice and pancreatic enzymes. Now let's switch gears and talk a little bit about chronic pancreatitis. It's classically caused by alcohol abuse, because alcohol is irritating to that pancreas. And because of the chronic inflammation, you get chronic damage to the pancreas and chronic pancreatic failure with malabsorption, steatorrhea, and all those things that we saw with pancreatic failure from cystic fibrosis. It can also damage the pancreas to the point of causing diabetes. And chronic pancreatitis will also increase the risk of pancreatic cancer. Then to manage chronic pancreatitis, just like with cystic fibrosis, you're going to give pancreatic enzymes and fat-soluble vitamins. Let's move on to pancreatic cancer. So pancreatic adenocarcinoma. We've already mentioned a couple neuroendocrine tumors of the pancreas, like a gastronoma or a VIPoma. But generally, when someone says pancreatic cancer, we're talking about pancreatic adenocarcinoma. And this is an aggressive cancer that has a really poor prognosis. Now, one reason is that it doesn't cause many symptoms until it's pretty far gone and has already metastasized to the liver. Now, it classically presents with weight loss, abdominal pain, or jaundice because the tumor is obstructing the biliary tract. And that jaundice can be pretty severe and can come on pretty suddenly. Often painless jaundice as well. Now, I remember a patient who I was seeing right after the New Year. She was fine at Christmas, but by New Year she was very bright yellow. She was dead by April. Pancreatic cancer moves very, very quickly. It is pretty horrible. Now, there's also a very rare presentation called Trousseau syndrome where you get hypercoagulability and venous thrombosis and migratory thrombophlebitis. It can be associated with lots of different malignancies, but pancreatic cancer is certainly one of them. In fact, Dr. Trousseau, who first described this association between thrombophlebitis and pancreatic cancer, he later diagnosed Trousseau syndrome in himself, and then he developed pancreatic cancer, unfortunately. Now, don't get Trousseau syndrome confused with Trousseau sign, which is the sign associated with hypocalcemia, where you put a blood pressure cuff on the patient, tighten it, and they get a carpal pedal spasm in the hand. That's Trousseau sign, but we're talking about Trousseau syndrome. Now, the big risk factors for pancreatic cancer are things like chronic pancreatitis, which we already mentioned, tobacco use, being over the age of 50 years, and being either black or an Ashkenazi Jew. Now, there are a couple of tumor markers for pancreatic cancer. CA19-9 is the main one, but CEA can also be associated with pancreatic cancer. We tend to think of CEA as a tumor marker for colon cancer, but it can be elevated with pancreatic cancer as well. It's a common tumor marker for several different gut tumors, but it's not very specific for any one organ. All right, so let's cover a couple more things. We're going to talk about a glucagonoma, which is a hard thing to say. This is a tumor of the pancreatic alpha cells, so this leads to an overproduction of, you guessed it, glucagon. Patients will present with depression, dermatitis, a very specific one, a necrolytic migratory erythema. They can also get diabetes, they can get a DVT, and even some weight loss as well. A treatment includes octreotide or just resection of the tumor itself. Another rather rare tumor is an insulinoma. So this is a tumor of the beta cells of the pancreas. So here we see an overproduction of, you guessed it, insulin, which will lead to hypoglycemia. So how do we diagnose this? Well, hypoglycemia is certainly going to be present, but how could you tell the difference between an insulinoma and maybe just someone who is giving themselves too much exogenous insulin? Well, you need to check the C-peptide. The C-peptide will be elevated in an insulinoma. It will be normal in someone giving themselves exogenous insulin. 10% of insulinomas will be associated with men, that MEN1 syndrome. And the treatment is going to be surgical resection. And then we have a somatostatinoma. So this is a tumor of the delta cells of the pancreas. With too much somatostatin, we see a decrease in the secretion of things like secretin, cholecystokinin, glucagon, insulin, gastrin, and GIP. Patients will present with diabetes, steatorrhea, gallstones, achlorhydria as well. Treatment is going to be resection again, or you might want to give a somatostatin analog like octreotide. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, which hormones stimulate pancreatic secretion? So let's go through these. CCK, which stimulates both the pancreas and the gallbladder. There's secretin, which stimulates bicarb secretion. And we also mentioned acetylcholine, but that's just going to be from the vagus nerve, which is technically a neurotransmitter, not a hormone. Next, what enzyme catalyzes the rate-limiting step in carbohydrate digestion? So these are the oligosaccharide hydrolases, which are found at the intestinal brush border. Next, what are the possible etiologies of acute pancreatitis? Remember our fancy mnemonic, pancreatitis. So first we have hyperparathyroidism, so that gives you that hypercalcemia, alcohol, neoplasm, cholelithiasis, RX, so that's drugs, ERCP, abdominal surgery, hypertriglyceridemia, infection like mumps, trauma, idiopathic, and everyone's favorite, the scorpion sting. What is the typical presentation of a patient with pancreatic insufficiency? So you might see diarrhea, steatorrhea, malabsorption, weight loss, and deficiency of those fat-soluble vitamins, which are A, D, E, and K. And then what is the treatment for pancreatic insufficiency? Well, you need to limit fat intake. You're going to give pancreatic enzyme supplements, and also don't forget about those fat-soluble vitamin supplements as well. All right, so now let's run through just a few rapid-fire facts to finish this off. Painless jaundice should make you think of pancreatic cancer, especially in the head of the pancreas. Most common cause of acute pancreatitis, we said it was gallstones and alcohol. And the most common cause of chronic pancreatitis is just alcohol abuse. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the warm-up. First question. A young child has recurrent lung infections and granulomatous lesions. This is most likely due to what underlying defect in neutrophils? Well, the clue here is the granulomatous lesions. So this child has chronic granulomatous disease, which is caused by a deficiency of NADPH oxidase. Next, which bacteria form spores? So this isn't a complete list of spore-forming bacteria, but I want you to think about Bacillus anthracis and Bacillus cereus, and Clostridium species, including Clostridium perfringens, Clostridium tetani, Clostridium botulinum, and Clostridium difficile. And then also think about Coxiella burnettii, which is similar to Rickettsia. Last question. A 6-month-old child develops flaccid paralysis after ingesting honey. So what's the most likely causal organism? That's Clostridium botulinum. And then what's the underlying mechanism of disease? So this is a two-part question. They may or may not ask you for the intermediate piece of information, which in this case is the name of the organism. They may just give you the presentation and then ask for the mechanism of the toxin. So in this case, you need to know that botulinum toxin inhibits the release of acetylcholine. So definitely make sure you know those mechanisms of those bacterial toxins. And remember, when babies get botulism, it's not because they're ingesting preformed toxin. Babies are ingesting the botulinum spores, and then those spores mature in the gut. So now we're ready for the lecture.
Hi there! This is the first of several videos focusing on the liver. In this video, I'm going to talk about some liver basics, like embryology and anatomy of the liver, also the function of the hepatocytes. In subsequent videos, we'll cover alcoholic liver disease, viral hepatitis, and all sorts of other liver diseases. Obviously, the best place to learn about the liver is in the hip attic. Huh? Okay, we can pretend I didn't say that. Let's start out with some embryology. When we talked about the pancreas, we mentioned there was something called the hepatic diverticulum, and that grows off the anterior part of the distal foregut around week 3 and week 4. And that hepatic diverticulum goes on to become the liver and the biliary system, as well as the head of the pancreas. Remember, these are all endodermal structures. Now, during most of the fetal life, the liver is the major site of hematopoiesis. There are mesodermal hemopoietic stem cells that migrate from the mesonephros to the liver at about 3 weeks, and that's where most of the fetal blood cells come from until the bone marrow gets going around 28 weeks. We'll talk about that again in hematology. Now, we've talked about the embryonic origins of the liver. Let's look at the finished product of the adult. The liver can be subdivided into lobules with a vein in the center. Within each lobule, these pink hepatocytes are organized into interconnected stacks or sheets or plates that are all 1 cell thick. Surrounding these hepatocyte plates are interconnecting sinusoids that are filled with blood. Blood flows from the periphery of the lobule toward the center of the central vein. Out here in the periphery of the lobule, you have a portal triad. What's the portal triad? A portal triad consists of a branch of the hepatic artery, a branch of the portal vein, and a bile ductule. Let's first remember that there are 2 sources of blood coming into the liver. The hepatic artery brings in nice oxygenated arterial blood. The portal vein is the grand channel that brings together a lot of venous drainage from the GI tract. You remember that the mesenteric veins and the gastric vein all empty into the portal vein. So the portal blood coming into the liver is rich in all the things that were absorbed from the gut, from nutrients to drugs and toxins and all the other things enterocytes absorb. all that portal blood is going to have to go through the liver for metabolic processing before the blood can rejoin the central circulation. As the blood enters the lobule, it has to pass by all these hepatocytes on the way from the portal vein to the central vein. The hepatocytes pull out the glucose and store it as glycogen. They also pull out the lipids and cholesterol and process them. They metabolize the drug molecules and toxins and all other stuff. To recap, all the blood coming into the hepatic lobule is going to flow along from the portal triad, along the hepatocyte plate, toward the central vein. Now, you can break up the hepatocytes of the lobule into 3 different zones. Zone 1 is made up of the hepatocytes close to the portal triad. Zone 3 is the hepatocyte furthest away from the portal triad and closest to the central vein. Zone 2 is everything in the middle. The hepatocytes found in each of these zones are slightly different because they're exposed to slightly different concentration gradients of things in the blood. It all makes logical sense if you remember the direction of the blood flow. For instance, in Zone 1, you're going to have more highly oxygenated blood because of the proximity to the hepatic artery. And in Zone 3, you're going to get less oxygenated blood because it's furthest from the hepatic artery and the portal triad. It makes sense that Zone 3 hepatocytes are going to be affected first by ischemia and hypotension because they're the furthest away from the oxygenated arterial blood. Zone 1 hepatocytes are most affected by viral hepatitis because they get the highest viral load. Zone 3 hepatocytes are more sensitive to toxic injury, like from acetaminophen overdose or from alcohol toxicity, partly because of the tenuous oxygenation state as mentioned previously. These Zone 3 hepatocytes also have the highest concentration of P450 drug metabolism enzymes. Now, while blood flows away from the portal triad and toward the central vein, bile flows in the opposite direction. As the hepatocytes do their work, they make bile and dump them into these bile caniculi. Bile then flows towards the bile ductule of the portal triad and ultimately into the hepatic ducts and out of the liver towards the gallbladder. Take-home points. Blood flows from Zone 1 to Zone 3, and bile flows from Zone 3 to Zone 1. Let's talk about what exactly the individual hepatocytes do. I like to think about the hepatocytes as performing 4 basic functions. They make proteins, they metabolize toxins and drugs, they store things that the body wants to hang on to for later, and they make bile and excrete the bilirubin. Let's talk about each of these briefly. All right, number 1, the hepatocyte make lots of different proteins. Don't write all this down, but just think about the variety and the importance of the protein products in the hepatocytes. They make coagulation factors so that your blood can clot. They make complement proteins as part of your immune system. They make albumin, the most abundant plasma protein and an important modifier of serum osmolarity and oncotic pressure. They make apolipoproteins for lipid transport. They also make C-reactive protein, another important immune system component. They make angiotensinogen, which forms a crucial link in the renin-angiotensin-aldosterone system. They make transferrin for iron transport. They make ceruloplasmin for copper transport. And beyond proteins, hepatocytes are also important for the synthesis of cholesterol and phospholipids. We also said that hepatocytes are involved in drug and toxin metabolism. The liver processes both the drugs and toxins absorbed from the gut and the toxins and metabolites generated from the body. This metabolism is carried out by specialized enzymes like cytochrome P450 enzymes, the UDP glycuronyl transferase, which we're going to talk about in a minute with the conjugation of bilirubin, aspartate and alanine aminotransferase, or AST and ALT, which process protein metabolites through the alanine cycle by deamination and transamination. The steroid hormone converting enzymes. Without your hepatocytes, estrogen would just keep going around and around. But with your liver, you can break down estrogen and progesterone, as well as testosterone, vitamin D, cortisol, aldosterone, and thyroid hormone. So the liver is an important player in endocrine autoregulation. The third thing we said hepatocytes do are store things for later. They store glucose as glycogen, They store cholesterol and triglycerides, especially VLDL particles. They store minerals like iron bound to ferritin, certain vitamins like B12 or cobalamin, and fat-soluble vitamins A, D, E, and K, which are all stored in the liver. The fourth big function of the hepatocytes is to synthesize bile, which acts as a detergent to emulsify fat and allow for pancreatic lipase and amylase to digest the fats. Bile also acts as a carrier for the excretion of bilirubin from breakdown of red blood cells. Speaking of bilirubin, let's now talk about the metabolism and excretion of bilirubin and some diseases where bilirubin isn't handled correctly, resulting in hereditary hyperbilirubinemia. Inside the hepatocytes, there's an enzyme called UDP, glucouronyl transferase. This is the main enzyme I want you to remember when it comes to bilirubin. So remember, UDP, glycouronyl transferase, is going to transfer a glycouronyl group, also known as glycouronic acid, onto our bilirubin molecule. We call this conjugation. Remember, in Pharm Basics, when we talked about drug metabolism, we talked about conjugation as one mechanism our bodies have to inactivate drugs. The hepatocytes conjugates or joins drugs to something like sulfate or glutathione or glucuronic acid. Glucuronic acid conjugation makes the bile molecule more polar and soluble in water. Otherwise, unconjugated bilirubin is mostly water insoluble and lipophilic. Newborns have a reduced amount of UDP, glucouronyl transferase, so they can't conjugate bilirubin as effectively as adults can, and as a result, newborns often get a little bit of what we call physiologic jaundice. It's physiologic because it's expected to some degree. The jaundice usually resolves on its own in a week or two as the liver's UDP, glycouronyl transferase production ramps up. But too much unconjugated bilirubin builds up in the blood, it can lead to a condition called kernicterus. Kernicterus is where the bilirubin crosses the lipophilic meningeal blood-brain barrier and deposits in the brain, where it causes brain damage and, at high enough concentrations, death. Bilirubin is highly neurotoxic. With kernicterus, they can have chorea because of the basal ganglia damage, ocular motor changes like gaze deviation because of ocular motor center damage, and hearing loss because of auditory center damage. So, obviously, we want to prevent kernicterus. To do this, we treat hyperbilirubinemia before it gets to that critical kernicterus threshold. We treat with phototherapeutic modality called Bili lights. Bili lights are a special blue light that don't conjugate bilirubin, but they do convert it to an isomer that the body is able to excrete. The other name for unconjugated bilirubin is indirect bilirubin. Lab reports don't use the terms conjugated and unconjugated. They call them direct bili and indirect bili because of how they're measured. If you add the two, that's total bilirubin. In a baby, the total bilirubin will be elevated because of indirect bili. And in an adult, the degree of indirect or direct hyperbilirubinemia tells you more about the underlying pathology. All right, we talked about the process of bilirubin conjugation. Now let's talk about a handful of hereditary diseases of bilirubin conjugation that are worth talking about. These include Gilbert syndrome, Crigel-Najjar syndrome, Dubin-Johnson syndrome, and Roto syndrome. Gilbert syndrome is an autosomal recessive syndrome that affects about 5% of Caucasians. It's due to a mutation in the promoter region of the UDP glycouronyl transferase gene. So our enzyme structure and function is normal, but there's just not that much of it made. These individuals just conjugate bilirubin a little bit slower than usual. As a result, they always have a slight elevation in unconjugated bilirubin or indirect bilirubin. Their indirect bilirubin is always a little bit higher, but it's completely benign and completely asymptomatic. Maybe if they're under some physiological stress, they can get slightly jaundiced, but generally this is just an incidental finding on the labs. We don't even have to work it up. We just note that the indirect bili is always slightly elevated, and we kind of make a mental diagnosis of Gilbert syndrome, and we forget about it. It's clinically insignificant. Another disease of UDP glucouronyl transferase deficiency is Crigler-Najjar syndrome, of which there are two forms, type 1 and type 2. In type 1, there's complete absence of UDP glycoluronal transferase, so patients can't conjugate bilirubin at all. They can't excrete it in their bile. They present with jaundice and elevated indirect bilirubin within the first few days of life. And if they don't get treated, they develop severe kernicterus, and they die within a few years. Obviously, this needs to be recognized and treated. There are 3 main options of treatment. You can do phototherapy with bili lights, though this usually isn't enough. Another option is you can do plasmapheresis, where you take out the patient's plasma and remove the unconjugated bilirubin that is still bound to albumin. But ultimately, these are temporizing measures. The only cure to type 1 Crigler-Najjar syndrome, which is a liver transplant. That's going to give the patient a liver that does make UDP glycoluronal transferase, and that cures the problem once and for all. The other form of Crigler-Najjar syndrome is called type 2 Crigler-Najjar syndrome, and it's much less severe than type 1. Instead of completely absent UDP glycoluronal transferase, with type 2 you do make some, but it's mutated and has decreased effectiveness. So clinically, it's more like Gilbert syndrome. The degree of hyperbilirubinemia is generally less severe with type 2 Crigler-Najjar. But sometimes, when you've got a jaundiced newborn, it's tough to distinguish between type 1 and type 2. So, to tell them apart, you give a trial of phenobarbital. Phenobarbital is a barbiturate, but one of its side effects is to induce production of certain hepatic enzymes, including UDP glycoluronal transferase. If you give phenobarbital to a patient with Crigler-Najjar type 2, it will cause the liver to ramp up production of UDP glycoluronal transferase, and the bilirubin levels will start to come down. But if you give phenobarbital to someone with type 1, nothing happens. So when you see that newborn with high indirect bilirubin and you aren't sure if they have type 1 or type 2 Crigler-Najjar, start them on phenobarbital. If they respond and their bilirubin levels come down and they become more responsive and less lethargic, you know this is type 2. If they don't get any better, you'll know it's type 1. There's another syndrome called Dubin-Johnson syndrome, where the patient can pull the unconjugated bili out of the blood and they can conjugate it just fine. So the problem isn't with glycoluronal transferase at all. Instead, patients with Dubin-Johnson can't excrete the conjugated bilirubin into the bile. There's a defective transport protein that's supposed to transport organic anions. Dubin-Johnson patients end up with an elevated direct bilirubin because the conjugation is normal, but it can't escape. Morphologically, the big clue is that the liver turns black. The liver can't excrete metabolites of epinephrine, like metepinephrine, which are derivatives of tyrosine, which also contributes to the formation of melanin. And these all get trapped into the hepatocytes and polymerize, and these polymers basically act as pigment that turns the hepatocytes black. Dubin-Johnson is a benign condition, and it doesn't require any treatment at all, kind of like Gilbert syndrome, because the hydrophilic conjugated bilirubin doesn't pass through the lipophilic meningeal blood-brain barrier. We don't get deposition into the brain. But remember, D for Dubin-Johnson, D for direct bilirubin, D for dark liver. Finally, there's one more disorder called Rotor syndrome, which is similar to Dubin-Johnson, except it's even more mild, and it doesn't cause a black liver. So it's kind of like Dubin-Johnson light. Now, it's time for the end of session quiz. First question. From which embryonic germ layer is the liver derived? That's endoderm. Next, what 3 structures make up the portal triad? It's a branch of the hepatic artery, a branch of the portal vein, and a bile ductule. And where is the portal triad located relative to the flow of arterial blood and the flow of bile? The portal triads are located at the periphery of the hepatic lobule, so that the arterial blood flows away from the portal triad toward the central vein, and the bile flows toward the portal triad to be collected into the bile ductules. What enzyme is responsible for the conjugation of bilirubin? This is UDP glucuronal transferase. Next, which hereditary hyperbilirubinemia matches each of the following statements? Mildly decreased UDP glycoluronal transferase. That is seen in Gilbert syndrome. Completely absent UDP glycoluronal transferase is Crigler-Najjar type 1. Grossly black liver. You see this in Dupin-Johnson syndrome. Which responds to phenobarbital? This is Crigler-Najjar type 2, and Gilbert syndrome might respond as well. Treatment includes plasmapheresis and phototherapy as a bridge to a liver transplant. That's Crigler-Najjar syndrome type 1. Asymptomatic unless under physical stress. That's Gilbert syndrome. Now, let's run through a couple of rapid-fire facts. Severe hyperbilirubinemia in a neonate. Think about Crigler-Najjar syndrome type 1. And mild, benign hyperbilirubinemia is most frequently Gilbert syndrome. Is it hot up in the hepatic where you're studying yet? Bet you didn't think I'd bring that one up again. All right, thanks for watching. See you next time.
It's time for another warm-up. Let's get going. After undergoing marrow transplantation, a patient develops dermatitis, enteritis, and hepatitis. What is the most likely cause? So this is probably graft versus host disease, where the new immune system that came with the new bone marrow is attacking the host. Lots of different tissues are being affected here. Next, what are 8 examples of encapsulated bacteria? What test can be used to detect encapsulated bacteria? So first, what are the 8 examples? Well, you can use the mnemonic, even some pretty nasty killers have shiny bodies. So E is for E. coli, S is for strep pneumoniae, P is for Pseudomonas aeruginosa, N is for Neisseria meningitis, K is for Klebsiella pneumoniae, H is for Haemophilus influenza, S is for Salmonella typhi. And then the B in bodies is for group B strep. And then what test can be used to detect those encapsulated bacteria? Well, it's the Quelong reaction, which is where you add the antibodies and then the capsule will then see some swelling. All right, that brings us to the end of the warm-up. Let's get to that lecture.
You're back! If you can't guess by looking at my super fashionable and absolutely professional t-shirt, we're going to be talking about the effects of alcohol on the liver, and that will lead us into a discussion of cirrhosis and portal hypertension. Let's go ahead and get started. All right, alcoholic liver disease. There are different degrees of liver damage associated with chronic heavy alcohol use. The first stage, the mildest stage, is steatosis, or fatty liver. This is where you have fat droplets building up in the cytosol of the hepatocytes, kind of pushing all the rest of the cellular contents aside. But that's about it. This is caused by a combination of the effects from the alcohol, including oxidative stress due to ethanol metabolites like acetaldehyde, and ethanol metabolic pathways that result in switching on of fatty acid synthetic enzymes that result in the synthesis of lipids. Now, this isn't really seen with moderate drinking, which is defined as 1 alcoholic drink per day in women and 2 alcoholic drinks per day in men. This is seen in people who surpass moderation, but it is potentially reversible over time if you stop drinking. The next stage is alcoholic hepatitis. This is where you have inflammation of the liver on top of the fatty deposits. Here, the hepatocytes become swollen and necrotic, and you start to see neutrophils infiltrating the liver parenchyma. You can also see these big squiggly twisted rope eosinophilic deposits of cytokeratin in the liver cells. These are called Mallory bodies. They can be seen in lots of different liver pathologies, but they're classically associated with alcoholic liver disease. The presentation is variable with alcoholic hepatitis. There can be asymptomatic hepatic inflammation that surreptitiously burns away the liver until the point of decompensated cirrhosis is reached. And in symptomatic patients, the mild and more common presentation is with right upper quadrant abdominal pain and anorexia, a distended liver border, some jaundice, and maybe some low-grade fever. There's also the possibility of fulminant liver failure that is characterized by coagulopathy, hypoglycemia, increased portal pressures, in addition to the symptoms of mild hepatitis. All patients with alcoholic hepatitis are typically going to have elevated aspartate and alanine aminotransferases, also known as AST and ALT respectively. And with alcoholic liver disease, the AST is usually at least twice as high as the ALT. Now, a lot of students get it mixed up in their heads, which one's supposed to be higher, is it AST or ALT? Well, when you think about alcohol, think a Scotch and tonic, and that spells AST.
So AST is generally higher than ALT in alcoholics with liver disease by a ratio of 2 to 1 or greater. The specific reason for this is twofold. Alcohol depletes ALT relative to AST, which is thought to be due to B6 deficiency, and while ALT is found only in hepatocellular cytoplasm, AST is found in the hepatocyte cytoplasm and the mitochondria. And the mitochondrial poisoning of acetaldehyde preferentially causes spillage of mitochondrial AST into the bloodstream. The last stage of alcoholic liver disease, if alcoholic hepatitis goes on long enough, is progression to cirrhosis, which is the final and relatively irreversible liver damage. You have scarring and fibrosis of the liver, and you've obliterated a lot of the normal architecture and wiped out a lot of the hepatocytes. Here's a gross picture of a cirrhotic liver, characterized by a very nodular surface. If you were to palpate the liver edge on a patient, it would feel hard and nodular. In the earlier alcoholic hepatitis, the liver tends to be enlarged and swollen, but with cirrhosis, the liver is often so scarred down that you can't even feel the liver edge at all. By the same token, with cirrhosis, the AST and ALT may be elevated, or they may be normal, or even low, because you've kind of trashed so many hepatocytes that there aren't really any left to spill AST and ALT. This is a liver biopsy that shows cirrhosis. You've lost a lot of the normal liver architecture, and the lighter pink areas are the more or less normal hepatocytes, but the darker areas are areas of inflammation and fibrosis. All these purple cells are lymphocytes and inflammatory cells. Now this is a trichrome stain of the same liver. With a trichrome stain, the collagen stains blue. So again, the pink areas are these residual nodules of hepatocytes, but a lot of the hepatocytes have undergone necrosis and they've been replaced by collagen and sclerosis and scarring. You can't really make it out here, but the sclerosis tends to localize around the central vein in zone 3 of the hepatic lobule, which you'll remember is the most vulnerable to ischemia, oxidative, and toxic injuries. Now, alcohol is not the only cause of cirrhosis. Many chronic liver diseases can lead to cirrhosis, and regardless of the etiology, there are two broad categories of problems cirrhosis can cause. The first category is metabolic liver failure, where the hepatocytes aren't doing any of the important functions that we talked about before. The second category is problems related to portal hypertension because of all the scarring, which makes it hard for blood from the portal vein to squeeze through the sinusoids, and then the blood starts to back up in the portal system and cause other problems. First, let's talk about metabolic liver failure. So think back to your short list of hepatocyte functions. We've got protein synthesis, metabolism of toxins, energy, vitamin, and mineral storage, and synthesis of bile and excretion of bilirubin. So if the hepatocytes aren't synthesizing proteins, you can have lots of problems. If they don't make coagulation factors, you'll get a coagulopathy, an elevated PT and PTT, and you might see bleeding and bruising. If they don't make albumin, you'll have decreased oncotic pressure, which is what keeps fluid in the vasculature. Remember your Starling forces here. And that fluid will end up diffusing out of the vasculature and into the interstitial space, and you'll end up getting peripheral edema. This is one of the contributors to ascites in cirrhotic liver disease. If they don't make complement and C-reactive proteins, you'll have decreased innate immunity and lose a key component of the non-specific immune system. If the hepatocytes can't metabolize toxins like ammonia, you can get something called hepatic encephalopathy with confusion, delirium, and hypersomnia, and even coma and death. This can also cause something called asterixis, or liver flap, where you have the patient extend the arms and extend the wrists, and the hands end up kind of flapping, because they can't maintain the wrist extension. Another sign of hepatic encephalopathy is fetor hepaticus, which is this nasty, musty odor of the breath. And it's also called the breath of death, which is a fairly evocative, if not a melodramatic term. Now, treatment of hepatic encephalopathy depends on lowering ammonia levels, which can be achieved through the use of lactulose, which draws ammonia into the stool and allows for its elimination via the poop. Gut flora can also contribute to the production of ammonia, so a second-line treatment for refractory hepatic encephalopathy is the antibiotic rifaximin, though this is a very expensive treatment option. We also talked about how the liver is responsible for inactivating steroid hormones like estrogen. Liver failure can lead to elevated estradiol levels, which can cause testicular atrophy and gynecomastia in men. Hyperestrogenism can also cause spider telangiectasias. So these are these little telangiectasias, usually on the chest. There's a little red spot in the center and then tiny vessels radiating out from the center. And they look like legs on the spider, so they call them spider telangiectasias or spider angiomas. High estrogen also causes palmar erythema. So cirrhotic patients can have a redness of the palms of their hands. And finally, if the hepatocytes aren't conjugating and excreting bilirubin, that bilirubin will end up building up in the skin and the eyes, and you'll see scleral and sublingual icterus, and maybe generalized jaundice. One other metabolic function lost in liver failure might be decreased lipids, such as LDL and HDL. So as a physician, you might be tempted to look at the lipid profile and say, wow, your LDL is really nice and low, you're doing great. But it could just be that the liver isn't making any LDL, in which case that's not a good thing, obviously. So be aware of that. So that's metabolic liver failure. Now, what about portal hypertension? We often see portal hypertension with cirrhosis because, again, the hepatic scarring is going to increase pressure in the hepatic sinusoids and cause blood to back up into the portal vein and farther upstream. So when the blood backs up into the liver can become enlarged. We call that hepatomegaly. So the liver might be somewhat shrunken from cirrhosis, or it can be enlarged. Blood can also potentially back up into the spleen and cause splenomegaly. Now, since the spleen is a major red blood cell and platelet filtration system, portal hypertension can result in platelets getting caught up in the spleen, causing what's known as platelet sequestration. So people with liver failure often have thrombocytopenia. When fluid backs up into the liver and the portal vasculature, it may start to weep off the surface of the liver and from the vasculature into the peritoneal cavity, and that can contribute to ascites. So ascites is partly due to portal hypertension and partly due to poor synthetic function and low albumin. How do you treat ascites? Well, you can give diuretics. Potassium-sparing diuretics like spironolactone in combination with furosemide is often effective in medically managing ascites. Alternatively, you can do something called paracentesis, where you actually put a needle and a catheter into the abdominal cavity and drain the fluid. You may be able to imagine that ascites fluid is a terrific medium for bacteria to grow in, and people with cirrhosis also usually have depressed immunity. So ascites creates a risk of something called spontaneous bacterial peritonitis, which can be potentially deadly. Another really big issue with portal hypertension is that as blood backs up into the portal vein and the portal vein pressure starts to rise, other vessels start to dilate to reroute the blood away from the liver and to allow the blood to get back into the systemic circulation and to the heart. These are called portosystemic anastomoses, and we find them in lots of places. For instance, if the vessels of the abdominal wall dilate near the umbilicus, that's called caput medusae because it looks like the head of Medusa. If the rectal veins dilate, we call them anorectal varices, which are a lot like hemorrhoids, although technically they're not hemorrhoids. And if the esophageal veins dilate, they're called esophageal varices. A varix is just a tortuous, dilated blood vessel. You can also see renal varices and paravertebral varices. Really, anywhere there's a potential anastomosis between the portal venous system and the systemic system, you're going to see engorgement of veins. And you should definitely be familiar with these different portosystemic anastomoses. Esophageal varices are particularly problematic when they bleed because this leads to an upper GI bleed with hematemesis and melena. So what can we do to treat bleeding esophageal varices? Well, one drug you can give to reduce splanchnic circulation and stop the bleeding is octreotide, which is an analog of somatostatin. Somatostatin acts to decrease visceral circulation. And you'll remember that somatostatin, as a hormone, is known to broadly decrease GI function. It decreases gastric acid production via histamine and gastrin inhibition, and it decreases insulin and glucagon production, among other inhibitory effects. Another drug you can give to decrease splanchnic vasodilation is propranolol or nadolol. These are beta blockers that are commonly used to prevent variceal bleeding. Ultimately, though, esophageal varices need endoscopic intervention to do rubber banding of the bleeding varices or sclerotherapy of the varix. Patients with persistent difficulties from portal hypertension can benefit from a transjugular intrahepatic portosystemic shunt, also known as a TIPS procedure. That's where you create an artificial channel in the liver going from the portal vein to the systemic venous circulation. Here we relieve portal hypertension basically by allowing blood to bypass the liver. Now, the obvious plus side of hepatic shunting is that you relieve portal hypertension and reduce blood through the varices, which decreases the rate of esophageal bleeds. But the downside of hepatic shunting is that you bypass the detoxifying and metabolically active part of your liver. So you increase the risk of hepatic encephalopathy because you're decreasing the liver's ability to detoxify the blood. So all that ammonia and all those toxins are going to get dumped straight into the systemic circulation, and it just goes right to the brain. So to recap, the various medications that a cirrhosis patient may end up being on include furosemide and spironolactone to treat ascites and edema, a beta blocker like nadolol or propranolol to help prevent bleeding from esophageal varices, vitamin K to maximize clotting potential, lactulose to trap ammonia in the gut so that it gets excreted in the stool to reduce serum ammonia levels, which may help treat hepatic encephalopathy, and finally rifaximin, which can be used to help with the treatment of refractory hepatic encephalopathy. One other quick topic that's related to ascites is the serum ascites albumin gradient, also known as SAG. This is analogous to the Leitz criteria you use to determine exudate versus transidate in pleural effusions in the sense that the serum ascites albumin gradient is something that we use to determine the cause of a patient's ascites. So first you need to measure the serum albumin. That's part of the standard liver panel. And then you measure the albumin in the ascites using a paracentesis. The serum ascites albumin gradient is just the serum albumin minus the ascites albumin. It's not a ratio, so you're not dividing. It's a gradient, so you're just going to subtract them. If the SAG is 1.1 or greater, your body is putting out a transidate instead of an exudative fluid, and this indicates portal hypertension and the modulation of Starling forces, which can be from cirrhosis, heart failure, or Budd-Chiari syndrome. If the SAG is less than 1.1, that means the ascites is not due to portal hypertension, and it's more of an exudate instead of a transidate. So either you have high albumin in the ascites from something like ovarian cancer in the peritoneum, which often causes ascites, or from TB or pancreatitis, or it could mean that you have low serum albumin, like from something like nephrotic syndrome. So that's SAG. One last thing I just want to mention in passing is that cirrhosis is a big risk for the eventual development of hepatocellular carcinoma. It doesn't matter if this cirrhosis is from alcohol abuse or from hepatitis C or hemochromatosis or whatever. There's always an increased risk of liver cancer in cirrhosis. All right, let's do the end of session quiz. First question, what are the signs of portal hypertension? Let's think about your portosystemic anastomoses. You can have ascites, hepatosplenomegaly, esophageal varices, hematemesis and melena from bleeding of the varices, anorectal varices, and caput medusae. An alcoholic patient presents to the ER with upper GI bleed. His transaminases are elevated. Which transaminase, ALT or AST, do you expect to be higher, and by how much? In alcoholics, AST is typically about twice as high as ALT. What cocktail of medications is commonly taken by patients suffering from severe cirrhosis? We mentioned earlier diuretics, potassium-sparing and furosemide, a beta blocker like nadolol or propranolol, vitamin K, and lactulose plus or minus rifaximin to treat hepatic encephalopathy. All right, now let's run through these rapid-fire facts. Triglyceride accumulation in hepatocytes, that's fatty liver disease. Eosinophilic inclusions in the cytoplasm of hepatocytes, those are Mallory bodies, seen in alcoholic liver disease classically. And the type of cancer that's closely linked to cirrhosis, that's hepatocellular carcinoma. All right, that was GI 13. I'll see you next time.
Let's go over the warm-up. First question, to which lymph nodes does each of the following regions drain? The upper rectum drains to the perirectal nodes and then ultimately to the inferior mesenteric nodes. The lower rectum drains to the internal iliac nodes. The external anus below the pectinate line drains to the superficial inguinal nodes. And the testes drain to the para-aortic nodes. Next, what's the function of MacConkey's agar? So MacConkey's agar is used to select out gram-positive bacteria so that only gram-negatives will grow. And it also distinguishes lactose fermenters from non-lactose fermenters. MacConkey's agar contains crystal violet and bile salts which inhibit the growth of gram-positives. And it contains lactose as the only carbohydrate, plus a stain called neutral red. So if these organisms ferment lactose, they're going to take up the neutral red, which means that the lactose fermenters form pink colonies on MacConkey's agar, and the non-lactose fermenters will form white colonies. And the last question, what portion of the eye is opacified in a cataract? It's the lens of the eye. Now let's get started with the lecture.
Oh, you're back for more liver lectures. From me? You must be a glutton for punishment. Better check your liver ultrasound for fatty liver disease. The lecture is on liver pathology. Let's start by talking about liver studies. On your test, you'll be given a bunch of lab functions related to the liver, and you'll be asked to interpret the most likely cause of liver function test abnormality. Now, we've done some introductory information on this when we talked about liver anatomy and physiology and alcoholic hepatitis, but now let's get into more depth about other liver inflammatory diseases. Alright, so the most basic aspect is that cell markers are indicators of cell damage. When a hepatocyte is damaged and the cell bursts open, the contents of that cell spill into the serum, so part of our liver function tests indicate the degree to which liver cells are being damaged. The aminotransferases are what most people think of when we say LFTs. They include aspartate aminotransferase, also known as AST, and alanine aminotransferase, also known as ALT. Now, importantly, AST is not specific to the liver, and it's also present in the skeletal muscles. So one confounder of AST levels is rhabdomyolysis or muscular dystrophy or muscular crush injuries. ALT is more specific to the liver. We can gain some information about the possible pathology by comparing the AST to ALT ratio. AST is found more in the mitochondria of liver cells, and so it's more prone to being spilled with mitochondrial toxins like alcohol. And a commonly thought of ratio is that AST 2 times greater than ALT is an indicator of acute alcoholic liver damage. ALT is more concentrated in the cellular cytoplasm, so if ALT is greater or at least equal to AST, a viral hepatitis is more likely. The next biomarker we see is gamma-glutamyl transpeptidase, also known as GGT. GGT is also elevated with excessive alcohol consumption. So, if you have an AST to ALT ratio of 2 or greater and a normal GGT, chances are that you're being pointed away from alcoholic liver damage towards some other pathology. GGT can also be elevated with diseases affecting the biliary tract. The next biomarker is alkaline phosphatase. Keep in mind that alkaline phosphatase is also found in the bone, so it can be confounded by osseous injuries and high bone turnover diseases like Paget's disease, or even constitutionally elevated in children who are growing. With relation to the liver, alkaline phosphatase is similar to GGT in that it's associated with the biliary obstruction. Biliary obstruction is most commonly due to gallstones, but it can also be caused by cancer or some autoimmune pathologies. We're going to talk about that in a future lecture. All right, now let's take a look at this cut surface of a liver. It looks like the liver is sprinkled with nutmeg, which is why we call it nutmeg liver. So what is nutmeg liver? Well, you can imagine that we're seeing enlarged hepatic venules and peripheral hemosiderin staining in the darker nutmeg speckled areas. Nutmeg liver occurs when there is hepatic congestion. This is commonly caused by right-sided heart failure. Importantly, no matter the cause, if congestion of the liver persists for a long period of time, you can get what's known as central lobular necrosis and fibrosis. If this goes on long enough, you end up getting cirrhosis. And since this is often due to heart failure, we call it cardiac cirrhosis. Now, another cause of hepatic congestion is a disease known as Budd-Chiari syndrome. This is occlusion, usually due to thrombosis, of either the inferior vena cava or the hepatic outflow vein. Now, this may seem simple, but let me just remind you that there are 2 venous systems of the liver. Okay, we've got the hepatic portal vein, which is the confluence of the portal venous system, which brings blood to the liver from the gastric tract, and then we have the hepatic vein, which is the main outflow vein of the liver to the IVC. Budd-Chiari syndrome, like right-sided heart failure, which also backs up blood in the IVC, starts with central lobular congestion and necrosis and can also result in congestive liver disease and fibrosis. Now, the clinical manifestation of Budd-Chiari includes the typical signs of portal hypertension. Though the blockage is of the hepatic vein, or the IVC, the backup of blood ends up resulting in portal congestion and hypertension. So we see hepatomegaly, ascites, abdominal pain, and we can also see esophageal varices, caput medusae, and internal hemorrhoids. We can differentiate between hepatomegaly due to right heart failure versus due to Budd-Chiari by looking for jugular venous distension. If you have congestion of the liver with jugular venous distension, then that's because of right-sided heart failure. But if you have congestion of the liver with no jugular venous distension, then it's probably not because of right-sided heart failure, but something else like Budd-Chiari syndrome. Budd-Chiari is associated with hypercoagulable states, pregnancy, polycythemia, and hepatocellular carcinoma, all of which increase the risk of thrombosis of the hepatic vein. Overall, though, it's pretty rare. It's about 1 case per million people. All right, let's look at another pathology, Reye syndrome. Reye syndrome is a potentially fatal disease, and the buzzword association for this is aspirin in children with respiratory viral illnesses. So, although this can occur rarely in people without aspirin and has even been seen in some adults receiving aspirin with some flavivirus encephalitides like West Nile and dengue, the most common thing you're going to be asked about is aspirin in children. Now, the pathophysiology of Reye's disease is currently unknown, but the main term I want you to remember for Reye syndrome is hepatoencephalopathy, meaning you get pathology of the liver and the brain. Early in the course, patients will have rash, vomiting, headaches, confusion. This then progresses to hypoglycemia, stupor, coma, and death. And if you did a liver biopsy on these patients, you would see fatty liver damage. Some of the encephalopathy that we see is secondary to the disease process itself, but some of it's contributed to by the hyperammonemia, which is also known as hepatic encephalopathy, that occurs with fulminant liver failure. Reye syndrome is thought to be caused from damage to cellular mitochondria, although the pathophysiology, as I said before, is unknown. The aspirin metabolites are thought to decrease beta oxidation by reversible inhibition of mitochondrial enzymes. And again, aspirin is not recommended for children for this specific reason. One notable exception, and one that you should potentially know for step 1, is that you should use aspirin in children with Kawasaki's disease. So remember, Kawasaki's disease is characterized by high fever for 5 or more days, strawberry tongue, conjunctivitis that spares the limbus, palmar erythema, and spotty rash over the face and trunk. These patients should get aspirin. All right, on to Wilson's disease. Wilson's disease is an autosomal recessive disease in which you have inadequate copper excretion into the bile. So the bile is the main mechanism by which we excrete copper. And if you can't get copper into the bile, then you're going to have copper accumulation in the liver and then in multiple other places in the body. In Wilson's disease, there's a defect in a specific enzyme called ATP7B. And that enzyme is responsible for secreting copper into the bile, and it's also important in transporting copper in the serum by adding it to a protein called ceruloplasmin. In general, patients with Wilson's disease have a low serum level of ceruloplasmin, and that can be one of your diagnostic criteria. But again, the main problem is that you're not getting rid of copper. You can't get copper into the bile and then out of your body, which leads to copper accumulation. And that's particularly in the liver, the brain, and the cornea. Another name for Wilson's disease is actually hepatolenticular degeneration, because you get cirrhosis of the liver and damage to the lenticular nucleus of the brain, which consists of the putamen and the globus pallidus nucleus, don't forget that, and these are the places that are typically affected. You also get these corneal deposits known as Kaiser-Fleischer rings. These are golden brown corneal rings around the edge of the eye, and these are indicative of copper deposition. You can also see renal dysfunction in patients with Wilson's disease, specifically Fanconi syndrome. Now remember, Fanconi syndrome is where you have proximal tubular dysfunction in the kidney. Proximal tubule is the first place where you have renal absorption of solutes. So if you have dysfunction in that part of your nephron, the proximal tubule, then you're going to be spilling out all the vital things into your urine. All right, so how do we treat Wilson's disease? Penicillamine, that's the drug to remember. Penicillamine chelates copper and allows for excretion through the urine instead of into the bile. This is pretty easy to remember because it's a copper disorder, and pennies are made of copper, sort of, and you treat this copper disorder with penicillamine. So that's Wilson's disease. All right, on to another metal accumulation disorder, hemochromatosis. This is a disorder of iron hemostasis. So the classic triad in hemochromatosis is cirrhosis, diabetes mellitus, and skin pigmentation. And because of the combination of skin pigmentation and blood sugar derangement, you often hear the term bronze diabetes used in association with this disorder. You also see dilated congestive heart failure with electrocardiographic abnormalities including arrhythmias, and then you'll also see testicular atrophy and impotence in males, and again, like in Wilson's disease, there's an increased risk of hepatocellular carcinoma with the cirrhosis. So there's two major causes of hemochromatosis. The most common cause is an autosomal recessive mutation in the HFE gene, which has effects on the production of a protein known as hepcidin. Now, hepcidin is the major iron uptake protein regulator. Decreased hepcidin from HFE mutation results in increased iron uptake. Hemochromatosis can also be secondary to excessive transfusions. Patients with beta thalassemia or sickle cell disease have chronic anemia that often requires multiple transfusions over a long period of time. So while the red blood cells are being destroyed and then being replenished by transfusion, we are building up huge amounts of iron from the destruction of those red blood cells. So you may be given iron labs and be asked to interpret them. The primary components of iron labs are iron, ferritin, transferrin, and transferrin saturation. So the iron value is indicative of unbound iron. Ferritin is a complex of iron and apoferritin and is the primary intracellular iron storage protein. Transferrin is a protein that allows for transfer of iron in the blood. Total iron binding capacity is how much free transferrin there is. Transferrin saturation is related to how much of the transferrin is bound to iron. So when we look at the iron panel for a patient with hemochromatosis, we see that they're in a state of iron overload. So you'll see increased total iron, decreased total iron binding capacity, and increased transferrin saturation. Ferritin levels are also usually high. All right, so how best to treat hemochromatosis? Well, we can use phlebotomy to discard the iron in the red blood cells. If you take out red blood cells on a regular basis over time, you're going to start losing iron. Now, you can imagine that some of the conditions that would lead to secondary hemochromatosis, the ones that are transfusion dependent, like beta thalassemia and sickle cell anemia, you can't really do phlebotomy with them. So in these patients, we use a chelating agent like deferoxamine. That's the basics of hemochromatosis. All right, so the next liver pathology we're going to talk about is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is an autosomal codominant disease, and it involves two major organ systems, the liver and the lungs. So trypsin, as you might remember, is a proteolytic enzyme produced by the pancreas. Now, alpha-1 antitrypsin is a protein that generally inhibits most proteolytic enzymes that are released from inflammatory cells as a normal part of bodily defense against microbes. Elastase is a particular proteolytic enzyme that is usually inhibited by alpha-1 antitrypsin. Lack of the inhibition of elastase in the lungs results in pan-acinar emphysema. The liver pathology is a little bit more complex. We see the mutant form of alpha-1 antitrypsin polymerizing in the liver cells and becoming toxic. Clinically in alpha-1 antitrypsin, you see early onset, which means younger than 50, pan-acinar emphysema and liver cirrhosis, which might manifest as jaundice and elevated LFTs. The typical situation is a patient who is too young for liver and lung pathology or who doesn't abuse their organs enough to manifest the pathology. All right, let's talk about hepatic adenomas. These are liver tumors that are going to occur most often in females aged 20 to 44, but even then, it's pretty rare. They're associated with combined oral contraceptive use, anabolic steroid use, and also with glycogen storage diseases types 1 and 3. Now, some of these patients have right upper quadrant pain, but it's mainly an asymptomatic disorder, and many times this is just an incidental finding on imaging. Malignant transformation to hepatocellular carcinoma takes place in about 10% of patients. So while the hepatic adenoma in and of itself isn't a big deal, if it becomes hepatocellular carcinoma, that's a big problem. If a patient on an oral contraceptive develops a hepatic adenoma, we typically stop the oral contraceptive and then check serial imaging and alpha-fetoproteins to make sure they're not developing hepatocellular carcinoma. All right, short one, hepatic angiosarcoma. It's a blood vessel tumor in the liver. This is a malignant endothelial neoplasm that occurs in the liver. Risk factors for this are vinyl chloride and arsenic exposure. That's all you need to know for step 1 for this particular disease. The last topic today is hepatocellular carcinoma. This is the most common primary malignant tumor in the liver of adults. there are several pathologies that increase the risk of hepatocellular carcinoma. In general, anything that causes cirrhosis increases the risk of hepatocellular carcinoma over time. So, the chronic hepatiditis, Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency, and alcoholic cirrhosis, those are the most obvious ones. A particular carcinogen buzzword to remember is aflatoxin from Aspergillus fungus in peanut farmers. Now, the symptoms of hepatocellular carcinoma include jaundice, tender hepatomegaly and ascites, and hypoglycemia. You can also see polycythemia that results from elevations of erythropoietin. Now, you can imagine that a malignancy of the liver is likely to cause venous stasis in the liver and is an inherently prothrombotic state, so we need to worry about Budd-Chiari syndrome as well. All patients with cirrhosis or chronic hepatiditis need to have monitoring of alpha-fetoprotein and interval ultrasounds to assess for the development of hepatocellular carcinoma. Okay, let's go on and do the end of session quiz. What is Budd-Chiari syndrome and what conditions are associated with it? Budd-Chiari is occlusion of the IVC or the hepatic veins. It's usually associated with polycythemia vera, pregnancy, hepatocellular carcinoma, or any generally prothrombotic state. Next question. A young man presents with ataxia and tremors. He has brown pigmentation in a ring around the periphery of his corneas. What treatment should he receive? This guy has Wilson's disease, so he should receive penicillamine. What is the underlying problem in Wilson's disease? You'll remember that the underlying problem in Wilson's disease is impaired copper excretion into the bile. Ceruloplasmin, the copper ferrying protein, is usually low, and copper isn't put into the bile for elimination. What are the characteristics of Wilson's disease? Remember that there is copper accumulation resulting in basal ganglia degeneration, resulting in a Parkinsonian-type symptoms, asterixis, cirrhosis, those brown Kaiser-Fleischer rings around the edges of the cornea, personality changes, and dementia. Next question. What is the classic triad of symptoms in hemochromatosis? Remember here, bronze diabetes. So that's diabetes, bronzing of the skin, and cirrhosis. What lab tests are used to diagnose hemochromatosis? We use iron studies. Ferritin is your screening test, and that will be elevated, but you'll also see an elevated transferrin saturation, elevated serum iron, and decreased total iron binding capacity. What is the treatment for hemochromatosis? Phlebotomy primarily, and sometimes deferoxamine. What are the risk factors for the development of hepatocellular carcinoma? Remember, chronic hepatiditis, including hepatitis B and C, hemochromatosis, alpha-1 antitrypsin deficiency, hepatic adenomas, and in general, anything that causes cirrhosis. All right, now on to our rapid fire facts. Hepatomegaly, abdominal pain, ascites, Budd-Chiari syndrome. Green-yellow corneal deposits, Wilson's disease. Those are also known as Kaiser-Fleischer rings. Low ceruloplasmin, that's Wilson's disease. Cirrhosis, diabetes, and hyperpigmentation, think of hemochromatosis. All right, that's all for this lecture. See you next time.
Let's go over the warm-up questions. First question, which three bacteria are obligate intracellular bacteria? The main ones to know are Rickettsia, Coxiella, and Chlamydia. Next, a 20-year-old dancer has decreased plantar flexion and decreased sensation over her posterior proximal lower leg, the lateral margin of her foot, and the plantar surface of her foot. So damage to which nerve is the most likely cause of these findings? Well, this is the tibial nerve. The last one, what substances serve as chemotactic agents for leukocytes? We mentioned IL-8, leukotriene B4, C5a, which is part of the complement system, and kallikrein. Now let's get to the lecture.
Hi everyone, welcome to our Step 1 video on autocorrect teleprompter fail. That's hepatitis. Welcome to our Step 1 video on hepatitis. Hepatitis describes an inflammatory state of the liver. It's most commonly caused by viral infections, but you can also see it in chronic alcohol use or with toxin ingestion. Most of this lecture is going to be about the viral hepatitis, their transmission and significance. Now, some viral hepatitis can make you very acutely sick, but the more chronic ones are often relatively quiescent and result in a slow exhaustion of the liver's regenerative powers. Asymptomatic illnesses, of course, have the problem of being unknowingly transmitted. For this reason, hepatitis B is super pervasive in some communities. When you get sick with acute hepatitis, though, you usually get a typical viral syndrome of malaise, arthralgia, fatigue, nausea, and vomiting, along with very liver-specific symptoms of right upper quadrant pain, jaundice, scleral icterus, and tender hepatomegaly. Now, the most common lab abnormality is going to be elevated aminotransferases like ALT and AST. You'll remember from previous lectures the principle that ALT is found in hepatic cell cytoplasm, while AST is found preferentially in hepatic cell mitochondria. So, in viral hepatitis, usually ALT is equal or greater than AST, while in mitochondrial toxin like acetaldehyde that's found in the metabolism of alcohol, you see a preferential spilling of AST. Your labs may also be significant for elevated total and direct conjugated bilirubin. Alkaline phosphatase may be somewhat increased, although typically highly elevated alkaline phosphatase with elevated ALT and AST is more indicative of a bile duct disorder. So when you do a histopathologic view, you might see what are called Councilman bodies. These are highly eosinophilic cells with somewhat restricted cytoplasm, often surrounded by normal parenchyma that represents dying hepatocytes. You'll recall from our first hepatology lecture that Mallory bodies, which are the eosinophilic inclusions that are made up of damaged and precipitated cytokeratin intermediate filaments, are also seen in liver disease, most commonly in alcoholic liver disease. All right, now that we've gone through the general characteristics of viral hepatitis, let's go into more depth. Let's start at the beginning of the alphabet with hepatitis A. So hepatitis A is a single-stranded, non-enveloped mRNA virus of the genus Hepatovirus and family Picornavirus. You can forget that fact as soon as you're done with step 1. It's transmitted primarily via the fecal-oral route, and the biggest risk factor in the US is international travel in the unvaccinated or those who have waning vaccination status who travel to South and Central America where sanitation standards are less strongly enforced. Hepatitis A very commonly causes an acute hepatitis picture. So you see fatigue, vomiting, fever, jaundice, right upper quadrant pain. Hepatitis A very rarely results in fulminant hepatic failure with significant coagulopathy and ascites. The laboratory diagnosis is made using IgM anti-hepatitis A antibodies. If you see anti-hepatitis A IgG antibodies, typically that indicates resolution of an acute infection or active immunity conferred by vaccination. Treatment is pretty much just supportive care because it's almost always a self-limited disease. The hepatitis A vaccine is available in both inactivated and attenuated forms. The first dose is usually given at 1 year, and then the second dose is given at 2 years of age. All right, now to the end of the hepatitis alphabet, to another symptomatic acute hepatitis, hepatitis E. Hepatitis E is also a single-stranded RNA virus, but the taxonomy is in flux, so don't worry about learning that. Hepatitis E virus is also transmitted by fecal-oral route, just like hepatitis A. Contaminated water supplies are a common source, so while this virus is found worldwide, it's most common in areas that have poor sanitation or water processing. In particular, we see this virus cropping up a lot in Southeast Asia. It causes an acute hepatitis picture, like hepatitis A, but it's more likely to proceed to fulminant hepatic failure when compared to hepatitis A. This virus is particularly lethal in pregnant women. So, if you get a question about a pregnant woman with hepatitis, remember to think first of the fecal-orally transmitted RNA virus hepatitis E. Laboratory diagnosis is made by detection of the virus by PCR in the serum or stool, or by detecting the hepatitis E IgM antibodies. Treatment for hepatitis E is supportive, just like hepatitis A. And while there is a hepatitis E vaccine that's been developed, it's not yet commercially available. Okay, now we're going to move on to the most complicated hepatitis virus, hepatitis B. This one is a double-stranded DNA virus of the orthohepatinovirus genus and of the hepatinovirus family. It's the only DNA virus of the hepatitis group. Very importantly, hepatitis B can be transmitted from mother to fetus. This is also known as vertical transmission. It can also be transmitted through sexual contact and through blood. The most common method of contraction in the United States is through sexual contact. Importantly, there are different disease characteristics depending on the population that is infected with the virus. So infants who have perinatal transmission and children who get the virus are more likely to be asymptomatic, but they're more likely to develop chronic hepatitis B. Adults, on the other hand, are more likely to have symptomatic acute hepatitis from novel hepatitis B infection, but they're more likely to clear the virus and not develop chronic infection. In infected children, roughly 85% develop chronic hepatitis B, and in infected adults, roughly 15% develop chronic hepatitis B. So hepatitis B can also have extrahepatic disease manifestations, and this is thought to be due to circulating immune complexes. This includes polyarteritis nodosa, membranous nephropathy, and aplastic anemia. Chronic hepatitis B infection has a relatively high progression rate to cirrhosis, and it's very carcinogenic. In the developing world, the most common reason for hepatocellular carcinoma and liver cancer in general is chronic hepatitis B infection. Hepatitis B serologies are relatively complex, so let's take some time to look at the virus markers and the body's responses and then talk about how they change based on the stages of infection. So let's first talk about the main markers we test for. Among the hepatitis B antigens, we have surface antigen, also known as S antigen, and envelope, or E antigen. Surface antigen is an indicator of active disease. If surface antigen is positive, the patient has hepatitis B virus in them, whether acutely or chronically. Anytime you see positive surface antigen, you know they are infected and able to infect others with hepatitis B. The envelope, or E antigen, is an indicator of high viral production and indicates greater transmissibility. Now, naturally with these antigens, we also have antibodies. Surface antibody production tells us that the patient has been exposed to surface antigen and has mounted a successful immune response. A positive surface antibody will mean one of two things. Either they have recovery from an active hepatitis B infection, or they were immunized with an activated vaccine. Anti-envelope antibody is inconsequential. They can still be chronically infected and have anti-E antibodies. Now, there is one more antibody called the core antibody, and this is against a protein antigen that's found in the core of the hepatitis B virion. We don't test for core antigen presence, so we don't see a core antigen on a blood test, but the antibody is written. Core antibody helps you to know if the patient was ever infected with hepatitis B or if they ever received the vaccine. The only way you get exposure to the core antibody is if you get infected with the actual virus. So, patients with surface antigen antibody but no core antigen antibody are patients who were vaccinated. There are both core IgM and IgG antibodies. As we expect, IgM will rise early in the disease, and then later in the disease, IgG is produced. Ultimately though, core antibody does not confer resistance or demonstrate clearance of the hepatitis virus. So don't be fooled by a patient with IgG against the core who still has a positive surface antigen. They are still infected. One more lab to add on here is the hepatitis B DNA. Generally, we do this by PCR. Hepatitis B DNA tends to be high during times of high infectivity, when we also expect hepatitis E antigen to be elevated. The most important things to take away from this section are that surface antigen indicates active infection, surface antibody indicates immunity, core antibody differentiates between a person who is immune secondary to immunization versus infection, and E antigen is associated with increased infectivity. All right, so let's go over some scenarios that you might see on your test. A patient from Southeast Asia presents for a routine checkup. You check a hepatitis panel on them and you see the following hepatitis B serology results. Hepatitis B surface antigen positive, hepatitis B surface antibody negative, hepatitis C antibody IgM positive, hepatitis B E antigen positive, and hepatitis E antibody negative. What's going on here? Well, the surface antigen is positive, which means that there is active disease. The surface antibody is negative, and when the surface antibody is negative, then it means you've not recovered from this infection yet. So as long as hepatitis B surface antigen is positive, you can expect that hepatitis B surface antibody will be negative. Next is the hepatitis B core antibody. So remember, core antibody is going to be positive with anyone who is infected with hepatitis B, whether new or old. But what type is it? It's IgM, and it's IgM probably because it's early in the course of infection. So if you have an infectious process and it's still early on, you're going to have IgM core antibody. The E antigen is positive. And what does E antigen mean? It means they're highly infectious. The E antibody is negative, and we might expect that hepatitis B DNA would be high in this situation. All right, let's try another one. Here we see that the surface antibody is negative, the surface antigen is negative, but the core and envelope antibodies are positive. What's going on? This patient is in a special situation known as the window period. The body has managed to suppress and largely clear the surface antigen, which means the infection is on its way to resolving and is now in the process of producing detectable amounts of surface antibody. This patient is likely on his or her way to recovery, and it's very, very unlikely that they're going to develop chronic hepatitis B. The core antibody is still positive in this situation though, and since it's still relatively early in the course, you're going to have an IgM predominance. The hepatitis B DNA could be high or low, so it can vary. The hepatitis E antigen and antibody can also vary. Most of the time though, the hepatitis E antigen will be negative and the E antibody may be positive. All right, next situation. We've got another patient from Southeast Asia on whom you've ordered a hepatitis panel. So you see a negative surface antigen, a positive anti-surface antibody, and a positive anti-core and anti-envelope antibody. What's going on in this patient? Here we see a past infection from which the patient has recovered. Our surface antigen and antibody status tell us that we've developed an immunity, and the core and envelope antibodies tell us that we have had a history of disease. As you would expect, hepatitis B DNA should be 0. The logical next scenario, as I'm sure you've guessed, is the following. Negative surface antigen, positive surface antibody, negative core antibody, negative envelope antibody. So, surface antigen and antibody indicate that we're immune, and a lack of core antibody tells us that this was likely due to vaccination rather than immune response secondary to infection. Hepatitis B DNA, it's going to be absolutely 0. All right, last example. Here we have positive surface antigen, negative surface antibody, positive IgG core antibody, negative E antigen, and positive E antibody. No surface antibody in response to the positive antigen, so we know we have active disease. And our core IgG antibody makes us think that we have a chronic infection. Chronic hepatitis B has 3 different phases we see, so we should talk briefly about each of them. Remember that a small minority of patients who get hepatitis B as an adult will progress to chronic hepatitis B, but a large majority of children and babies who get hepatitis B develop chronic hepatitis B. The phases of chronic hepatitis B infection play into why children are more likely to develop chronic disease. Now, when babies get hepatitis B perinatally, initially there's a high level of hepatitis B virus replication, and the hepatitis B E antigen is super positive, and the hepatitis B surface antigen is positive, and there are high levels of hepatitis B DNA. But even though there's very high viral activity, there's just no evidence of any active liver disease. Patients are not jaundiced, the liver function tests are normal or not very elevated. So this phase is called immune tolerance phase. For some reason, the body is not really reacting to the virus and there's very little damage being done. So the body's tolerating the virus, and that's where the name comes from. This phase can last 10 to up to 30 years. The next phase is called the immune clearance phase. For some reason, the immune system wakes up and starts responding to the chronic, well-seated hepatitis B virus. The E antigen is positive initially. The surface antigen is obviously positive because they have active disease, and there's still active viral replication going on, so there's also positive hepatitis B DNA, and it's generally high. Now that the immune system is woken up, we start to see liver damage taking place, and there's an immune-mediated liver cell death, so we start to see liver function tests rising. Now, the upside of this phase is that the immune system can have some success and suppress viral replication. So we see a downtrending hepatitis B E antigen, which means that the infectivity goes down. Patients in this phase are also more likely to respond to treatment. So if you get a question about the best time to start treatment for chronic hepatitis B, the answer is often in the immune clearance phase. The final phase of chronic hepatitis B is the inactive carrier phase. Here, the patient has normal liver function tests again. The hepatitis B surface antigen is still positive, again, because they're still infected, but the hepatitis B E antigen is negative. This is still considered chronic hepatitis B, but it's quiescent. Reactivations of the hepatitis B viral replication cycle are common and are likely to push us back into the immune clearance stage again. All right, that's all there is to know about the serologic aspects of hepatitis B. Let's go on to what we can do to help treat people with hepatitis B. So the original primary drugs for hepatitis B and hepatitis C were interferon drugs. Interferons have, at best, moderate success, but they made you have flu-like symptoms for the entire duration of treatment. So imagine having 6 months of flu-like symptoms, and you can see why compliance was a really big issue for patients who have a largely asymptomatic disease. Now, however, we're starting to use antivirals, many of which cross over into the treatment plans for HIV. Tenofovir is one of the most commonly used drugs for the treatment of hepatitis B, but others include entecavir, telbivudine, lamivudine, and adefovir. The other topic that tends to get a lot of questions is what to do with a pregnant woman who's testing positive for hepatitis B surface antigen. If the hepatitis B DNA is very elevated and there's active liver involvement, then sometimes the mother will be started on antivirals like lamivudine. But you can also dramatically decrease the vertical transmission by giving the baby the hepatitis B vaccine and hepatitis B immune globulin within 12 hours of birth. All right, now that we've talked about hepatitis B, let's talk about a virus that's dependent on hepatitis B to infect. Hepatitis D is a tiny single-stranded RNA virus that's in the Delta Viridae genus. The D in hepatitis D can stand for many things. It's called the Delta virus. It's also a defective pathogen, but in the right situation, it's most likely to be deadly. Hepatitis D can only infect an individual that's already infected with hepatitis B. There's no way to get hepatitis D by itself. The hepatitis D nucleotides assemble inside a capsid that's made out of hepatitis B parts. The nucleocapsid and surface antigens are actually entirely hepatitis B encoded. Transmission is through blood and sexual secretions. It can be transmitted at the same time as hepatitis B, in which case we call it a co-infection, or it can come later when a patient has chronic hepatitis B infection, and in that case we call it a superinfection. The infection is generally acutely symptomatic and is most likely to cause fulminant hepatitis. The mortality rate of co-infection or superinfection with hepatitis D has the highest mortality rate at 20%. Additionally, hepatitis D co-infection increases the likelihood that hepatitis B will become a chronic infection if you get it in a co-infection state. Treatment is not standardized, but most people are using pegylated interferon alpha for 1 year. For prevention, all you have to do is get the hepatitis B vaccine, because if you don't get hepatitis B, then you can't get hepatitis D. All right, good. Now we're at the last of the hepatitis viruses. Hepatitis C is another single-stranded RNA virus of the genus Hepacivirus and of the family Flaviviridae. The presentation is generally asymptomatic until progression to cirrhosis. Now, hepatitis C is more likely to become chronic than any of our other hepatitis viruses. 50 to 85% of patients will remain chronically infected, and about 5 to 30% of those patients develop cirrhosis. Cirrhosis due to any cause increases the risk of hepatocellular carcinoma. The rate due to hepatitis C is about 1 to 4% per year after establishment of the cirrhotic state. And hepatitis C cirrhosis hepatocellular carcinoma risk is compounded by co-infection with hepatitis B and alcohol use. Patients with cirrhosis should have an ultrasound performed every 6 months. And again, we can see extrahepatic manifestations from hepatitis C, including membranoproliferative glomerulonephritis, essential mixed cryoglobulinemia, lymphoma, thyroiditis, porphyria cutanea tarda, lichen planus, and diabetes mellitus. Transmission is through blood, but it can rarely be passed through sexual contact. New guidelines for testing in patients you suspect have hepatitis C is to do a hepatitis C antibody screen with reflex to the hepatitis C RNA to identify if the patient is chronically infected and to determine viral load. Treatment for hepatitis C can get complex. The old standards were pegylated interferon and ribavirin, but now we're using newer antivirals that have much fewer side effects and have much better cure rates. All right, great. On to autoimmune hepatitis. Autoimmune hepatitis is exactly what it sounds like. It's a disease of the liver that occurs when the body's immune system attacks the cells of the liver. You're going to start to see typical elevations in liver function tests like AST and ALT. When you start to see elevations in LFTs, the very next step is to check for viral hepatitis. In this case, it's going to be negative. Now, as with most autoimmune diseases, including primary biliary cholangitis, autoimmune hepatitis is more likely to affect women. And of course, with one autoimmune disorder, you increase the risk of other autoimmune disorders. Now, there are two important types of autoimmune hepatitis. Type 1 is positive for ANA and/or to anti-smooth muscle antibodies. These patients typically have a more mild presentation and they respond well to immune suppressive therapy. Type 2 autoimmune hepatitis is defined by the presence of antibodies to liver and kidney microsomes and/or to liver cytosol antigen. These patients are more likely to have acute or fulminant hepatitis and they respond poorly to immune suppression. All right, now it's time for the end of session quiz. Pause the video, answer the questions, and then we'll go through the answers together. First question. Identify the hepatitis B status of the following patients based on their hepatitis B serologic markers. The first one is a patient who has recovered from acute hepatitis B infection without becoming chronic. The positive core antibody tells you that the patient has had an infection, not just the vaccine, but because the surface antigen is negative, you know it's not a chronic infection because there's no virus left in the body. The next one, where the only positive is the core antibody, that's an acute infection in the window period. The next one, with positive surface antigen and positive IgM core antibody, that's acute infection. Below that, the one with positive surface antigen and positive IgG core antibody, chronic infection. And the last one, where the only positive is a surface antibody, that's a patient who's been immunized. Next question. Which hepatitis viruses are transmitted through the fecal-oral route? Hepatitis A and E. All right, last question. Which antibodies can be used to help make the diagnosis of autoimmune hepatitis? For type 1 autoimmune hepatitis, we have positive ANA and positive anti-smooth muscle antibody. In type 2 autoimmune hepatitis, we have anti-liver, anti-kidney microsomal antibody and anti-liver cytosol antibodies. Thanks for sticking through it with me. It's time for another warm-up. Let's get going. Which immune deficiency is associated with each of the following findings? So first we have anaphylaxis on exposure to blood products with IgA. This is selective Ig deficiency, so this is a B cell disorder. Next we have coarse facial features, abscesses, eczema. So this presentation is seen with hyper IgE syndrome. So this one is also referred to as Job's syndrome, and this is a T cell disorder. Thrombocytopenic purpura, infections, eczema, so this one is the Wiskott-Aldrich syndrome, which is a B and T cell disorder. Next, we have delayed separation of the umbilicus. So this is leukocyte adhesion deficiency type 1. So this is a phagocyte dysfunction disorder. And then we have neurodefects, partial albinism, recurrent infections. This is a Chidiac-Higashi syndrome, also a phagocyte dysfunction disorder. All right, next question. Bilateral Bell's palsy should raise suspicion for what condition? So you want to think about Lyme disease, also possibly Guillain-Barré syndrome. All right, that's it for the warm-up. Let's get to that lecture.
Coal seems to be a big button issue these days. Coal mines, Old King coal, Coca-Cola, collard greens, Cole's angiitis. What's that? It's cholangitis, not Cole's angiitis. They're not the same root word? Well, how do you think I would know that? Do I look qualified for this? I thought gitis was a weird name. Anyway, thanks for coming back. In our first lecture, we went over the hepatocyte production of bile products and their excretion of conjugated bilirubin. Now we're going to discuss the biliary tract, which is the glorified plumbing system that carries the bile from the liver to the gallbladder and duodenum. Let's start with the basic anatomy. Bile is made in the hepatocytes and is excreted into the bile canaliculi that line the plates of hepatocytes, which lead to the bile ductules of the portal triad, which then converge into larger and larger subducts until they form the left and right hepatic ducts of the left and right lobes of the liver, respectively. Then the left and right hepatic ducts come together to form the common hepatic duct outside the liver, and the bile flows from there into the cystic duct and the gallbladder. The gallbladder stores and concentrates the bile. It acts pretty much as a reservoir of bile and really not much else. As the bile flows down to the duodenum, it will also encounter a branching path that leads to the pancreas. The exocrine pancreas produces large amounts of digestive enzymes that join the bile in the duodenum to, digest. So importantly, removal of the gallbladder or cholecystectomy doesn't prevent you from making bile. It just prevents the storage and timed release of it. The gallbladder remains largely quiescent until it is called upon to perform its heroic duties of squeezing out bile by a chemical messenger. The primary hormone or chemical messenger that causes the release of bile is known as cholecystokinin, or CCK. CCK is released by the eye neuroendocrine cells of the proximal duodenum in response to partially digested proteins and free fats of the digestus. There's another important hormone that comes into play here, secretin. Secretin is released by S neuroendocrine cells primarily in response to the decreased pH of chyme. Rather elegant, isn't it? After proteins have been broken down into their components by hydrochloric acid and pepsid, the digestus passes through the pyloric sphincter into the duodenum along with the acidic digestive media. This stimulates the production of cholecystokinin and secretin. Cholecystokinin results in contraction of the gallbladder and release of bile into the duodenum, while secretin acts on the pancreas to cause release of trypsinogen and chymotrypsin for digestion and bicarbonate to neutralize the acidic medium. So when CCK tells the gallbladder to contract, bile is expelled from the gallbladder back into the cystic duct and then into the common bile duct. The common bile duct is where the cystic duct and the common hepatic duct come together. And then the common bile duct eventually joins the main pancreatic duct so that the bile and pancreatic juice mingle together, and then it all comes through the ampulla of Vater and into the duodenum. We can visualize the bile duct through the ampulla of Vater using a procedure called ERCP, which is endoscopic retrograde cholangiopancreatography, where an endoscope is positioned into the second portion of the duodenum and we inject contrast retrograde through the ampulla of Vater into the common bile duct in order to visualize the lumen of the biliary tract, to look for any evidence of obstruction, whether it's from gallstones, from scarring, stricturing, or tumors. Let's discuss what bile is actually made of. Bile mostly consists of bile acids, but also contains phospholipids, cholesterol, bilirubin, and protein in that order. Great. So what are bile salts? Well, a bile salt is composed of a cation, like sodium, plus a bile acid. Okay, so what are bile acids? Bile acids are always synthesized from cholesterol, and basically what you get when you oxidize or add hydroxyl groups to cholesterol. So the liver takes perfectly good cholesterol molecules and oxidizes them through a cytochrome P450 enzyme pathway, which are concentrated in zone 3 of the hepatic nodule. This forms cholic acid, which is a newly synthesized or primary bile acid, and other derivatives. And these bile acids and bile salts, which contain remnants of hydrophobic moieties of cholesterol, but now have a polar acidic region, act as a detergent and are what allow bile to emulsify lipid particles in the gut so that we can absorb dietary fats. Now, most of these bile acids are conjugated eventually to either taurine or glycine moieties. Taurine is an organic acid, kind of like an amino acid. If you conjugate the bile acid to taurine, that makes taurocholic acid, and if you conjugate it to glycine, it makes glycocholic acid. So again, you take cholesterol, you turn it into a bile acid, most commonly cholic acid, and then you conjugate it further with glycine or taurine, and then you join that bile acid with a cation like sodium or potassium to make a bile salt. But that's not all. In your bile, you also have bilirubin. We talked about that in the video on liver basics. So to review, the bilirubin in bile is derived from heme molecule breakdown from red blood cells and has to be conjugated to a glucouronyl group to become soluble before it is excreted into the bile. And then bile also contains unoxidized cholesterol and phospholipids. We've already discussed the functions of bile over the course of the last few lectures. Bile is important for digesting and absorbing lipids. It's important for excreting cholesterol and bilirubin. Bile is important for copper excretion and in fact is one of the body's only mechanisms to excrete copper. Bile also has some antimicrobial bactericidal activity, and it may help kill bacteria that we ingest with food. Let's focus our attention again on bilirubin for just a moment to complete topics from our previous lectures. Again, bilirubin comes from the breakdown of hemoglobin when red cells reach their expiry date. Initially insoluble, unconjugated bilirubin gets bound to albumin for shuttling through the blood and is carried to the liver where it is conjugated and excreted into the bile. From there, conjugated bilirubin in the bile goes into the duodenum and the small intestine and eventually to the colon. In the colon, gut bacteria start to convert that bilirubin into urobilinogen. Most of that urobilinogen is going to stay in the colon and get oxidized to something called stercobilin, and then will be excreted in the stool. Sterco comes from the Latin word for feces, and stercobilin is what gives feces its characteristic brown color, like a poop emoji. But then a relatively small amount of the urobilinogen that is made in the colon is reabsorbed by the gut, and it enters the mesenteric veins and goes back to the liver along with the bile salts and goes back into the bile. We call this, importantly, enterohepatic circulation, and it allows for important recycling of bile acids to reduce the metabolic demands of digestion. A tiny amount of reabsorbed urobilinogen isn't captured by the liver and ends up in the kidneys, where it is converted to urobilin and excreted in the urine, and this is what makes urine its characteristic yellow color. Now we're going to talk about jaundice and hyperbilirubinemia a little bit. We've talked about this previously when we talked about physiologic jaundice in newborns, and we also talked about disorders of UDP glucouronyl transferase, like Gilbert syndrome and Crigler-Najjar syndrome. But there are tons of other disorders that can cause hyperbilirubinemia. First, we're going to look at some more diseases that cause high unconjugated bilirubin, and then we're going to look at diseases of conjugated bilirubin. There are three big categories of diseases that cause unconjugated hyperbilirubinemia. Diseases of increased bilirubin production, diseases of impaired bilirubin uptake and storage, and diseases of decreased enzyme activity by uridine phosphate glucouronyl transferase activity. So what would cause that increased bilirubin production? It should be anything that causes increased red blood cell breakdown or processing of red blood cell waste. In this situation, we need to overwhelm the liver's capacity to conjugate using the UDP-GT system, and the excess remains as unconjugated bilirubin. Consider hemolytic anemia. This is usually an intravascular process. You're breaking down many red blood cells, so you have more heme to process, and that yields much more bilirubin. In the same vein, we have red blood cell dysmorphias like spherocytosis and sickle cell anemia. Here we have an extravascular hemolytic process. We'll talk about these more in hematology, but blood cell dysmorphias cause increased red cell turnover primarily because of increased splenic clearance. More red blood cells broken down equals more bilirubin produced. Another consideration is hematoma breakdown. Some infants, especially vacuum-delivered infants, have a cephalohematoma, a big collection of blood under the scalp. Given a neonate's already reduced UDP-GT enzyme activity and functionality, it doesn't take much time to overwhelm the system and make more unconjugated bilirubin. The next big group for unconjugated hyperbilirubinemia is impaired bilirubin uptake and storage. The first one here is viral hepatitis. Following viral hepatitis, the liver just isn't taking care of business with bilirubin like it ought to be. So it's taking up less unconjugated bilirubin to conjugate, but the bilirubin that is conjugating isn't excreted into the bile, so you end up with conjugated and unconjugated hyperbilirubinemia. And then the second bullet is drugs. Certain drugs like rifampin can impair the uptake and storage of bilirubin, resulting in increased bilirubin. Then our last group of disorders are the diseases where you have decreased UDP-GT enzyme activity. We talked about this in the first lecture of the series. We saw this with Gilbert syndrome, with Crigler-Najjar syndromes type 1 and 2, and also with neonatal physiologic jaundice. Then what kinds of things cause high levels of conjugated bilirubin? You can have impaired transport of bilirubin where the hepatocytes can conjugate the bilirubin, but they just can't excrete it. From our first lecture, we remember Dubin-Johnson syndrome and also Roeder syndrome. The next group are diseases that do not originate in the biliary system but cause biliary epithelial damage. This can be seen with various types of hepatitis, as we've said before. Viral hepatitis causes both conjugated and unconjugated hyperbilirubinemia. The other obvious one is cirrhosis. Fibrosis of the liver from chronic inflammation will end up damaging the coexisting biliary epithelial system and its ability to excrete bilirubin and bile. The next cause of direct hyperbilirubinemia is intrahepatic biliary obstruction, where you have obstruction of the bile ducts inside the liver itself, such as with primary biliary cholangitis and primary sclerosing cholangitis. We're going to talk about both of those in a second. And certain drugs, such as chlorpromazine and estrogen, can cause this as well. You can also have extrahepatic biliary obstruction, either from pregnancy, pancreatic neoplasms in the head of the pancreas, pancreatitis, cholelithiasis, cholangiocarcinoma, which is a cancer of the bile ducts, choledocholithiasis, which are gallstones that are impacted or blocking the bile ducts. We'll talk about that shortly too. And finally, biliary strictures or narrowed areas of the bile duct as seen in primary sclerosing cholangitis. Now clinically, how could you distinguish between an intrahepatic biliary obstruction and an extrahepatic biliary obstruction? Say, in a patient who shows up in the emergency room with jaundice. You could do a right upper quadrant ultrasound. An ultrasound should be able to tell you if there is an extrahepatic cause of the biliary obstruction, as in this case, patients would have dilated intrahepatic bile ducts. Primary sclerosing cholangitis. Let's talk about some details of these diseases of the biliary tract. Start with primary sclerosing cholangitis, or PSC. PSC is a disease where you have concentric fibrosis of the intrahepatic and extrahepatic bile ducts. It's obvious in the way it's named. Primary indicates that it occurs without an etiologic insult. Sclerosing means hardening or narrowing, which is what happens as the fibrosis invades the bile ducts themselves of the liver. The pathophysiology is unknown at this time. When you do an ERCP or an endoscopic retrograde cholangiopancreatography on this patient, instead of the biliary tree having a nice, smooth, regular lumen, you see very irregular areas of stricturing and narrowing and areas of dilation that look like beads. This is often described as beads on a string appearance. So when you see that or you hear beads on a string, think about primary sclerosing cholangitis or PSC. There are a couple of other characteristics that can help lead you to the diagnosis of PSC. PSC is most commonly seen in men around the age of 40. Up to 80% of these patients have a positive P-ANCA, which is an anti-neutrophil cytoplasmic antibody, and it is associated with ulcerative colitis, leading some to believe there is a component of autoimmune disease, although this is currently not proven. And since it's an inflammatory disorder of the bowel tract, it increases the risk of cholangiocarcinoma. Next, let's talk about primary biliary cholangitis, or PBC. This was also previously referred to as primary biliary cirrhosis. It's a totally different disease, although the presentation and the name and the abbreviation are just similar enough to PSC to cause some confusion. As mentioned, this used to be called primary biliary cirrhosis, but the newer preferred name is primary biliary cholangitis. You might see either name or both names on your exam. PBC is an autoimmune disease where you have T lymphocytes infiltrating in the liver that subsequently attack the small bile ductules within the liver parenchyma. This causes granuloma formation seen on liver biopsy very commonly. Eventually, PBC can cause cirrhosis, but cirrhosis does not occur in all patients and is only a late manifestation of PBC, which is a big reason that they changed the name, because you can have early stage biliary cholangitis without evidence of cirrhosis and fibrosis of the liver tissue or parenchyma. The demographics of PBC are quite different from PSC. 90% of patients are middle-aged women. Another distinguishing feature is that 95% of these individuals with primary biliary cholangitis are positive for anti-mitochondrial antibody, or AMA. It's important for your test to remember antibodies associated with these two important liver conditions. Anti-mitochondrial antibody for primary biliary cholangitis and anti-neutrophilic cytoplasmic antibody, or P-ANCA, for primary sclerosing cholangitis. And also importantly, PBC can be associated with many other immune disorders, most commonly Sjogren's syndrome, but also CREST and other types of scleroderma and rheumatologic conditions such as rheumatoid arthritis. There is one drug that is mainly used to treat primary biliary cholangitis, ursodiol, or ursodeoxycholic acid, which is a bile acid that has hydrophilic properties. Ursodiol is a naturally occurring bile acid that was originally isolated from bear bile that decreases synthesis of cholesterol in the liver and changes the composition of bile. And in PBC, ursodiol is thought to delay progression of PBC and improve survival, though there is a meta-analysis that shows there's really not much improvement in mortality or symptomatology. Together with ursodiol, there's one other drug that is FDA approved for the treatment of PBC. The second drug is called obeticholic acid, which is also a bile acid. This was just FDA approved approximately 2 to 3 years ago. It's used in combination with ursodiol. Because of its recent FDA approval, it may or may not be on your test. The definitive treatment for both PSC and PBC is liver transplant, but only when patients progress to cirrhosis and develop complications of cirrhosis. Now that we've talked about the primary contributors to biliary cirrhosis, PBC and PSC, let's talk about the secondary causes of cirrhosis. Secondary biliary cirrhosis means there is biliary obstruction secondary to some other process, specifically and most commonly an extrahepatic process that's blocking biliary outflow, sometimes due to pregnancy, neoplasm, gallstones, biliary stricture, or pancreatitis. Any of these things could block the extrahepatic biliary tree, and the pressure that builds up into the intrahepatic ducts slowly over time leads to bile stasis and ascending cholangitis with eventual fibrosis, and cirrhosis. All of these diseases will cause direct hyperbilirubinemia and cause resultant darkening of the skin and jaundice, pruritus, dark urine because of conversion of direct bilirubin to urobilinogen, and light-colored or acholic stools because that bilirubin isn't making it into the stool, and there are lower levels of stercobilin. On the labs, all of these diseases can cause elevated alkaline phosphatase because alkaline phosphatase tends to be elevated whenever there's cholestasis or stasis of bile, which results in canalicular injury, and the bile canaliculi is the source of the elevated alkaline phosphatase within the liver. Let's talk in more detail about extrahepatic biliary obstruction such as gallstones or cholelithiasis. First, we should clear up some aspects of naming and vocabulary to improve understanding. There's cholelithiasis. Lith is stone, so cholelithiasis is a gallstone. There's cholecystitis. We said the cholecyst is the gallbladder, and itis is inflammation or infection, so this is inflammation and or infection of the gallbladder. And classically, this is inflammation of the gallbladder due to infection, just like sinusitis, bronchitis, and meningitis are typically caused by infections. We've already mentioned cholangitis, which is inflammation or infection of the biliary tree, and choledocholithiasis is gallstones that are stuck in the bile ducts. So make sure that you understand these terms. Let's talk about gallstones. In the U.S., more than 10% of people over the age of 50 have gallstones, and most of these people are completely asymptomatic. The classic risk factors for gallstones are the 4 F's: fat, fertile, females, and 40. Fat means obesity because dysregulation of the bile acid to cholesterol to bilirubin ratio increases the likelihood of gallstone formation. Fertile because pregnancy increases the risk of gallstones, and the more times you're pregnant, the higher the risk. Oral estrogens and oral contraceptive pills are associated with a slightly increased risk of gallstones as well. Women have more gallstones than men, and a vague notion that most people who get gallstones are over the age of 40. There are also several different types of gallstones. There are stones that are composed primarily of cholesterol. There are pigment stones composed primarily of bilirubin and bile pigments. But most gallstones are what we call mixed stones, meaning they have a mix of cholesterol and pigment. Gallstones form in the lumen of the gallbladder when cholesterol and bilirubin precipitate out of the bile within the lumen. This can be due to stasis, but is thought to be more strongly contributed to by an imbalance of the bile acid cholesterol bilirubin ratio. But as long as the stones stay in the gallbladder, they are not a problem. Gallstones mostly cause problems when they come out of the gallbladder and obstruct the cystic duct or biliary tree. Biliary colic is a condition in which you get right upper quadrant pain because a stone temporarily obstructs either the cystic duct, most commonly, or less commonly, the common bile duct. If a stone is obstructing the biliary tract, you'll get pain when you eat because CCK release stimulates gallbladder contractions, and that increases the pressure in an obstructed, closed biliary system. And this can cause pain, classically in association with eating fatty foods. That's biliary colic, right upper quadrant pain due to gallbladder contraction with eating. And that in and of itself is an indication to remove the gallbladder, though it's not an emergent indication. Gallstones can also cause something called pneumobilia, which is where you get air in the biliary tree because a fistula forms between the gallbladder and the small intestine. And a gallstone ileus occurs when an exceptionally large gallstone goes from the gallbladder into the GI tract and causes intermittent obstruction, most often in the distal, most narrow part of the small intestine or the ileum. It's not very common, but it does happen. The diagnosis of gallstones is primarily with right upper quadrant ultrasound. Here you see an ultrasound, and you can see a big oblong black area. That is the lumen of the gallbladder. And then these white hyperlucent areas with shattering are gallstones. They're free-floating, so they've sort of settled to the most dependent part of the gallbladder. Another way to determine if a patient is having biliary colic is to do a HIDUS scan, which is a radionucleotide scan of the biliary tree. You inject a radio-labeled substance called HIDA into the patient, and the HIDA gets taken up by hepatocytes and excreted into the bile so that you can visualize the gallbladder and biliary tree. An inability to visualize the gallbladder with this test indicates obstruction of the cystic duct and thus acute or chronic cholecystitis. This is a HIDA scan from a 35-year-old woman with Crohn's disease who is having abdominal pain. So they injected the HIDA and they scanned her at 15 minutes, and you can kind of make out the outline of the liver because the hepatocytes are initially taking up the HIDA, and this dark spot is the gallbladder where all that HIDA is being dumped into the bile and being stored and concentrated in the gallbladder. Then they scanned her again at 30 minutes, and here there's less HIDA in the liver and more in the gallbladder, and you also start to see some of it coming out of the gallbladder and into the duodenum. Then at 45 minutes, there's more in the small bowel and very little in the liver at this point. And then at 60 minutes, they give a shot of CCK, which, as you know, causes the gallbladder to contract, and they measure the amount of HIDA that is injected into the small bowel at that point to give us a number called a gallbladder ejection fraction, which is a measure of gallbladder health or function. So this is a normal HIDA scan because the cystic duct is not obstructed, and a normal amount of HIDA is ejected from the gallbladder into the duodenum. Another major complication you can get from gallstones is cholecystitis. And I want you to make sure you keep cholecystitis separate from biliary colic, and the next thing we're going to talk about, cholangitis. Very different topics. Cholecystitis is an infection and inflammation of the gallbladder. The classic physical exam finding in cholecystitis is a positive Murphy sign. This is where you put your hand underneath the patient's rib cage on the right upper side and press up into the gallbladder fossa, and when the patient inhales deeply, it hurts so much that they cut that deep inspiratory breath short. What we're doing here is causing further impingement on an inflamed organ. You have pressure from your hand on one side and pressure from a diaphragmatic excursion on the other side. If the patient can't take a full inspiratory breath, then we have a positive Murphy sign. Cholecystitis is most commonly due to gallstones, but rarely it can be due to ischemia or viral infections like CMV or cytomegalovirus. This is referred to as acalculous cholecystitis or gallbladder inflammation without stones. Importantly, we need to remember that biliary colic is intermittent pain that occurs with eating and is secondary to intermittent obstruction of the cystic duct during gallbladder contraction. The patient does not have an infection and should not have acute gallbladder wall thickening. Cholecystitis, on the other hand, is a clinically infected state, usually because of gallstone obstruction of the fossa on a continuous basis with bacterial overgrowth. These patients will be febrile, can have an elevated white blood cell count, and elevated bilirubin labs, and possibly elevated alkaline phosphatase. On ultrasound or CT scan, you will see thickening of the gallbladder wall, pericholecystic fluid, and fat stranding in the gallbladder fossa in severe cases. The treatment of cholecystitis is to first give antibiotics, usually intravenously, to cool off the infection and then remove the gallbladder several days later. Okay, let's talk about cholangitis, which is inflammation or infection of the biliary tree. This is also most commonly caused by gallstone migration into the biliary tree, also known as choledocholithiasis. The stone usually gets lodged in place, and any bacteria that are trapped proximal or behind this stone are going to have a chance to start multiplying and making pus, and that's what cholangitis is. Treatment of cholangitis is ERCP with removal of the stone and pus and then a cholecystectomy, or a cholecystectomy with intraoperative cholangiogram. That's visualization of the biliary tree through contrast injection in an antegrade fashion directly into the cystic duct and common bile duct to assess for any further obstruction or stones. The hallmark symptoms of cholangitis are important and are known as Charcot's triad of cholangitis, which is composed of jaundice, usually much worse than in cholecystitis, fever, and right upper quadrant pain. There's also something called Reynolds pentad. Reynolds pentad is Charcot's triad of jaundice, fever, and right upper quadrant pain, plus 2 other signs. It's a pentad, and pentad means 5, just like triad means 3. So Reynolds pentad is Charcot's triad, plus more severe symptoms, including hypotension, which is indicative of septic shock, and altered mental status. And remember, this is Charcot's triad of cholangitis. There's also a Charcot's triad of multiple sclerosis. What's that triad? Tremor, nystagmus, and scanning speech. All right, guys, you made it through the new material. Let's do a quick end of session review and wrap up our lecture. First question. What is the fate of bilirubin after it is conjugated and secreted into the GI tract? The bacteria in the colon convert it to urobilinogen, and most of that is excreted in the stool as stercobilin. A little bit is reabsorbed and recycled into the bile via the intrahepatic circulation, and then a small amount is excreted in the urine as urobilin. Next, what are some of the intrahepatic and extrahepatic causes of biliary obstruction? The intrahepatic causes are primary biliary cholangitis, primary sclerosing cholangitis, and drugs such as chlorpromazine and arsenic. And for the extrahepatic obstruction, you have pancreatic neoplasms, primary sclerosing cholangitis. Remember, this gives both intra and extrahepatic biliary obstruction, pancreatitis, choledocholithiasis, cholangiocarcinoma, or cancer of the bile ducts, and benign biliary strictures. What is the difference between primary biliary cholangitis and primary sclerosing cholangitis? PBC has a positive antimitochondrial antibody. It's usually seen in middle-aged women, and it's an autoimmune disease and is commonly associated with other autoimmune diseases, including Sjogren's syndrome or Crest syndrome. PSC is associated with positive P-ANCA. It's primarily seen in men over 40, and it's associated with ulcerative colitis and cholangiocarcinoma. And there's the characteristic beads on a string, intrahepatically and extrahepatically dilated bile ducts on ERCP. Last one. What are some of the risk factors for the development of cholesterol gallstone? It's the 4 F's: fat, fertile, females, over 40. That's the end of this session quiz. Thanks for joining me.